Good morning, Hans Lokale, General Surgeon, Moroto Regional Referral.
Good morning. Twice Gamukama is my name. I am the surgeon, Kabale Regional Referral Hospital and Kabale University. I'm also a plastic and reconstructive resident who is in his final year. Thank you.
Good morning. I'm Kwikiri Zarona, fourth year medical student, Kabale University.
Good morning, everyone. My name is James Ampumuza. I'm a fifth year medical student, Kabale University.
Good morning, everyone. I'm Dr. Ampire Daffin. I work at GCZ Hospital, and I'm alumni Kabale University and founding member of Kabale Surgical Society. Thank you.
Good morning. I'm called Nick Arthur Jonathan, General Surgery Resident, Kabale University.
I'm Anne Shikanda Wesonga, Pediatric Surgeon, Mulago.
Morning, everyone. I'm Reverend Sister, Professor Ajiko Mary Margaret, General Surgeon, Soroti Regional Referral Hospital.
Hi, Joseph Epodoya, my name's Senior Consultant Surgeon and Urologist, and also President-elect, Association of Urologists of Uganda. Thank you.
Yes, good morning. My name is Dr. Tommy Obduvire, resident surgeon based at Mbale Regional Referral Hospital.
Hello, I'm Dr. Justine. I'm a visiting surgeon from the US working in Mbale.
Hello, I'm Dr. Fred Maiso, general surgery resident in Mbale Hospital. Thank you.
Hey, good morning to everyone. I am Dr. Brenda Namuga, a general surgery resident in Mbale.
Good morning. I'm Dr. Luede Aliva Flavia Ojok. I'm a general surgeon from Soroti University.
Good morning. My name is Dr. Natalie Muhia, plastic surgery resident.
Good morning. My name is Ezati Daffin, plastic surgery resident.
So right now we are going to dive into our first session. I want to call Dr. Anne Shikanda, who is a pediatric surgeon at Mulago National Specialized Hospital, to take on the session. Thank you.
Good morning, everyone, once again. You are all welcome to this session. It's a session 3. It's about capacity building and quality improvement. Maybe before we start, one thing I've just noted is, according to the introduction, we are lacking. We are not blended. We don't have orthopedic surgeons. I think ENT surgeons, we only have one. So Association of Surgeons should encompass all surgeons, all surgical specialties, and I think it's our role to try and be inclusive and include all the surgical specialties. I think we should aim at that. So call up your friends to come. So session 3 is about capacity building and quality improvement. And we are going to have our first presentation from Dr. Gamukaba Richard. He's going to talk to us about success of the 5R quality improvement project on the surgical ward, enhancing patients' outcomes and efficiency in Mbale Regional Referral Hospital. Dr. Richard Gamubaka, the floor is yours.
Protocol observed. Good morning, colleagues and friends. Madam Moderator, I'm requesting that I call one of my colleague friend we have been doing this quality improvement with. He's not going, okay, will be one of the people to take up, to condense some of the questions that will be coming. Dr. Maiso, please, you are welcome. Can take a seat. Yeah, Dr. Richard Gambaka is my name. Those are our credentials. So we are looking at 5R to rescue our surgical patients in Mbale Regional Referral Hospital. So these are some of the acknowledgements that we are having. Dr. Fred, please. You are welcome. These are some of our acknowledgements. Mbale Regional Referral Hospital, community, and then administration. Of course, with special thanks to Dr. Adam. I can see some of our mentors around. Dr. Fred Bissot is around. I think he's there. Dr. Justin, the rest of the team members, Dr. Boo, I think he has not yet come, but special thanks to them. Why we started this quality improvement in surgical department, I think so many people and everyone is talking about mortality, but mortality after surgery is 2 times higher than the global average, despite the healthy, in a healthy patient like me, after surgery, my mortality rate is very higher, 2 times. Fred, you can take up a seat. Yeah, so over the last 8 years, improvement in the surgical department of Mbale Regional Referral Hospital, we have seen a trend of success where we have had a lot of, we had the surgical high dependence unit, which was opened. It was a donation. Some friends of ours from UK donated to us surgical high dependence unit. Of course, we have increased specialties in the region. Surgical specialties, anesthesia, and of course the COSEXA training. And we are saying mortality after laparotomy from 22.4 in 2017 to 11 in March 2024. But still, we are seeing a lot of our patients passing on after surgery. Reason being, they deteriorate and pass on. I think it is a common thing, a common saying in surgical department. In the morning, on the morning rounds, after a surgeon has done a very good surgery, thyroidectomy, and when the surgeon asks the sister on duty what happened to the patient, they say, no, doctor, the patient deteriorated and died. That is a common thing and has been always. So, now our activity, QI project in surgical department, we initiated it using the 5R. So our aim was to reduce post-op deaths within the 12 months. And we started the project in 2023. And for those 12 months, we had a lot of success in our management of patients. And the 5R are, we have been having risk assessment of patients using the ASO score calculator. Everyone, I think, is well conversant with the ASO calculator. Recognition, responding, reassess, and then reflection. But the changes in 5R has led to a lot of changes in our surgical department in terms of quality improvement of the care we give our patients, and then also the department at a whole. Yeah, so this is the ASOS calculator. I think many of us are covered with it, where it talks about the age, and then we have the ASA, American Association of Anesthesiologists, which assesses the physiological status of the patient, and then the surgery, the timing, the severity, and then the indicator. So on my right, I think that is your right, a patient that scores greater than 10 is at high risk of dying after surgery compared to the one who scores less than 10. And as you see the percentage there, greater than 19, you are at around 26.4% of dying after surgery, compared to somebody who has scored 3. So all patients who undergo surgery in Mbale Regional Referral Hospital are scored, even if it is a simple surgery, like people keep on saying. Yeah, so high risk versus low risk. So what happens? In the beginning, I told you that we had an introduction of our high dependence units. We have one bed for ICU. One bed can be turned into ICU in the surgical department. This picture portrays the ward. We have a number of patients, quite a number of patients. So most times our HDU is full. So what happens? Most of the patients who score 10 and above are admitted on the ward. We have gazetted beds. Those the red tags you are seeing on patients' bed, they have critical patients. So these beds are near the nursing station. So all those patients, when our high dependence unit is full, we admit them on those beds, both male and female. And this is the second R of recognition. This is a very simple tool where we are looking at pulse rate, saturation, blood pressure. Actually, we are not introducing something new, but we are just building on what we already know, what we have learned from school, to see that we improve on our patients' outcome. So even pain score, and we are saying, we have the color codings as you are seeing. The patients who is in yellow, red, and above, those ones are at high risk of developing complications. So it gives us a red flag. Supposing you are looking at oxygen saturation and the patient is using the pulse oximeter, is peaking less than 90, that patient is, of course, is deteriorating after surgery. So the nurse on duty, the medical officer on duty, the intern on duty, and the surgeon who did the surgery, and also the surgeon who is covering that week, everyone should be in the know of what is happening in this patient using this news observation chart. This is a news observation chart. It's a tool which is common to everyone, but of course we are running away from it. We are looking at some new things. So we are saying, let us go back to our originality of management of patients. So look at this. This is the data of one of our nurses before we started the quality improvement project. A 90 nurse just wrote in the patient's book compared to our news observation chart. So when you go on the ward round as a consultant or as a surgeon, and you look at these two, you are comparing, which one is easier for you to read to understand the physiology of the patient. The other one is very difficult to understand and internalize what is happening to the patient. But the other side on my right, I think is on your left, yeah, it's very easy. You can just look at how they have plotted and then joined the lines that the patient's condition is either improving or deteriorating, and it's easier to call for help. Yeah, so the 3 and 4 R's, response and reassess. You see the staff feels confident after we have had these severe, multiple trainings for them on how to take, of course we keep on re-echoing on how to take BPs, how to interpret, because there is a difference between taking and noting and then interpreting. Yeah, so this one calls for, if the patient is deteriorating, everyone who is concerned about that patient is in the know of what is happening to a patient. And this one calls for a trigger of intervention. Say, for example, BPs are dropping down, and the patient is, after, say, abdominal surgery, what do you do as a nurse? 2 large bore cannulas, probably maybe the patient is hemolyzing in 2 large bore cannulas, blood picked for grouping and cross-matching, you are resuscitating, you connect on fluids, then you inform the team that did the surgery, and then the surgeon also, who is on duty, should be in the know, so that as early as possible, we pick this patient, and then probably if there is need for taking the patient back to theater, he is saved from that. Yeah, of course, we are looking at time communication, where we have WhatsApp groups, sometimes direct calling, sometimes by, of course, email will take long, but WhatsApp and direct calling is what we have always been using. Yeah, this is a communication board where we have, in the morning, we always have huddles. The intern who was on duty that night always updates the communication board of high-risk patients, and then the patient may not be high risk, but also he has something. Maybe the BPs dropped down a bit, and he was resuscitated. He was also put on the communication board. So in the morning, these huddles are done everywhere, but of course we have run away from our roots. So what we are trying to say that let us wake up and still go back to our roots. Morning huddles, knowing that the patients so-and-so bed number 2, 3, 4, 5, those are patients of high risk, and those are the patients we start with reviewing, then we continue with the rest of the patients. Yeah, so of course here we are looking at effective resuscitation of a patient who deteriorated. Then afterwards, you see one of our nurses very happy after reassessing the patient. Of course, if the BPs have dropped down, you have done what you were supposed to do, rescuing the patient. You keep on reassessing to see whether the BPs are still dropping or whatever you have done is not, the patient is not responding to it. Then the number 5 is reflection. These reflections have done a lot of very good work and improvement in our surgical department, and has brought the surgical team together. So regular team reviews of rescued patients and then failed patients. Sometimes you can start in your protocol for resuscitation or for rescuing patients, but of course we are not the custodians of life. God takes the patient, and then we review our patient. Our files of what happened to the patient. Biweekly interpersonal mortality and then morbidity, and then the quality improvement data review. Actually, this one has given us a very good way of reviewing our surgical patients' data. I'm going to show you. Then we also have CMEs done during that time. I can see the gentleman in front there is Dr. Mwonge, one of the quality improvement cast, I think, at SODIA and at Ministry of Health, and then the whole surgical team. Yeah, these are some of the questions we ask ourselves during those quality reviews. Do we accurately identify our high-risk patients? Do we admit them on the correct ward? Then completeness of the vitals. So during those meetings that we always have bi-weekly meetings, You can see the first graph. Do we accurately identify our high-risk patient? Where we started from, and we had some hiccups, but currently we are at 100%. Of course, not all. We keep on having new interns, new people in the department, but CMEs continues. That's why you see that sometimes we have those issues. And when you look at the completeness of data, the red shows high dependence unit or ICU, and then the blue on the ward. So the blue on the wards, respiration is a challenge. Pain score is also another challenge. But of course, during those weekly meetings, we keep on projecting a graph, and then we brainstorm what could be the problem, where is the real problem. Maybe sometimes the nurse came at night and just slept, and actually this one also wakes up our nursing department, because this project ideally is entirely dependent on the nurse's attitude towards work. So in the morning when we review and the patients, there is no graphing of the patient at with the news score. We know that the nurse didn't do anything on that patient, despite them insisting that they did. So the impact, further reduction in laparotomy, about 14%. We improved surgical care, thank you, and improved surgical departmental meetings. That is one of the best impact that we have had. Previously, we were having scanty meetings, maybe once in 3 months, but currently, actually today, they are having a surgical meeting. We are not there, but they are running a surgical meeting to review all the patients. And during the mortality reviews, we are not looking at blame games, but we are looking at how we should improve. What did we do right, and where did we do wrong, and improve accordingly. Then we had a discussion with the Ministry of Health. I think Commissioner Dr. Ola, I think, is going to be around, but we had a discussion with him in the ministry, and he was very excited. Actually, for him, he wanted to write, I think, a commanding post or something like that, that all hospitals should start implementing the 5 Rs. But we told him, no, let us first study it do other pilot studies in other hospitals. And these are some of the hospitals which were recruited. I'm very happy to announce that some of my mentors, my teachers, are part of this. Professor Ajiko, Dr. Epodoi, I think those ones were highly welcoming. I met them in the Soroti Regional Referral Hospital, and when you talked about quality improvement, everyone just stood up and was eager. Quality improvement in surgical department, because these quality improvements have been done in other departments, but not in surgical department. So everyone was very eager. I have seen also Dr. David Nyeko is around. Lacho Hospital also came on board. Dr. Mubez, the team lead, Iganga, Dr. Chigonya, Chibuli Muslim Hospital, I think is there. Yeah. Dr. Semfuka Gulu, Dr. Masereka, I saw him yesterday around, Naguru Hospital. All those people, trust me, surgeons are very nice people to meet. I have met them personally, and I had indoor discussions with them, what we are trying to bring on board, what we are trying to advocate for, and everyone was welcoming. And these are words that I got from Professor Jiko, asking me, first of all, my age. Then after age, she said, if we still continue having young people like you who are enthusiastic about patient care, then Uganda is on the right track. That was Professor Jiko's word. These are some of the meetings we had with our mentors and our interns after. So we took this picture after the surgical meeting. Thank you so much. I think that's what I have. Thank you so much.
Thank you. Thank you so much, Dr. Richard Gamubaka. I think that's a very interesting talk, and I think within ourselves we can actually reduce mortality by things that we can just do locally, and I think that's a very great study that all of us should embrace, and I'm looking forward that it will be rolled to all government hospitals. Thank you so much for that enlightening talk. So the online team, do you think Dr. Maya El Hariri is online? So Dr. Maya is not online. She was going to give her talk online, but I think she will give it later. And is Dr. Nixon, has Dr. Nixon arrived? Dr. Nixon Nyonzima? So Dr. Nixon is not yet here. So I guess we shall go to our keynote speaker. So the other two speakers are unavailable before we go to the keynote speaker. If anyone has questions to Dr. Richard about this wonderful talk, let's have the questions directed to him. Thank you. There should be a mobile microphone moving around. If you have a question, just raise your hand. There is a question right there. Moving microphone, please.
Okay, thank you so much. My name is Dr. Tommy. I'm excited about this study. I think if we have more of these kind of studies, it's going to improve patient care. I have two questions. Number one, the baseline picture of our patients at Mbale Regional Referral Hospital in terms of mortality and comorbidities did not come out clearly. Because if we are to assess the successes of the study, we need to know where we started from in terms of quality and quantity. So we really needed to see the quantity baseline and then what happened after the study. Are we getting better in terms of quantity? Then the next question goes in relation to the Ministry of Health's policy, which is being implemented now, about paperless data in the facilities, that is electronic data. Because according to what I've seen with this study, I'm seeing it's more of the analog kind of data collection and also using papers, and yet we are moving more to electronic data management in health centers and also hospitals. So I just wanted to know how this study and the authors are going to navigate through this upcoming electronic data system. Thank you.
Can we have another question, please? Sister Dr. Ejiko has a question. Can you pass the microphone to her?
Thank you so much. Mine is not a question, it's just an addition. Just to tell you all surgeons and the other disciplines are present here that this quality improvement project is very good. It looks complex at the beginning. And when it was introduced to Soroti and we were trained how the project works, at a snapshot you can recognize patients that die before surgery. and the dose during surgery, and then a dose after surgery. And it gives you a very good challenge to ask yourself why, what was the cause of this death? And then also the reflections and those hurdles every morning. Once you enter your unit, you are able to already know that, oh, bed number what is a critical patient, the other bed. So you are actually able to pay attention and respond very fast and see what can be done. So I think this is a very, very good quality improvement for all the surgery disciplines. Thank you so much.
Thank you, Sister Doctor. I totally agree with you 100%. Can we have another question?
Thank you. Thank you so much for that presentation. I really appreciate. Quality improvement is one of the issues that we really need to use as to drive quality and better outcomes for our patients. I just want one clarification. In the data you're capturing, you talked about completeness of vital signs. I just hope that vital signs includes notes written by the nurses and the doctors, because for a long time, for me, I'm an internal medicine physician, so a long time we used to have this joke about surgeons and they don't like writing too much. They can make an assessment, write a diagnosis, and take the patient to theater. So I hope, in lieu of the current environment of litigation and quality of data being captured by us clinicians is equally very important. So that builds on that hurdle, the hurdles that you have, and later on the mobility or the mortality review meetings you have, they're all going to be hinged on the data, on the quality of data that has been captured beyond the usual vital signs. Thank you so much.
Let's have one more last question before Richard responds.
Thank you for that very enlightening presentation. And I think it is something that is dear to our hearts. It's very painful to do surgery and then patients die. So when we audit ourselves and we see how we can do that better, it's very good. I'm just wondering about the challenges you may have faced as you were starting this project, because there are some simple things that can fail you. You have the chart, and I think you had it in the project. I'm just trying to look forward if you're to roll this out to all the hospitals where we work, Mulago inclusive. Simple things like that stationery, making it available. The issue about human resource, the nurses, because we do know that sometimes there's a shortage of even nurses who are able to follow up and do this monitoring overnight, even during the day. You find wards where there's only one nurse and about 20 patients. How are you able to consider those factors that come in as we try to improve the quality of healthcare, besides producing the tool, but also looking at it in terms of the human resource and other requirements to make it work? Thank you.
Thank you, Dr. Olivia. Richard, we shall allow you to respond to that. Then after that, we shall have another round of questions.
Okay. Good morning. Protocol observed. I'm Fred Maiso, as already communicated, and I'll take some of the questions, and then Richard will respond to the other questions. So I want to start with Dr. Tommy's question about where did we start from, what was the picture vis-a-vis what is the current picture. So in the beginning, as Dr. Richard tried to talk about it, is that we noticed there was a higher mortality, especially in patients who have just undergone operations. And initially, we had a higher mortality of about 22% of patients. That is after major abdominal surgeries, we're losing those patients. So the question was, how can we improve this? And one of the things we looked at was their risk even prior to the surgery. And the thing that came up was that we need to do a proper risk assessment before we take these patients to surgery, and we see what we can do about it. And that's the idea of the ASOS. ASOS was a tool that was used before in other African countries. And when we looked at it, we thought that maybe we can adapt some of its aspects, whereby if you use the ASOS, you're going to, as doctor has showed, that you're going to notice that this particular category of patients are at a very higher risk. And as he showed you that if you use that tool, you come up with a number. Particularly if you notice that if someone scores like 19 from that particular risk calculator, they have a mortality rate of about 26 of dying. So we notice that if we can categorize our patients and we put more emphasis on the high-risk patients, meaning those are the patients who score 10 and above, we transfer those particular patients to a high dependence unit, or we transfer them to a designated bed where we can monitor them more frequently as compared to those low-risk patients. It made a difference. And indeed, using that together with the coming on board of the high dependence unit, we're able to curb down the mortality rate from 22% to 14%, that is in a period of 1 year, okay, using this particular data. And then lastly, I will also answer Dr. Luzge's question about the vital signs. In this particular project, we focus on all the vital signs we are supposed to take, but special emphasis is put on the vitals such as the temperature. We want to monitor the temperature of our patients post-surgery. We want to monitor the pulse, okay? And we want to monitor the SpO2 respiratory rate, and then pain score, and then the level of consciousness. We have noticed in this particular study that most of the times we don't tend to monitor level of consciousness, which sometimes adds up, and then we don't monitor the pain as well for our patients. You realize that to conduct all these particular vital signs, some of them you require to have gadgets, but others you really don't require any gadget. And this is something we are emphasizing, we are trying to push towards our interns, but as well as we ourselves, the residents, that at least for every patient you see who has just been operated, if today is day 1 after the surgery, kindly take their pain score. Know that today they are scored like this, and then maybe tomorrow they were able to score to this particular value. And this tries to give you an idea that a patient at least is improving or something is happening, okay? And as Dr. Luzge is that this particular vital signs is really key for this particular study, because it enables us to recognize our patients who are deteriorating, and we intervene appropriately, and everything is documented, and we overemphasize that let's document it on the forms that are provided, a new score form. Thank you.
Yeah, thank you so much, Dr. Freddy, for condensing some of those questions. Yeah, Dr. Tommy talked about electronic data. Actually, we faced this challenge, and a couple of 2 weeks back, we were doing Jumpstart event for Nakuru Hospital, and what we found there is that they are paperless. They have embraced electronic system 100%. And these are some of the challenges that we were discussing with the director there about how to navigate about it. So we had a consultation with the obstetricians and gynecologists of Nakuru, and they also told us that their pantograph is not in the system, though it is a tool which is used worldwide, but is not in the system. So for now, what they are doing, every patient is having a clipboard with a pantograph. Every mother is having a mother who is in labor is having a clipboard with a pantograph. So this is the same idea we borrowed from there, and then we discussed it with the director, who was very willing to buy the clipboards, and we provide a stationery for every patient, every high-risk patient. So at the end of the day, we are looking at engaging the Ministry of Health, since they are also excited about the the project. So we are engaging them. At the end of the day, probably some of these tools will be included in the electronic system for easy monitoring of the patients. Yeah, back to doctor's question. First of all, this project has led to so many things, but also inclusive resource distribution. Sometimes we have a number of patients and we don't know how to handle them. And sometimes when the HDU is there, there is a lot of politics. So now we know which kind of patients go to HDU or ICU. You cannot just do a hernia, a patient is low risk, yet we have another high risk patient, and then you admit them in high dependence unit when we have a patient who is at risk of developing a complication after surgery. So, but the major challenges that we faced were, of course, human resource. But that human resource, we navigated, most of these challenges we navigated around, like human resource. If, say, for example, you have had 10 surgeries, you may have about 2 or 3 high-risk patients. And on the ward, those high-risk patients are supposed to be, their vitals are supposed to be taken as per the standard. 30 minutes after 4 hours, within 4 hours, then 1 hour within 4 hours, then the rest is 16 hours. Then, of course, but we are still saying, do not forget the other category of patients that because they have undergone surgery and they are low risk, so they cannot deteriorate. But we are saying these ones who are at risk of developing risks after surgery, at least we should do the standard way until maybe we get enough human resource on the ward. Then the issue of attitude, like I said, mostly this project entirely depends on the nurses. But that attitude thing, we fought it, or we struggled with it for a quite long period of time until we involved in the teams, the nursing team, and everyone, of course, plus talking to them, counseling the nursing team, and then all that, and giving them scenarios and examples. Supposing you are the one who has been operated and you are admitted on the ward, what happens? Won't you like to be taken care of like the way we are saying that take care of? So we want to leave a system where everything is moving forward well. Then we had the challenge of equipment. Those one, actually this project has brought in a lot of good people, like I would say donors. Busolwe took up that project and the Rotary Club gave them monitors and these other equipments. Mbale, I think we have also received some donation from the Rotary Club of Mbale, and also we are thinking that probably even ASO will donate for us or some hospitals, some monitors. Because in Sister Jiko's hospital, the monitors are not enough. And this project, the head of department, Jinja Regional Referral Hospital, yesterday was begging, was sweet-talking to us that we also have a jumpstart event for Jinja Regional Referral Hospital. But we are going to look into that, because at the end of the day, what are we looking at? We are looking at patient care improvement. And none of us, everyone who is in this room is a patient at one time. So we need to leave a system where everything is smooth. Thank you so much.
Thank you so much for responding to those questions. I think this is a very interesting topic that can go on and on, but we are time bound. I just wanted to say something. I think our main limitation to vital sign monitoring is human resource. And if this project is rolled out, I hope it will come with that. I'll just give an example from Lago. A night nurse can have 50 patients, and there's one nurse on duty. And a vital sign, it's not a one thing, you're supposed to do it continuously. So when you engage the nurses, they will tell you, doctor, I can't do it. Like, I have to give treatment, I have to do the vitals. So I think it should come with the element of human resource, and especially nursing care. But I think it's a very good initiative that can improve patient care. So because of time, we won't be able to take another round of questions, and I'm going to invite, sorry about that. I'm going to invite our next speaker, who is our guest speaker. His name is Dr. Nixon Niyonzima. He is a consultant and research scientist at the Uganda Cancer Institute. Dr. Niyonzima's research interests are the molecular characterizations of cancers in sub-Saharan Africa, and is working on development of affordable low-cost diagnostics for diagnosis and prognostication of cancers in resource-limited settings. He did his doctoral studies in molecular and, that is a PhD, in molecular and cell biology at the University of Washington on the HIV reservoir eradication and design of PCR-based assays to quantify the latency integrated HIV and virus-associated cancers. He is currently the laboratory director at the Uganda Cancer Institute and also heads the research and training departments at UCI. He's also the project coordinator for the East Africa Centers of Excellence project at the Uganda Cancer Institute, as well as the regional cancer centers in Arua, Mbarara, and Mbale. He's an adjunct senior lecturer at Makerere University and an external examiner at Mbarara University. He also has over 40 peer-reviewed publications. So you're most welcome, Dr. Nixon Niyonzima.
Thank you for that kind introduction. Good morning, everyone. So when I received this invitation of unearthing the building blocks of institutional and individual research capacity in health sciences, I was a bit puzzled as to what to tell you, but I decided that I'm going to tell you a couple of things. Yeah, so of course, I have the obligatory slide on the Uganda Cancer Institute, and I'm also going to tell you briefly about what has been done in the past, but also discuss the challenges of biomedical research in Uganda and in Africa in general, and then tell you about what we're doing as Cancer Institute to address some of these challenges and what the future outlook is for biomedical research in our setting. So the Uganda Cancer Institute was established in 1967, and it was established as a collaboration between Makerere University, Mulago Hospital, and the US National Cancer Institute. When the Uganda Cancer Institute was started, it was established as a cancer research center for pediatric cancers. And in 2016, because of different challenges, the Institute attained autonomy and was also designated as the East Africa Center of Excellence in cancer care research and training. As I'll show later, this had enormous benefits for the Institute. The Institute currently is located, of course, at Mulago, but we're also setting up 4 regional cancer centers in Gulu, in Mbale, in Arua, and in Mbarara. And all these regional cancer centers have actually received funding. The Gulu Center has been completed, the construction, and we're now in the process of operationalizing this center. At Mulago, we have a comprehensive cancer center, so we have all departments of oncology, so medical oncology, radiation, we have surgical oncology, gynecological. Recently, we have also added nuclear medicine, as well as pediatric, palliative, as well as community cancer services. Our mandate is all things cancer, so cancer prevention, cancer treatment, cancer research, training, as well as follow-up. This is, again, historical. So part of what spurred the development of the Cancer Institute was the discovery of Burkitt's lymphoma, or the description of Burkitt's lymphoma. And what I'm showing are just images from the 1950s and 60s of 2 children with Burkitt's lymphoma at the Uganda Cancer Institute, but also the Burkitt's map that was done across Africa. And this is a nostalgic image of Mlago Hospital, and I put this because of the floods yesterday, that we had significant drainage in the 1970s, but also a beautiful structure to do research and training. And of course, this was the faculty in the medical school in the 1960s. So now, pivoting to cancer research in Africa, these are the current trends that we're seeing an increase in number of publications, and I angled my talk towards cancer research, largely because most of my experience is under cancer and virology, but it's really illustrative of the entire biomedical research field in Africa. So what we're seeing is that output in research is increasing. If you look at the trends from 2009 to about 2020, you can actually see a steady rise in number of publications in all fields. But of course, cancer is the most affected of all these, that the least number of publications is from oncology. So output is increasing, but most of these publications are collaborative publications. So you have a South and North collaboration. So you have a researcher from the US, the UK, Europe, and then an African researcher. And 67% of all the publications were from North Africa, but of this total, 48% were from Egypt. That's the total from Africa. Then from sub-Saharan Africa, we have 19% coming from Nigeria alone, when you combine all the sub-Saharan Africa countries. So what this shows is that, yes, there's some research in Africa, biomedical research, but it's predominated by two countries. That's Egypt, Egypt, Nigeria, and then South Africa comes a close third. So what are some of the challenges? And I outlined this, but I'll talk about each very briefly. So funding is actually the biggest challenge to biomedical research in Africa. We need funding to conduct the research. We need funding to build infrastructure. We need funding to train personnel. And without the funding, then becomes challenging to actually conduct research. And as we'll see later, most of the funding for biomedical research in Africa is not from Africa. So we cannot set our own research agenda. We depend on who is paying the money. Infrastructure is a problem, and infrastructure is both research but also clinical infrastructure. It's difficult to do research when your patients are dying. So most of the time, these go hand in hand, that we need to improve clinical research, clinical care, if we're to actually address research challenges. Personnel is also a significant issue, that we have a paucity of highly trained personnel. I read a recent study that was saying that we only have about 2,000 PhDs in Uganda, and those are very few, because if you want to conduct high-class biomedical research, you need highly trained people. You need mentorship, and mentorship is not only for the research, but straight from training. If most of our universities have less than 35% staffing, the mentorship is a problem. And the few senior researchers that we have are actually working with non-Ugandan actors, non-African actors. Most of them have the North collaborations. So maybe what we call senior researchers here are also being mentored by the northern colleagues. But there's little mentorship of our colleagues here. Brain drain is also a big impact, that most of the people who train very highly leave the continent. But I think this is going to change with the recent intervention of Trump, that it's going to become difficult, for example, to go to the US. So hopefully we'll retain some of these here. We have issues of data management and mismanagement. And the team before has been talking about digitization in Chirudu and Naguru. These are examples of interventions that we need to do to assure that there's data quality, but also that the data is available to do research. I've already talked about access to care, that we need to improve the quality of care if we're to do good biomedical research. Research regulation, so UNCST, the local recs, and also National Drug Authority. Working with them is important to establish an environment that's conducive to research. And of course, public awareness. We need to talk to our people. We have encountered some of these challenges at the Cancer Institute, that when you tell people to come and enroll in a clinical trial, even a phase 3 clinical trial, everybody thinks this drug has never been tested, there's no efficacy, and therefore we cannot participate in this trial. It's until recently, when we have started to see success in clinical trials, that now patients are more eager or more willing to participate in clinical trials. Otherwise, when you say we have a clinical trial, it's like you've moved from the lab to the patient, but most of the trials we're doing are actually far advanced, and we know the efficacy of all these drugs. So at the Cancer Institute, we have done a number of interventions to actually address some of these challenges, and I'm going to present this in two parts because some of these are actually dedicated to improving the quality of care to address the research challenges. And you'll agree with me that if your patients are dying, it's very difficult to actually conduct any research in that environment. So the first thing that we did at the Cancer Institute was, of course, infrastructure improvement, infrastructure development. We're also looking at clinical excellence. We have done personnel development. We have also enriched partnerships and collaborations. We have supported mentorship, and we have also built other support services that improve the ability to conduct research. And of course, funding and policies go hand in hand to support this. So regarding infrastructure development, when the UCA was established in 1967, it was established as an 18-bed hospital. So that was the Lymphoma Treatment Center, and then STC was added in 1969. But currently we're expanding to a 350-bed hospital, and that's the building in the left bottom. And then you saw we're building a dedicated research and training building. Actually, we're setting up 2 buildings that are dedicated to research and training. So that's the one in the right, in the left upper corner, as well as another that I'll show later. And then also basically improving all the infrastructure that supports care. If the care is conducted in a high class environment, it means that you're actually able to do research, you're following protocols. The standard of care you have at the Cancer Institute shouldn't be standard of care in the US in 1960. It should be a global standard of care for all these patients. And I'm sure if you've interacted with a REC and you're talking about standard of care here, they'll tell you you're giving this regimen that is for 1980 because that's the standard of care here, but you need to change and give the current standard of care. So what we have done first is building infrastructure at the Cancer Institute, and then so this is the research and training building, which is at the top of the hill. This is fairly advanced, the construction, and this is supported by African Development Bank. It's research and training, but it has, as I'll show on the next slide, it has surgical services. So we had a paucity of, we had very few theaters, so we're building 4 new theaters in that building, and a 12-bed ICU, including 6 beds that are dedicated to surgery. We have a training facility, we have a conference facility. We're building reference laboratories, but I've also created research spaces. So we have a research lab, we have sit-down spaces or touch-down spaces for researchers that come to do research at the Cancer Institute. And we're not looking at staff of the Cancer Institute alone, but also partnering with the university to see if there are PhD students or scholars who need space. We'll provide that space so that people can do research in a comfortable environment. And we've also created a clinical trials ward, including a clinical trials pharmacy, as well as a clinical trials clinic. So basically a floor dedicated to clinical trials. So we have outpatients, we have inpatients, and then we also have the pharmacy. This is the current state of the building. We are hoping that by end of this year or early next year, we'll be able to enter this building. And this is the inside, what it looks like. So the other thing that we have worked on as the Uganda Cancer Institute is what we call research core facilities. These are the other facilities that an individual will not need to establish, or that research is going to be expensive if one individual is going to establish, say, a biobank. So we have established these core facilities, we have established the lab, we have established the biobank to support researchers. And this is really the progress of our biobank. We currently have more than 10,000 tissues annotated. That's pathology alone. But overall, we have about 600,000 tissues that have been annotated and banked at the Cancer Institute. And this is a stepwise process. It's phased. We currently have 12 ultra-low temperature freezers. We want to expand to 25 within the next 5 years. So around 2028, which is our timeline, we want to be able to expand to about 20 ultra-low freezers for the biobank, the refrigerators, assorted fridges. We have 2 liquid nitrogen tanks at the institute, and we also want to expand this so that researchers actually have access to these facilities. We have also, the metallic slide storage cabinets. And the idea is that these resources are available to researchers. You develop your concept, you come to the Cancer Institute. The Cancer Institute is managing these resources. They are not managed by the researcher. Of course, we'll be charging a small fee to maintain these facilities. But the idea is that as a researcher, you don't need to set up these facilities yourself. If you want to do breast cancer research, the tissues are there. If you want laboratory equipment, it's there at the Cancer Institute, and you can use it. So we have set up microbiology, we have set up flow cytometry, we have also set up sequencing, we have set up PCR, and the idea is that these will actually support research. Now, these are in the research section, but we think that these facilities are also going to support clinical care. So we don't want to do world-class research and third-world clinical care. We want these 2 things to move hand in hand. And of course, we have also invested in bioinformatics as we are setting up the sequencing facility. Regarding personnel development, which is really a key component of any research, UCI, with support of African Development Bank, we have supported over 204 health workers. Now, our concept at the Cancer Institute is that every health worker we train is a research resource. So we don't train people that are specifically researchers, but we train our health workers, our staff, to such a high level that these health workers can also contribute to research. And of these, we have supported 12 PhD trainees and also 43 oncology fellows. And we also have 6 accredited fellowships, oncology fellowship training programs at the Cancer Institute, so medical oncology, gynecologic oncology, pediatric oncology and hematology, radiation oncology, urologic oncology, as well as head and neck surgical oncology. We're also providing our staff with protected research and training time. So most of our staff will have clinic duty for 3 days or 4 days a week. And then the extra time is supposed to be dedicated to research and teaching. And we've also revised our HR structure. So that's a human resource structure. And we have embedded research-specific positions. So we have clinicians. So a clinician can actually rise to a consultant or senior consultant in cancer research. That's embedded within our structure. Nurses can rise. All staff can actually be embedded within this structure and actually rise to the top. And the idea was that there are also people who are basically research scientists and also need to be employed and rise through the structure. If you're not a clinician in the past, it was difficult to work at the Cancer Institute, but we're changing this. Of course, we have also introduced positions for biobanking, for regulatory officers, biostatistics and epidemiology, cancer registration, immunologists, bioinformaticians, and all these are actually support staff. They support, except the first one, they support the entire institute to do research. So our research regulatory, our biostatisticians are to support people to actually do the applications, to develop their studies, and all this is actually supported by the institute to minimize the cost of research at the institute. And clinical excellence, I've already talked about this, that we want to offer world-class care, and these are some of the things that we have done. We're enhancing quality initiatives at the Cancer Institute, and recently also our lab was accredited by SANAS, but also doing other quality interventions to make sure that the clinical care does not lag behind research. And the example I would like to give is a clinical trial we're currently conducting at the Cancer Institute. It's a multi-site international clinical trial, and it's a breast cancer clinical trial. They are looking at PIK3CA mutations, but for first line, it is Phesgo, which is a drug that is pertuzumab and trastuzumab. It was registered in Uganda about 2 weeks ago. But the eligibility, if somebody has to have been on that treatment for at least 6 cycles to benefit from these new drugs. So we negotiated with a pharmaceutical company that gave us this drug so that we actually take people through induction on this worldwide standard of care. our standard of care has been inferior to what is being offered across the world. So we want to also move our clinical services to such a level that when we attract trials from outside Uganda, we are not affected by this issue of you offering 1980 standard of care. And we have also built partnerships and collaborations, and we're looking at both local and external partners. Of course, the Fred Hutch is our longest partner, and we also have other external universities. Now, what is happening here is that the landscape for partnerships has changed this year. Most of our partners have been American partners, but we're now trying to look out and engage other partners that are non-US because of the changes that have happened over the last couple of months. And we're also engaging pharmaceutical companies or pharmaceutical partners. We have a lot of pharma partners that are working with the Cancer Institute to advance research. And of course, the local universities. And I've put these local universities because each of our regional centers is actually going to be co-situated or co-located with a university. So Mbarara, we're going to have the Mbarara Regional Center. Gulu, we have Gulu. Busitema, we have the Mbale Center. And then Muni, we have the Arua Center. And the idea is that the facilities that we are constructing in those centers will advance both research and training for those universities. So we're building the infrastructure and the necessary facilities for research countrywide. And of course, mentorship, we have public engagements, we have weekly research in progress, and also have conferences and to support staff. The image here is from the Makerere Medical Journal in 1966. You may not be able to read it, but it's an aid to pediatric history taking in simple Uganda. And why I put it here, it was the Department of Pediatrics trying to mentor the local, the undergraduate students on how to take history taking. And I hope these are things that we can continue doing to nurture the young population. Of course, funding is still a big problem. Like I mentioned, most of the funding is from high-income countries. Most of our research portfolio is either from pharma or from NIH. And usually also requires a senior non-Ugandan co-investigator. So for most of them, it's very difficult to find a Ugandan alone winning this grant. But as UCI, we're currently providing research funding for pilot grants, and we're also applying for institutional grants to support our staff. And then, of course, Ministry of Science and Technology has also provided research funding to the Cancer Institute that we're distributing to our staff to ensure that we have this. And funding is still our biggest challenge, partly because as a country, we're not prioritizing research. We're also working on data stewardship. We're establishing a national cancer registry, which is going to be a network that gets data from different regional registries. So the Kampala Cancer Registry, which is already in existence, Gulu in existence, and then 3 others that we're going to set up, all feeding into a national cancer registry to cover 35% of the population. And of course, we're also moving to electronic medical records so that our data is accessible and usable. I'm coming towards the end, but we're also having, of course, this research dissemination. I think I've talked about this already, but this is the same journal, 1966. So other interventions is regulation. So the Uganda Cancer Institute has an accredited research ethics committee. We have an institutional biosafety committee, and we work very closely with UNCST and NDA. And we're also partnering with the Ministry of Health on some interventions. The National Cancer Registry, we're working closely with the Ministry of Health. We have developed a research policy and research agenda that's locally relevant, and then also provide digital resources for our staff. So we have CT, which is for GCP and ethics training. We have EndNote, we have Hinari, we have Access Research for Life, Elsevier, and Up to Date, really to make resources accessible for our staff to do research. So over the past 5 years, we have seen a number of achievements. So in 2016, we had about 10 publications per year. So we're now averaging about 40, 45 peer-reviewed publications per year. We currently have 15 multi-site clinical trials. and 8 of these are pharma-funded clinical trials. We have over 60 active research studies, and we're also awarding at least 20 pilot grants per year for our staff to be able to do research. And of course, we have established robust partnerships. We're improving our research infrastructure. We have research policy and research agenda, as well as a biennial research dissemination conference that we hold for our researchers to actually disseminate this research. So, what's the future outlook? Funding challenges are going to get worse. The biggest funder of biomedical research is the US. With a change in landscape, it may get more complicated. We also need more trained scientists. We need more infrastructure. But that makes it seem gloomy, but the future is bright. There's more interest in biomedical research in Africa. If you look at part of the reason why all these clinical trials, for example, are increasing is because of the need for diversity in these clinical trials, but also, of course, some of the infrastructure that we have put up. If you look at genomics, there's interest in the African genome, and there's also more African funding. So government of Uganda is actually also deliberately increasing research funding, so through Ministry of Science and Technology, and then the universities are now also getting their own dedicated research grants. This is our research outlook for the Cancer Institute. This is actually a cancer research and innovation facility, which is going to be constructed starting in 2027. And this is at the location of the current Cancer Institute, so next to the Fred Hatch building. That is where STC is, the director's office are. This is where we are going to establish the Cancer Research and Innovation Facility. And the goal is that the lower UCI campus will be a research and training campus. And these are labs, offices, touchdown spaces, and really facilities to support biomedical research. And again, not for Cancer Institute, but really for the country. And this is just to show the location. The Innovation Center is really at the bottom, left, right-hand side corner in the bottom, and all this is infrastructure that the Cancer Institute is setting to build research capacity. So I've come back with the slide that I started with, catalyzing biomedical research in Africa. It's now not challenges, but what we need to do to catalyze biomedical research in Africa. We need to increase funding, we need to improve infrastructure, we need to undertake personnel development, and when you train people, you need to be able to absorb these people, you need to compensate them appropriately. We need to undertake mentorship. We also need to address the challenges of brain drain, data stewardship. We need to ensure excellence in clinical care. We need to have a robust regulatory framework for research. And of course, we need to engage with the public. We need to disseminate the research that we do. And dissemination is important because when we do research and we don't disseminate the research, nobody knows about the amazing discoveries that we have done. So we need more African journals. We need more networks where we can disseminate our data. And then, of course, we need to do more partnerships, more collaboration. And this is mostly for South-South collaboration. So Ugandans need to partner with Kenyans, need to partner within Sub-Saharan Africa. So thank you very much. I will be happy to take any questions.
Thank you so much, Dr. Nixon Mionzima. I'm going to ask you to take a seat at the podium. We shall take the questions later. So this session 3, my co-chair is Professor Moses Galukande, and our next speaker, who is going to give us a keynote address, is Professor Todd Tato, and he's going to talk about evolution and the future of surgical treatment for breast cancer. And I will invite Professor Galukande to introduce Professor Todd Tato.
Good morning once again. I'm not Professor Galukande. He is going to pick our guest of honor. Professor Todd Tato received his MD from Johns Hopkins Medical School in 1988, shortly after I was born. Completed his residency at the Medical College of Virginia and received a surgical oncology fellowship at MD Anderson Cancer Center in 1996. He received a Master's of Science in Clinical Research from the University of Minnesota in 2004. He's currently the Vice Chair of Global Surgery and Disparities at the University of Minnesota and is a Professor of Surgery in the Division of Surgical Oncology. He holds the Riggs Chair for Breast Cancer Research. His current research interests focus on the patterns and outcomes of cancer treatment. He's well published with over 180 peer-reviewed publications in journals such as the Annals of Surgical Oncology, the Journal of American College of Surgeons, Cancer, Journal of Clinical Oncology, and the Journal of the National Cancer Institute, to name a few. He has received board recognitions for his research on prophylactic mastectomy trends, lymph node staging, and breast MRI. Join me to welcome Professor Todd Tato to give us a keynote speech.
Well, good morning. It's an honor to be here. I'm a little disappointed that my age was referred to by Dr. Edward when I graduated from medical school. This is my third trip to Uganda, and I'm very, very honored and pleased to be back to explore your country again, to meet new friends and reacquaint with old friends. So I'm very excited about being here. All right, so this is how you move the slides. There. Okay, so I am Dr. Todd Tuttle, that's me, T-U-T-T-L-E. I'm frequently confused with this very famous Dr. Turtle. It happens everywhere I go. If you're expecting to hear from Dr. Turtle this morning, I apologize, he's busy, so you're stuck with me. So I live in Minnesota. Minnesota is in the north central part of the United States, just below Canada. It's not unusual this time of year to have a snowy Minnesota like you see right there. It's not as nice and beautiful as it is here, and we are delighted to be here and not in Minnesota right now. I'm a surgical oncologist at the University of Minnesota, which is in Minneapolis. I was the chief of surgical oncology for many years and then became the vice chair of our Global Surgery and Disparities program. The University of Minnesota and Uganda have a long history together, from pediatrics to infectious disease and, more importantly now, surgery. I visited Uganda multiple times. One of my partners, Dr. Bielman, this man spoke last year. He's been coming to Uganda for many years, I think 12, 14 years. I've met a lot of our surgical residents have come to Uganda to train. They have received outstanding training. They have learned about diseases that we infrequently see in the U.S. They have seen more advanced stages of disease than we see in the U.S., and they've learned how to diagnose and manage patients with less resources. So it's been a very valuable experience for our trainees. Likewise, we have invited surgical residents from Uganda to come to Minnesota, and it's been a delight. They have experienced how we educate surgeons in Minnesota. They've got to see how our medical system works, how ICUs work, how cancer tumor boards work, and it's been a delightful experience and exchange. I know there's a lot of surgical residents right here, and we'd love to have you come to Minnesota to visit. We can host you for 2 or 3 months, whatever works, and I can guarantee it'll be a great experience. It's not really that cold, and if you come during the winter, we'll get you some coats. Well, today I'm going to talk about breast cancer, and globally, breast cancer is the most common cause of cancer death among women, and I understand it's number 2 in Uganda. So it's a big problem, and I'm going to talk about how we have managed breast cancer in the U.S., which may serve as a model for Uganda as well. So prior to Halsted in the 19th century, there was no standard treatment for breast cancer. Physicians all across the world were doing different things. But in 1895, Halsted first described his operation known as the radical mastectomy. And this was a systematic effort to try to cure breast cancer as best as possible. The radical mastectomy involved removal of the skin, the pectoralis major and minor muscles, the breast, and the axillary lymph nodes. This is a survival curve from Halsted's first series from 1899 to 1931. Very disappointing. And Halsted commented that we rarely meet a physician or a surgeon who can testify to a single instance of a positive cure for breast cancer. So this is almost uniformly a fatal disease. And you can see the outcomes, even in the 1930s, were still very poor. This is the survival curves for breast cancer shown in the pink line from 1930 to 2015. And what you can see by looking at this pink line, that the survival rates didn't change from Halsted to really till the early 1980s, and then the survival rates markedly improved. And now in the US, more than 90% of patients who are diagnosed with breast cancer will survive 10 years. So what happened? What changed in the 1980s to the point where we could cure most women with breast cancer? And I think there are 3 important developments. The first was increased public awareness of breast cancer. And this was done a lot through celebrities. At that time, the president's wife and the vice president's wife were both diagnosed with breast cancer. And the message was that if detected early, breast cancer is curable. And that was probably the most important initial strategy. And I think it's a very important strategy for countries like Uganda. The second thing that started in the early 1980s was the use of population-based screening mammography. And this is very difficult to do. It's very expensive. There are very few LMICs that can actually afford to do screening mammography for the entire population. And thirdly was the development of randomized clinical trials. So this is Dr. Bernie Fisher. He was a surgeon at Pittsburgh, and he started the NSABP, which led to the development of a number of life-changing clinical trials in the United States. The first of these clinical trials is NSABP B04. In B04, patients with breast cancer were randomized to 3 arms: a radical mastectomy, Halsted's operation, a mastectomy plus a lymph node dissection, or a mastectomy plus radiation therapy. This trial showed no difference in overall survival, so Halsted's operation, which had been the only treatment for breast cancer for more than 3/4 of a century in the United States, was done with this publication, a very powerful prospective randomized trial. So the NSABP concluded if we can save the muscles, perhaps we could also save the breast. And so B06 was launched. And I would argue that B06 is the most important randomized trial ever done in surgery. In B06, women were randomized to either breast-conserving surgery with or without radiation therapy or a mastectomy. There was no difference in overall survival. It wasn't that they were close, they were exactly the same. So a bigger surgery did not improve outcomes for women with breast cancer. But not all patients today are candidates for breast-conserving surgery. One of the contraindications is large tumor size. And tumor size, there's a little bit of wiggle room with tumor size, but once you get to a tumor greater than 5 centimeters, it becomes more difficult to obtain negative surgical margins and a good cosmetic outcome. This is a problem I know that you face in Uganda. A second contraindication to breast-conserving surgery is inability to receive radiation therapy. So patients who've received radiation therapy in the past or women who are pregnant are not good candidates for breast-conserving surgery. A third contraindication is inability to obtain negative surgical margins after breast-conserving surgery. So what is a negative surgical margin? So the NSABP B06 defined a negative margin as tumor not touching ink, as shown on the right. When the tumor touches the ink, that is a positive margin. And we know that when you have a positive margin, that the local recurrence rate is almost 2.5 times higher than with a negative margin. So we have to get negative margins. Does it make a difference to have wide negative margins compared to narrow negative margins? And the answer is no. In a large meta-analysis, there was no improvement in outcomes between a narrow margin versus a wide margin. So several groups in the United States have advocated that the use of no ink on tumor is the standard acceptable margin for women undergoing breast-conserving surgery. And you don't need to go back and do more and more margins in order to get a wider negative margin. There are consequences of continuing to go back for close or positive margins, including morbidity, decreased cosmetic outcomes, cost, delay in other therapies, and patients' anxieties. And the fourth relative contraindication to breast-conserving surgery was a patient had multicentric breast cancer, more than one tumor in their breast, like this patient on the right. However, I think that contraindication is now gone. A recently published ICASOG trial, which was a single-arm study, included women 40 years or older with 2 or 3 foci of breast cancer, underwent multiple lumpectomies with negative margins, received radiation therapy, and the 5-year local recurrence rate was only 3%, which is very similar to the local recurrence rates for patients with just a single tumor. So presently, we do not think that a multi-centric breast cancer is an absolute contraindication to breast-conserving surgery. So I want to talk about mastectomies next. First is a simple mastectomy. It's a removal of the nipple-areolar complex and the breast tissue from the clavicle superiorly, the lateral border of the sternum medially, the inframammary fold inferiorly, without reconstruction and without any lymph node removal. The second is an operation that we do much more commonly, a skin-sparing mastectomy, where we remove the nipple-areolar complex, but we retain the rest of the skin envelope for reconstruction. And this is combined with reconstruction with excellent outcomes. Increasingly, we're performing more and more nipple-sparing mastectomies where we don't remove any skin. Our preferred approach is to do an incision at the inframammary fold. We remove all the breast tissue, we preserve the nipple rear complex, and then we combine this with immediate reconstruction at the same time. And the immediate reconstruction could either be autologous, using the patient's own tissue. Most commonly, we use a deep flap, or it could be implant-based. It's important to note that having a skin-sparing mastectomy or nipple-sparing mastectomy does not increase patients' risk of recurrence. And it does not impede our ability to diagnose recurrence if it happens. And the cosmetic outcomes can be very good. Not all patients are good candidates for nipple-sparing mastectomies. Those who have tumors close to the nipple, those who smoke, those with significant other medical problems, locally advanced breast cancer, or patients with a lot of breast tissue. Next, I want to talk about kind of a curious phenomenon that's happening in the United States, and we reported on this many years ago, and that is that an increasing number of women with cancer in one breast are choosing to have both their breasts removed. And these would be women who even have small tumors that would be amenable to a lumpectomy are now having a double or bilateral mastectomy. And other researchers have found similar trends, that the use of a double mastectomy for women with unilateral breast cancer is increased in all geographic regions of the United States, all patient ages, all races, all stages. The main reason why women cite for having a double mastectomy is worry about getting cancer in that opposite breast. Well, we know from older studies that 10-year risk of developing a contralateral breast cancer is less than 5%. In the most recent Taylor X study, the 9-year risk of developing a contralateral breast cancer was only 1.4%. So this concerns about a contralateral breast cancer risk are over-exaggerated by many patients. We conducted a Markov study looking at survival benefits for patients who have unilateral breast cancer, and we could find no benefit for any subset of patients with a double mastectomy. And a double mastectomy, especially with reconstruction, is associated with higher complication rate, higher reoperation rates, and more long-term chest pain. So the American Society of Breast Surgeons issued a consensus statement a few years ago that bilateral mastectomy should be discouraged for an average risk woman, but it should be considered for those patients who have a BRCA1 and 2 mutation. In the United States, we have the luxury of obtaining genetic testing on most of our patients. And I recommend that all of our patients consider getting tested for BRCA or other gene mutations because it may impact their care. Next, I want to talk about one of the most controversial topics in breast cancer surgery, and that is how do you manage the lymph nodes? And it seems so simple today with sentinel lymph node biopsy, and that is that a cancer in the breast can leave the breast through the afferent lymphatic channels, go to a single lymph node first that can be identified with a radioactive tracer or blue dye, and then removed and tested. And if there's no cancer in that first lymph node, then the rest of those lymph nodes should also be cancer-free. It took us a long time to figure out a relatively simple concept. And in fact, since the time of Halsted to about 2000, an axillary lymph node dissection with all of its problems remained the standard of care. Now remember BO4. In BO4, patients were randomized to an axillary lymph node dissection or axillary radiation. There was no difference in survival between those two groups. And the risk of axillary recurrence after radiation therapy was not worse compared to to axillary node dissection, and it was very low, 3%. So why did we continue? This study was published in 1985. Why did we continue to do axillary lymph node dissections until the 21st century? And the main reason is that oncologists used the information from an axillary lymph nodes to determine the use of adjuvant therapies. Well, today's sentinel lymph node biopsy has largely replaced axillary lymph node dissection for women with invasive breast cancer. I'm going to talk first about patients with non-palpable lymph nodes. The lymph nodes feel normal by exam. If the sentinel lymph node is negative, there is no role for an axillary lymph node dissection. You can save patients a lot of morbidity by adopting a relatively simple technique of sentinel lymph node biopsy. We've taught this procedure in Honduras, in Costa Rica, in Mongolia. In China, it's a very easy procedure to learn. So what if the sentinel node is positive for patients who have non-palpable lymph nodes? Again, we do not recommend removal of the rest of those lymph nodes. And why is that? And it's based largely on this study, ACOSOG Z11. In Z11, women who underwent a lumpectomy and a sentinel node biopsy, and there was cancer in the sentinel node, they were randomized to either removal of the rest of the lymph nodes or axillary observation. In the axillary lymph node dissection group, 27% of the women had additional positive lymph nodes. Since this was a large randomized trial, we can assume that about 27% of the women in the observation group also had lymph node metastasis. However, the axillary recurrence rates were very low, less than 1% in both groups. Even in the group that had 27% chance of having lymph node metastasis. And there was no difference in overall survival. These are some of the side effects in Z11, and you can see that paresthesias, pain, numbness, lymphedema were all significantly higher in the axillary lymph node dissection group. These patients had no benefit from a cancer standpoint from having all their lymph nodes taken out, and they were harmed. Now, importantly, in Z11, patients who underwent mastectomy were excluded. And so another trial called Amaros was conducted. Again, patients with T1, T2 tumors, they had a positive sentinel node biopsy. They were randomized to a lymph node dissection again or axillary radiation. 18% of the patients had mastectomies. And again, we found no difference in oncologic outcomes. The axillary recurrence rates with axillary radiation was only 1.2%. But look at the difference in lymphedema risk for node dissection versus radiation. That kind of makes me sad as a surgeon that we don't do as good a job as a radiation oncologist in preventing lymphedema. So today, if you have a positive sentinel lymph node biopsy, we can strongly conclude through ACOSOG, Amaros, and other randomized trial that there is no oncologic benefit for an axillary lymph node dissection. Those are patients with non-palpable lymph nodes. What if a patient has a palpable lymph node, comes in with a large lymph node you can feel under their armpit? What do we do in that situation? The Alliance trial was conducted, and this is a prospective single-arm study, and it included patients with clinical lymphadenopathy. They received neoadjuvant chemotherapy, and then they underwent a sentinel lymph node biopsy plus an axillary lymph node dissection in all patients to determine whether or not that sentinel lymph node was accurate in the setting. And what they found was that the overall false negative rate was 12.6% when the surgeons used both blue dye and a radioactive tracer and went down, and when the surgeons removed at least 3 lymph nodes, the false negative rate was improved. And the false negative rate for non-palpable lymph nodes is about 8 to 9%. So it's pretty close to where it was with patients with non-palpable lymph nodes. We can even make the false negative rate lower by doing a procedure called targeted axillary dissection, or TAD. In this situation, women who have palpable lymph nodes undergo a biopsy of that lymph node, and a clip is placed in that biopsy lymph node. Then the patient undergoes neoadjuvant chemotherapy. The lymph nodes are no longer palpable, and then after the chemotherapy is done, and at the time of the breast surgery, the surgeon removes that clip lymph node plus any radioactive or blue nodes, and this is associated with a very low false negative rate. So in this study from Memorial Sloan Kettering, they again looked at women with palpable lymph nodes. They received neoadjuvant chemotherapy, and then the lymph nodes became non-palpable. Then they went on to surgery with a sentinel node biopsy. If the sentinel lymph node was negative, out of 205 patients, they had 0 axillary recurrences. And other studies from other institutions using slightly different techniques also show very low risk of an axillary recurrence following this protocol. So what about the same patient? A patient who presents with palpable lymph nodes, undergoes chemotherapy, the lymph nodes are now non-palpable, you can't feel them. You do a sentinel node biopsy, but the sentinel node now has cancer in it. Well, right now there's a prospective randomized clinical trial going on, which is now, I think, completed accrual, in which patients are randomized to either an axillary lymph node dissection plus radiation therapy or radiation therapy alone. Now, I can tell you how this is going to end, is that, again, axillary lymph node dissection is going to lose. But data are coming. So, and all this complex talk about lymph nodes, where do we stand today? So if the lymph nodes are non-palpable, I'd recommend a sentinel node biopsy, no axillary node dissections. If the lymph nodes are palpable and you're not going to give neoadjuvant therapy, then you probably should do an axillary lymph node dissection. However, if you can give neoadjuvant chemotherapy, and as a result, the lymph nodes now become non-palpable, I think it is totally appropriate to do a sentinel node biopsy and to remove that biopsy-proven lymph node. If there's no cancer in that lymph node, then the patient can be spared an axillary node dissection. If there is cancer in that lymph node, then patients could either have radiation therapy alone or an axillary node dissection plus radiation therapy. If after neoadjuvant chemotherapy, the lymph nodes are still palpable, I think you're still stuck with an axillary node dissection. So where are we going in the future? Do we really even need to do a sentinel lymph node biopsy? In the past, and the explanation for doing any axillary staging is that the oncologist needed the information from the lymph node to determine what treatments to get. Well, today we don't use information from the lymph nodes as much as we used to for determining the benefit of chemotherapy. We look at estrogen receptor status, HER2/neu status, and genomic assays such as the 21 gene recurrence score. So the SOUND trial was published a couple of years ago. And in the SOUND trial, patients with small tumors underwent an axillary ultrasound, and the lymph nodes had to be normal by ultrasound. And then the patients are randomized to either sentinel node biopsy or axillary observation. There was no difference in any oncologic outcome for those patients who had no axillary surgery at all. So, big deal. Taking out a lymph node doesn't have that many side effects. That's what I told our residents and students for years. And then this paper comes along that proved me wrong. In the ENSEMA trial, again, patients with early stage breast cancer are randomized to sentinel node biopsy or observation. And in the sentinel node group, there was significantly worse morbidity, arm mobility, compared to axillary observation. And again, in the ENSEMA trial, no difference in oncologic outcomes. So I think we're coming to a time, not now, but in the future, where we don't even do sentinel lymph node biopsies for large groups of patients. I want to conclude by talking a little bit about the University of Minnesota Global Breast Cancer Program. we are very interested in decreasing the mortality and the morbidity of breast cancer treatments in low and middle income countries. One of the projects that we've been involved with for 15 years is providing breast cancer surgery in Honduras. Honduras is a very poor country in Central America, has a population of about 11 to 12 million people. We've been able to provide free breast cancer surgeries there for about 15 years. We've also been very involved with education in Honduras and trying to educate women, trying to educate providers of what breast cancer looks like. We've been involved with doing research in Honduras to try to improve outcomes, and we've been involved with advocacy. We've met with the Minister of Health, with the members of Congress to try to make breast cancer early diagnosis a high priority for the government. We've also initiated several multidisciplinary tumor boards in which we meet monthly, and the local team presents a number of different cases. And then we try to provide educational experiences for those cases. And we do this now with Mongolia and with Ethiopia primarily. The tumor board with Mongolia has been extraordinarily successful. We visited Mongolia 2 years ago. We taught them how to do sentinel lymph node biopsies. We gave them a number of lectures. And what happened in Mongolia, just with the initiation of this tumor board, is their mastectomy rates went from over 95% to now 50%. And the rates of axillary lymph node dissection went from 100% to now less than 50%. And so it's been a very impactful part of our job. We also started the first, I think it's the first, global breast cancer fellowship in the United States that's only open to physicians from low and middle income countries. And so fellowship is run exactly like any U.S. breast fellowship is. The fellows rotate through medical oncology, surgical oncology, plastic surgery, pathology, radiology, and they develop a multidisciplinary breast cancer training. And our goal is that we will develop these high-end clinical breast cancer physicians who will go back to their countries and lead breast cancer efforts in their own countries. Dr. Nixon talked about the brain drain. We will absolutely not take any or consider any fellow who wants to come to the United States and live. We are dedicated to having those individuals return to their home country. These two individuals here are our first two trainees. Dr. Batsuk on the left is from Mongolia. He's already working with the Minister of Health there to try to improve breast cancer outcomes. Dr. Alicia is on the right. She's from Honduras. She has also been setting up screening programs throughout Honduras since she left Minnesota. And finally, in May, we are launching our first monthly global breast cancer seminar. And this is an educational seminar that's going to talk about a number of different topics, including surgery, radiation oncology, how to manage a triple negative breast cancer, how to manage pregnancy-associated breast cancer. And it's geared towards physicians who are primarily treating breast cancer in LMICs. And our goals is to provide educational opportunities, but also to develop a network of physicians, advocates in LMICs who are dedicated to improving the lives of women with breast cancer. So our first seminar is May 6th. It's at 7 a.m. Central Time, 3 p.m. Kampala time. Dr. Benjamin Anderson, who's probably has done more for global breast cancer than anybody that I know, has agreed to speak. So I hope that you guys can come and we can provide you some information. So I want to end by saying I want to expand our partnerships with Uganda, particularly in the area of breast cancer. I would love to have our next fellow come from Uganda. and then come back to Uganda and lead breast cancer efforts. So thank you very much. You can WhatsApp me, you can email me, but I'd love to hear from you. Thank you. You want to do questions now or later?
Thank you so much, Professor Todd Tato. I will request you to come and take a seat at the podium. So I'm going to hand over the microphone to Professor Galukande.
Our dear delegates, you're most welcome, protocol observed. As the chair of the annual scientific conference and surgical landscape exhibition, I take this honor to invite our one and only president, Professor Moses Galukande. You're most welcome.
Good morning, ladies and gentlemen. You're all very welcome. Thank you for making the time. And in our midst, we have our guest of honor, the Honorable Minister of Health, Ruth Jenna Chen. You're very welcome. And yeah. So I'll thank our speakers for those wonderful presentations. I think what we'll do, we'll adjourn the session for questions, and then we'll do our next session that will be the panel that would include the minister. But before that, I'll do some remarks. Yes. Thank you very much. Those were wonderful presentations. All the presenters were Ugandans, including Professor Todd. I'd like to especially, before I say my remarks, to especially thank the team from Minnesota. Please stand up again for recognition. The team from Minnesota. We appreciate the collaboration very much. These people have been good to us. They are our good friends. We've had some of our residents go over to Minnesota. They didn't want to leave, but I told them you have to come back, so they came back. So thank you very much again, and we're looking forward to strengthening our collaborations and partnerships in breast cancer. And later this evening, we'll be talking about partnerships with pediatric surgery and ENT surgery. So we're looking forward to that. Allow me to welcome you once again. We appreciate your commitment and time. I have a few points to make. So this is our third national annual surgical exhibition. So combining the exhibition with the scientific conference. And you attended the second one, Honorable Minister. This is the third one. And what's the rationale? For both, the rationale is we want to advance the science of surgery. We want to meet and share and inspire and also reflect on our challenges and learn from each other. And we're doing this not only for ourselves, but also for people across our borders. And the gentlemen on your right and your left are not Ugandan. They look like they are Ugandan, but they're not Ugandan. That's part of our collaboration. Now, for the exhibition, we have a number of intentions, one of which is to improve public confidence in surgical services in the country. We are amazed that many people don't know what we can do. And when we do that, it's an effort to let people know that we can actually do a lot, and a lot does happen each time. And of course, you know very well, lately we commenced kidney transplant surgery. And one of the other things that's going to begin is with the ENT department. They have a brand new state-of-the-art machine that tests hearing loss, and we understand it's not anywhere in East Africa. We are the first ones to have it, and that service is going to be rolled out. Honorable Minister, I think one of our last conversations, you reflected on this fact, and we also encounter it in many conversations we have, that when we go to seek support, people tell us that it is easy to support other things, but it's difficult to make the case for surgery. Surgery doesn't seem to be well understood as a service in this country. I don't know about other countries. So we are scratching our heads. How do we make this possible? How do we make surgery known and accepted and supported the same way child maternal health is? So this very platform we're using is one of the things that's going to do that, we hope. And we have a couple of asks. The first ask we ask of you is to grant a National Surgery Day, which we shall use to make noise, good noise about surgery. Not banging tables, but good noise about surgery. And I remember you indicated that if there was acceptance from the Attorney General's office, it would be okay. So I took the advice, gave him a call, fronted this idea, and he said he has no problem with it, as long as he hears from you. So that's our first ask, a National Surgery Day, and we'll use this platform to make surgery known and supported as much as possible. The second ask, Honorable Minister, is this association is strong. Association of Surgeons is strong, but we have a feeling that maybe it's operating at a much lower level than it should. We know we can do amazing work, but we are encumbered by some circumstances and situations, one of which is all the surgeons here have a day job, so when it comes to putting together things like this, putting together camps, we struggle with finding the time. Instead of doing the main things, we're doing name tags. Not that name tags are not important, but we're doing name tags and doing those other things that are taking away precious time. So we have an ask of supporting our secretariat. We create a secretariat that does those other things that are taking our time, so that we can focus on the big things, so that our potential can be realized. And the permanent secretary yesterday indicated to us, and we are pleased to hear that the work the association does is not just for the association, but it is on behalf of the Ministry of Health. And we appreciated that comment very much. Once again, thank you very much for making the time. and I will invite you to address the association members.
Thank you very much. The President, the Association of Surgeons of Uganda, our esteemed medical professionals, implementing partners, visiting surgeons from Minnesota. I understand there are others from Zambia. My dear friend, Mr. Uma, I'm happy to see you. And the executive of the association, good morning to you all. It is a great honor for me to be here for the 2025 Annual Surgical Scientific Conference and also the 3rd edition of the Surgical Landscape Exhibition. Allow me to congratulate you for 3 years in a row organizing the surgical exhibition and the conference. I know it takes a lot. As the President was explaining, not only does it take resources, but it also takes time. And I was just commenting that you need to begin to hire event organizers. But I know you're going to look at me and say, provide the money. We shall discuss. Allow me to thank the Association of Surgeons for the very good work that you have been doing over the years. I was telling the President this morning that my husband, whom many of you know, he's also a medical doctor, he made a very nice comment. He said, the Association of Surgeons of Uganda is the most organized association in Uganda. Of course, I felt proud because I like to associate myself with the Association of Surgeons, although I'm not a surgeon. I felt good because I told him I'm coming here and he said, please tell them I deeply appreciate what they do. So we've been working with the association for quite a while now, and I was just saying that the work you do is highly appreciated, we value it, and you're not only doing it on behalf of the Ministry of Health, you're actually doing it on behalf of the government of Uganda and the people of Uganda. You have been working on having effective systems that work all over the country. It is not easy, but I want to appreciate the fact that you have visited regions, you have managed to attend to patients, you have reduced the backlog. It keeps on growing. Even when you reduce, it's like a drop in the ocean. Don't get discouraged, continue to do it. Because the number of people with diseases that require surgical intervention keeps on increasing for various reasons. And one of them is not very far-fetched, the numerous border accidents. I don't envy you because when I walk into Mulago, I see casualty filled with them every day. There are many others, the non-communicable diseases, including the cancers. I enjoyed the presentation because a friend just tested and was told she has a very aggressive cancer. And yesterday I was asking whether they are going to remove lymph nodes. Today I've got my answer. A very good answer, because I wanted this. I asked the surgeon and the surgeon was saying no. And I was asking why. Because I remember in my days I was taught that the lymph nodes have to go. Today I am going back, I think, with more knowledge out of this place. The heart diseases also need surgery, and we will have to take more bold steps to prioritize surgical care within our programs. The World Health Organization has been trying, but it may have to move a step back because of the current challenges of the executive orders and reduced funding, as they also move towards, narrowing the number of things that they attend to. But that doesn't mean individual countries or nations should not take the bold step forward and prioritize surgical care. We have had a number of discussions in this line with the association, and I want to request that we continue to have this discussion, because when you come, we have a discussion and you go away and you don't come back, and then we start fighting Ebola, we forget. So you need to keep on coming and reminding us until such a time that collectively together it will be a priority and it will have resources allocated to it. So on behalf of the ministry, allow me to sincerely thank surgeons from both the private and the public sectors for the work that you are doing. I made a comment earlier on and said, when you do the work, I take the credit. And I will continue to take the credit until God says, now somebody else has to come in and take the credit. I want to congratulate you on the exhibitions. I have had opportunity to attend two. I missed the one of yesterday. And every time it is amazing. Just like you said, Ugandans are not aware about the complex surgeries that you are able to perform. Recently, the cardiologists visited my home city and carried out closed heart surgery. And nobody wanted to believe that it is possible. Up to now, they are asking questions. Did it really happen in Lira Regional Referral Hospital? And I keep on saying yes, and everybody was saying no. So I took off time and went to the radio. And I said, you people, stop living in the past. Things have changed. Closed heart surgery is happening here. Brain surgery is happening here, thanks to the association. Because we no longer have to refer people when they have hematomas for brain surgery to Mulago. And that is the work of the association. You've gone ahead and built capacity. Allow me also to congratulate you on the capacity for kidney transplant. We are on the way. We are on the way to facilitating you. The council has delayed, but I want to give you a reassurance that in the very next few months, the council shall be in place to facilitate your work. You have a big undertaking to do. Apart from these conferences, you need to reach out to the population to understand believe and trust the services that you offer. I have a very big challenge as the minister when I get people coming and everybody is asking to be referred abroad, even for things that you are able to do. Because I have had opportunity to attend the exhibitions and also a few hours in the conferences, so I know, but the population are not aware. So everybody wants to be referred abroad, and it is not only annoying, but it also paints a very bad picture about our own colleagues here in the country, because people there begin to assume that you're not able to do such operations. And of course, it is a huge expenditure on the country, on things that we are able to do here, and you do them free of charge. So we have to work on disseminating information to all corners of Uganda so that people can be referred and they come with confidence, knowing that they will be given the best services ever, and of course, quality services. And the dissemination should not be limited only to the general population, but it should also filter up to the leaders. Because when leaders live by example, then the local man will follow. Right now, the leaders live by example, demanding to travel abroad, which is not what is desirable. I also want to appreciate you, all of you, those who have chosen to stay in Uganda. Many of you have chosen to leave to look for greener pastures. The bottom line is when you leave, then we cannot develop this nation. When you stay and work in the very difficult situations that you're working in, then you're contributing to the development of this nation, not only in terms of the economy, because when people are healthy, the economy grows, but also in terms of knowledge and building capacity. So allow me to appreciate all of you who have stayed, and to appreciate you for accepting to work in such difficult situations. But then the onus is on you. It is only you who can help government to improve the environment that you work in. It is only you who can bring to the attention of government the challenges that you're facing as an association in your workplaces. When you discuss with us, when you come out boldly and talk about it. I am glad that you have asked for a day. Just choose your day and it shall be granted. And I was just going to talk about a day. The nurses have a day. They have a midwifery day, which is different from the nurses' day. They also have a union day. And when they meet on their days, apart from having scientific discussions, they also take off time to lobby for things that they need to make the association and their unions stronger. The doctors don't have a day, neither do the surgeons, not even the pediatricians. So where have you been, is the question. Now that you have woken up, let's get that day. And we start moving out to the various areas in Uganda. As I conclude, allow me once again to appreciate you for the free surgical camps that you hold all over the regions in this country. My region was a beneficiary, and many other regions. When you go out there, you operate thousands of patients, thousands. And I'm saying thousands because the numbers are in thousands. Now that saves government a huge amount of money, huge amount. Of course we spend, and that is necessary. But the fact that you have saved lives, reduced the surgical burden, the families are happier. Perhaps it was a father or mother, the situation at home becomes better and they're economically productive, saves government a huge amount of money. I want to encourage you to continue and also to pledge that we shall work together to find better ways and resources to facilitate you to continue, because you're doing work for the nation. So as I conclude, allow me to call upon all stakeholders in government, private sector, partners, civil society organization, to consider increasing their investments in health and particularly in surgery. I also want to continue making an appeal to all of you to put more effort in capacity building for the younger groups that are coming up. The Ministry of Health values the partnership that we have created with the Association of Surgeons over the years, and will continue to strengthen that partnership for mutual benefit, but particularly for the population of Uganda. Lastly, I congratulate the leadership and the members of the Association of Surgeons of Uganda for organizing this very, very informative surgical scientific conference and also the surgical exhibition. I wish you all very fruitful deliberations. God bless.
Once again, please give a round of applause to our Honorable Minister, Dr. Ruth Acheng. And just before you take your seat, I'll be welcoming you to join us on a special panel that we're going to have with some other members. And at this juncture, I will also welcome other members on the panel, Professor Emmanuel Makasa, Dr. Ogwelo Uma, Professor Patrick Chamanywa, Professor Todd Tuttle, not Turtle. Please, if you're able to, we can come to the podium and take your seats as we prepare for the panel. We are going to be having a panel that is going to be discussing surgical access and advocacy. And I'm very glad it seems to be the topic, the running theme that keeps coming through many of the conversations that have been had. And we look forward to discussing and hearing a lot more from experts in this area. We appreciate that the minister is busy. As she moves, she may not be able to attend the panel, but I think her speech has answered some of the questions we were going to be asking her. Thank you very much, Honorable Dr. Ruth Acheng, and we appreciate your presence and you coming here. So we welcome the rest of the panelists.
Okay, good morning, members. Our panelists, you're welcome for this discussion. Before us, we have Professor Patrick Chamanywa. He's the Vice Chancellor, Uganda Matters University, Nkozi. We have Dr. Ahmed Ogwel Ouma, Senior Advisor, UN Foundation. Professor Emmanuel Makasa, he's the Executive Director, Center for Surgical Healthcare Research in Zambia. And Prof. Todd Tato, Vice Chair, Global Surgery and Disparities. And he's also the Registered Chair, Breast Cancer Research. You're welcome for this discussion.
Without further ado, first of all, the main issue we're going to be discussing in this panel is going to be looking at surgical access and advocacy and training in surgery. And all the members here are distinguished in this area. And I'll probably, just to start off, like to hear from Professor Todd. What do you think about surgical access on the global scale? We have been talking about it a lot during this conference so far. And yes, you've given us a lot about breast cancer surgery, but you are also quite conversant with the global surgery platform. And what is the global health policy for surgery, and what challenges do you think we face with its implementation?
Well, thank you very much. I think the major problem is time. And whether it is someone who gets injured on a boda, or someone who has a lump in their breast, or someone who has chest pain, of getting that individual with a symptom to a medical center, a well-trained medical center, in a timely fashion. And I think we can spend a lot of money on buildings and CT scanners and PET CT scanners, but I think the major emphasis should be on reducing that time to diagnosis and treatment of a particular disease. And it could be something as simple as a hernia. If a farmer has a hernia and cannot get it fixed, it cannot get it evaluated, he's not likely going to die from that hernia, but he may not be able to work. He may not be able to provide for his family for many, many months. And so I think strategy should really focus, a major focus should be on how to navigate patients who have symptoms to appropriately well-trained physicians.
Thank you very much, Professor Todd. And as you spoke about, as we talk about implementation in the Global Surgery Health Policy Program, yesterday we had a lot of interaction, and we heard from Professor Makasa, and he has some perspective on the African continent. And my question to you is, what progress have you seen being made in the area of global surgery in the region? You have been dealing a lot with the perioperative obstetric and anesthesia program, change from national surgical, and what perspectives do you have in terms of the progress being made with implementation of global surgery programs within the region?
Thank you so much. So we've made quite some progress, though sometimes it's not very visible. And also mostly because when we document this progress, we disseminate it to ourselves mostly, so not everybody may be aware. But I can put it in different categories. So when we look at governments, because they lead and they own the different countries and run the show, they are the strongest leaders we have, and they have a lot of power for convening and creating the space for other stakeholders to work in this field. So governments, and I'm talking the continent of Africa in its totality. So our governments have done a lot they've shown commitment by, first of all, prioritizing and putting the issue of perioperative or surgical care on the agenda in diplomatic engagements at the UN, at the different platforms where they meet, even within the continent. And they've made the political commitments, and these commitments are not specific to any political party. So to say, these are, for example, the Republic of Uganda has made those commitments, and they will run all the way through. So they've made decisions, resolutions, and they're also moving to facilitate the formulation and development and implementation of their national plans to ensure that there's a roadmap. So they've created the space, and also they've provided the roadmap for other actors to come on board. And then governments are also working through their intergovernmental platforms to do the same, to actualize these political commitments. So we have platforms like the African Union that is hopefully going to facilitate the anchoring of the Pan-African Surgical Healthcare Forum, or PASHEF, which is a continental body that allows Africans to deal with this issue themselves first. Most of the time, we've always looked outside Africa for help, but I don't think that in the surgical space we want to do that. We are happy with partnerships from outside, but we want to own this work and lead this work ourselves and tap into our capacities on the continent to ensure we can do this. There's WHO Afro, which is an intergovernmental platform of sub-Saharan Africa. Afro has already started working on this. They've created programs within themselves, and they are also developing a framework on improving perioperative care on the continent, as well as giving the correct guidelines in terms of the essential benefits package and, of course, the health benefits package at country level. We have other platforms like the EXA, WAHO, and the SADC. All are doing the same and are providing and developing the strategic plans. Then we go to the professional associations, different professional associations. Some of them are regional, some of them are national, like COSEXA, WACS. All these professional associations, the Uganda Surgical Society, are doing a lot to ensure that not only is expanding surgical services a big priority, as we're doing now, but they are also engaging all the other stakeholders, including governments, to ensure that this issue remains squarely on the agenda and also can be actualized. Let's not forget the academic institutions, universities, and NGOs are also involved. We have international NGOs, we've also got local NGOs. A few to mention: Smile Train, Kids OR, Mercy Ships, the G4 Alliance, the Global Surgery Foundation. The list is endless. These are doing tremendous work to ensure that they bridge the gap between the system and the community, and also supporting the governments. I think what's lacking now that we must try to work on is also the issue that the Permanent Secretary and the Minister just alluded to, of how do we engage the community. You can see all the people I've listed here are on one side of the picture. We need to work out and devise strategies and mechanisms in which we can now start engaging our own community. Our own communities don't know what surgical conditions are. They don't know what to do when they have a surgical condition, where to go. And also, they also have their own responsibilities as patients and as a community, and even the added value of receiving proper, safe surgery. So I think the community part is lacking, and we must accelerate closing that gap, because they are the beneficiaries of everything that we are trying to put together.
Thank you, Professor. You've made some very interesting remarks, especially about advocacy and coming out into the community. And I think the challenge we have is that as we sit here in the conferences, whatever we're discussing needs to come out to the public. I think the Minister has echoed that a lot in her speech, and I think that is a message that we seem to be coming out with in this conference: advocacy. No matter how well we're doing in the dungeons of our theaters, we need to come out and advocate for surgical services, as well as provide opportunities and increase awareness of what can be done to help our population. And you also brought out an aspect about the role of training. And at this juncture, I would like to ask Professor Patrick Chamanywa, who holds a unique position as being a vice chancellor of a training institution, being a surgeon, and also being involved in global surgery and leadership training and programs. And would like to hear some insight from you. What do you think the role of surgical training, what is the surgical training field now in Uganda, and how is it trying to address the challenges of surgical access and advocacy?
Thank you very much, our panel chair. Yes, training is a very essential component of the healthcare delivery ecosystem. However, it is difficult to quantify some of these things because we've not probably been intentional about what matrices we need to be capturing and therefore what performance indicators we are looking at. We are training surgeons. I'm getting an echo. We are training surgeons, we are training specialists, but probably we need to take a step back and look at a few things. And I would like to package these things into 6 Ps that we can all remember. As the teacher, I always try to digest these things to simple terms. So the first P is the purpose. What are we training for? Are we training to give people a qualification, or are we training to ensure that there is a gap that we are filling? And in so doing, what is the surgical workforce need in Uganda? Because I could say, yes, I've graduated 10 surgeons every year, but that cannot be good enough if I don't know the denominator. How many am I aiming to train so that the country can have the access to surgical care through the training? So that is important. And then the second P is the promise. As training institutions, what is our promise to the to the sector and to the population? Do we promise them a general surgeon? Do we promise them 10 general surgeons and 5 orthopedic and 6 neuro? What is the promise? Because it's until we know what our promise is that we shall be able to say, now we are moving towards what was promised. And I think putting that structure and that intention behind our training will help us measure our contribution to the access as training institutions. And so when you look at the product, the purpose and the promise, the third obvious one is the policy. As training institutions, we do open our adverts for people to come and apply for the training. But what is the policy framework like? When you train, how many should we train and how are they funded? Because if we leave it to the open market, to who can afford, then it's a throw of a dice. And if you get a 6 up, you are lucky. If you don't, you try again. But if we are intentional on the policy that we should fund so many surgeons in these different specialties every year, I think that will give us a better approach as training institutions. Because previously it was only Makerere and later Mbarara, but today we have 13 medical schools, and of these about 4 are giving postgraduate surgical training. But what is the policy guiding that training? Is it whoever can open a program should start? And if so, how many are we aiming and how many are we going to be qualifying. The other aspect with the policy is the deployment and retention. Because we are training surgeons, but are they being absorbed to where the need is, or are we all in Kampala? If I could ask here by show of hands, I know there was one from Kabale, but how many, and maybe Soroti? But what about the other regions? Where are those surgeons in this audience now? You know, and that shows you the deployment patterns, and therefore the need for a policy to determine that if so many surgeons come out, for the next so many years, they should be deployed at X sites. And after that, they can move freely. That will ensure there is a continuous supply of workforce to the hard-to-reach areas where the actual need is. When we do surgical camps, we don't do them in Kampala. We go out there. Why? Because we are very much aware that that's where the need is. But does the policy for deployment capture that so that the surgeons are where they are supposed to be? And then, of course, with that comes the rewards and the retention policy. What is driving many of our surgeons that we train every year out of the public sector into the private? It is largely on reward and retention mechanisms in the public sector. And so we as trainers, we could claim we are training many and therefore we are impacting, but we don't know if that impact is actually the real impact we should be looking at, just counting beans. Because there is a tendency to count beans, but not the nutritional value out of the beans. And that can be difficult. Of course, the fourth is the processes, how we train, the data we collect. The fifth I want to talk about are the premises. The premises, where are we training? And are we really adequately resourced to be training centers so that the training is going to meet the promise and the purpose? So if the premises where we train and also the premises where we provide surgical care are not giving us the basic optimal conditions, I cannot claim as a trainer that I'm doing good yet. Because we know even at the very core training ground, which we all at the country, as a country look at, and that is Makerere with Mulago and other affiliated hospitals. If you went in today and looked at the last week's surgical list and how many operations were successfully done and how many were canceled because of reason A, B, C, and the workforce to patient ratio, you will see that we still have some work to do. And that impacts on the training of the surgeons, the quality of the training. And then, of course, with that, therefore, the 6P is the product. So how do I guarantee the product if the premises, the policy, and the other aspects of the P's I've mentioned are not yet well aligned? So as a training institution, looking at it from a Vice Chancellor's point of view, those are the challenges that we are facing and having to mitigate every day to ensure that the people we train and our contribution as training institutions can actually mean something to the sector. And to sum it up really, this, like the Honorable Minister said, should be looked at as a public good. Surgical training is a public good because surgical care is a public good. And just like we see the government has never asked anyone to pay fees to join the army. You don't even pay fees to join the police. But we know that law and order and defense are just as important as a healthy population. And that's why I still would have asked the minister to continue helping us to reach to where this has to go, that education, health, security, and law cannot be put out to the competition. These have to be gazetted as public goods, and therefore funding has to be deliberately directed to these four sectors: education, health, law, and defense. Because that's what builds an economy, that's what ensures the well-being of the citizens to be productive, and I think that's where the training institutions would now come in at the production end and be able to give the promise that we give the population. Thank you very much.
Thank you very much, Prof. Chiamanywa, for those insightful deliberations. This one goes to Prof. Todd. Many times we've heard that surgery is a stepchild of global health. How can we advocate for surgery and surgical access to be an area of focus on the global health table so that it's no longer a stepchild?
I love your comment, and the stepchild quote obviously comes from the late Paul Farmer. He made that comment in 2008 because at that time, global health was dominated by infectious disease, malaria, TB, HIV, very important, and surgery was neglected. By 2015, 7 years later, Dr. Farmer commented that surgery was the most exciting frontier in global health. And I think things changed for multiple reasons. One is that we're able to show that surgery isn't as complex as we really think it is, and that it is economically feasible. By fixing someone's cataract who cannot see in Guatemala, they can now go to work, they can now function, they can now provide for their family. Preventing a breast cancer death or a cervical cancer death, as Professor Moses has shown, can prevent children being born and raised as orphans, which again leads to economic despair. And so I think those are some of the economic drivers of surgery is what should really be emphasized. I think it saves lives, it improves lives, it's economically feasible, it's good for the finances for the individuals, it's good for the finances of the country. In the United States, what I have found is that global surgery is being led by medical students and residents, and that is very exciting news. Very young people. I started in global health mid-career, but these individuals are starting in their 20s, and it's very exciting. I think we need to continue to push for advocacy. It's been talked a lot about today, and I think that if we could just make this argument that surgery is not as complex as we thought it was, that it's being led by young people, and that we can save lives and add to the economy of each country. And I think it'll go a long way.
Thank you, Prof. Todd. Prof. Makasa, if there is one thing I've taken from your messages you've been giving us since yesterday, is the fact that we are not engaging all stakeholders in advocacy for surgical services, especially the community. And the question is, how can we effectively engage all stakeholders in surgical advocacy so as to accelerate achieving the targets that have been set for 2030?
Okay. Yeah, so first of all of us must get involved. we all must get involved, and we must bring as many people as possible on board so they get involved, because the more we are, the more we can convince more people to come on board. So it's a snowball effect, and all of us can play a role in our little way to ensure that we can get more people on board. But this means that we have to be inclusive in our advocacy work. We must include everybody, not only, like I said, preaching to ourselves, preaching to the choir, like they like to say. We must go outside our comfort zones and include even those who are receiving surgery, because we can't be pushing the expansion of surgical services without understanding the concerns of those who are to receive surgery. Unless we can make it valuable for them, we can build as many hospitals and stock them up with everything that they need, and still the problem will continue, because those to receive the care are not going to come. They are worried about pain management. They've got myths and mysteries and theories about surgical care. They're scared of death and poor, bad surgery. They're scared of the complications coming out of surgery. They are worried about the expertise and skill that we have as surgeons. We must understand their concerns and their needs. And also, we also must engage them in a diplomatic, respectful way to educate them on their roles and responsibilities. Because the community, the patient, also has their roles and responsibilities that they must perform for this to work. So let's be inclusive, and then, like I said, the advocacy message should be targeted and customized. How we are going to advocate to the Minister of Health is not the same way we are going to advocate to the patient. How we are going to speak to each other is not the same way we're going to speak to, say, for example, other cadres that are, you know, my colleague here was presenting breast cancer. We all followed very easily because we understand the language, the words he used, the terminology he used, we understand that. We can't do that for the patients. If he was going to talk to the patients, he would have to use a totally different language. He may even have to use the local language so that the people fully understand what he's talking about. So we must customize our message depending on who we are targeting and use the appropriate language. We must leverage communication channels and platforms. And now we're living in an age era where I can talk to my kids with my phone. When I was in medical school, this was not possible. So we have technology now, and there's a lot of social media platforms where all the young people and everybody is. Are we using those platforms to pass on the correct message? Because it's not expensive anymore to talk to the whole world. Even from here, I can speak to the whole world. Nobody can restrict me. Previously, it was almost impossible to do that. So are we using these new technologies that are available to us to pass on the message? And then, above all else, there should be a value to convince somebody to join you or work with you or partner with you. So let's not always look at only what we get out of it. What does the other person get out of it? So we must think like that. If there is a value proposition, if we can convince others of the value of having safe, affordable surgical health care that is timely for everybody, then of course, the momentum will keep building.
Thank you, Prof. Makasa. This question is for Dr. Ahmed. The African region, especially sub-Saharan Africa, is underserved in so many services, including the surgical services. How can the African region increase advocacy for surgical care on the global health platform?
Yeah, thank you. Thank you, moderator. I would say we divide the approach for advocacy to the different target groups that will support, facilitate, and deliver on this very important journey that surgery needs to walk in the global health space. And I'll start with the politicians. This is where policy and resources usually end up being decided upon. Politicians' half-life is just as long as one election to the next. So we don't go planning for 20 years. You lose them, and therefore you lose your advantage, and most probably you lose the ask that you had. And politicians, we deal with them at national level and also at the regional and continental levels. So if we have a political message that needs to go out, then we need to see what is it, and there are very nice messages being given to the minister here, and some she's acceding to immediately. I wish other ministers will be that forthcoming. It will be a lot easier. So we deal with those that are national, but this is global surgery, and we need to go beyond one country for it to be able to work effectively. Because if one country is doing it well and the next is not, the whole concept of global surgery then does not become successful. So where do we get the politicians at the sub-regional and continental levels? Those platforms that Emmanuel had shared here, whether they are sub-regional or whether they are continental, or whether they are based on certain interests within the continent of Africa. But we need to get to the politicians, and the message needs to be consistent, which brings me to the second part of our advocacy. We should not leave our advocacy within one country. It is so important that what Uganda is doing is being shared with the neighbors, Kenya, Tanzania, South Sudan, etc., so that the professionals on the other side of the border are also doing the same. And that way we start mobilizing a different type of resource. It becomes the resource of consistency, that whichever platform you're talking about, global surgery, the messaging is very consistent irrespective of the country where you go. So when our policymakers go to any platform, they get the same message. And that consistency in messaging is so critical that I would encourage, as we continue to advocate within Uganda or other countries, we be in touch with our colleagues across the borders so that they too are doing the same thing for advocacy. The third is now related to unlocking resources through advocacy. And resources, yesterday I was saying, many of us think of money when we talk about resources. But in global surgery, I think money comes, for me, probably number 4 or 5. Because one of the biggest challenge is the facility. And I think, Prof, you're very clear about the place where the training is being done and then the actual service is being offered. When one country, for example, has this new technology that they have procured and they are using, then the neighboring country doesn't have to go all the way to Minnesota to train. They need to come across the border into Uganda and make sure that that technology is not only being used, but also it becomes a lot cheaper for the neighboring country to come into their neighbor to learn and get used to some of these new technologies that are coming up for purposes of global surgery. So the resources that we have, we share. And when the time comes for money, then also we do it in a coordinated manner so that the messaging is consistent and those who are given the responsibility of allocating resources can be able to allocate what is appropriate. Finally, in as far as advocacy is concerned, is the advocacy of the seniors to those who are coming after them. Many times we don't get to the stage of making the younger generation be interested in this case, surgery. And from whichever angle, whether it is the surgeon or the anesthetist or the nurse, and many others who are involved within the surgical profession, how do we make sure that the advocacy results in another new wave of professionals filling in the shoes of those who are becoming more senior and who are leaving the scene for one reason or the other? That way we get consistency in the delivery of the service, because they are those that we are passing on our knowledge, our skills to, and global surgery then remains an important part of delivery of services in a country. These are some of the issues that I will bring up in as far as advocacy across borders is concerned. Thanks.
Thank you, Dr. Ahmed. With those remarks, I'm sure many of us are encouraged to go out there and advocate for increased access to surgical care. Though many times we may start, but because of the uncertainty, the worries about the challenges, we may pull out. So Dr. Ahmed again, what challenges should we anticipate as the surgical fraternity in Uganda when we go out to advocate for increased access?
I think that the challenges have been very well shared earlier on, especially by the president, but I will stick to three that we need to be very awake to. One is lack of information about what we are doing as surgeons. The fear factor that you're going to be cut open is, at least in the African context, it conjures up a lot of negative images. And that challenge, the president had already shared that, and the minister as well, the actively engaging the public to know what you're doing is extremely important. Now, apart from the public, it's also very important that other professions outside of the surgical field are also educated on what happens in surgery. I think there was a colleague from internal medicine who was saying that surgeons don't like writing notes. There is need to share within the medical field. There is need to share within the healthcare sector. We have cadres who are not medical and they're still within the healthcare sector. That way they understand what actually happens within surgery, and that those misconceptions can be able to be addressed by sharing that information. This is one. Second challenge is going to be, how do you reach critical mass in as far as numbers are concerned, so that the services being provided reach an acceptable standard. Right now, the numbers are still so small that trying to achieve good quality delivery of services at the peripheral level becomes very difficult. And for me, we can be able to address this challenge through technology, where you have younger professionals who have been trained to a certain level. They may be deployed to a more difficult place, and then using technology, telemedicine, for example, more qualified experts can be able to walk them through some of the more difficult surgeries, and you get services being delivered in a more efficient way. So trying to get to that critical mass is going to be very, very crucial, that we find innovative ways of providing support to those who may not have reached the level of expertise that is required. The final challenge that I see is the capacity of our facilities to be able to provide confidence in the public. Are our facilities being looked at as a place where if you go, you get treated, managed, and healed? Or our facilities being looked at as a place where if you go, you don't come out, especially if it's going to be a surgical procedure? And we do that by first addressing the work environment in the facility. If I walked into a facility, a health facility, does it look like a health facility? Or is it run down, the walls are dripping of paint, the roof is leaking, and can we be able to ensure that our facilities give the confidence of a health facility before even someone gets in to ask what kind of services can they be able to get, and how those services are comfortable for the individual who is looking for that particular service. So this is within the realm of government and the experts that we design and improve the outlook of the facilities based on the level of care that they provide. And then when you populate it with experts, it becomes easy for members of the public to be able to gain the confidence that if I walk into that facility, I'm getting a service, surgical or otherwise, that is going to ensure that I get healed from whatever it is that one has. This is the three that I will be able to share now. Thanks.
Thank you very much to our panelists. At this juncture, I think in the interest of time, we'll only allow two burning questions from all of us here to our panelists before we close this session. I think there's somebody moving around with a mic. Yes, Dr. Kasaga.
Thank you so much, the panelists, for that interesting discussion. My question is to Professor Chamanywa. And I think Professor Makasa yesterday shared their Zambian experience. And I was reading about the Rwandan ENSO process. They got students and residents very interested in the ENSO process. So my question is that how are universities, for example, departments of surgeries, how are they going to position residents and medical students to kind of champion global surgery and, for example, the ENSO process? Allow me to also give a comment that I work with Incision Uganda, a national working group with global surgery, and as you've heard yesterday, we had many students and residents who are presenting on global surgery. And of course, the minister yesterday said that they will set a date, but my understanding from such meetings is that you'll have maybe a few delegates from ASAO, and maybe a paper will be presented. But we as students and residents would love to get involved, for example, in the data collection itself, probably giving us research ideas as residents, in topics for dissertation that can feed into the process like the ENSOP. Yeah, thank you so much for the discussion.
Thank you. Thank you very much for the discussion. My question goes out to Professor Tuttle. My name is Alice Katerega. And what your experience has been, or your take on the pitfalls surrounding the engagement of community and use of social media as regards management of breast cancer. I'll just give an example about the recent developments, or in the past couple of years, where prophylactic bilateral mastectomy seems to be becoming more popular and has been put out there, fronted by certain celebrities that I won't mention. So in people who have BRCA1 and 2 mutations, what is your take on how we address these pitfalls as scientists? Thank you.
That's a great question. I don't have the answer. I spend a lot of time in my practice talking women who have small little tumors that could be treated with a lumpectomy, a 1-hour operation, go home with no drains, no narcotics. I spend a lot of time talking them out of a double mastectomy with reconstruction, which provides no cancer benefits, and it's a longer operation, more short-term pain, more long-term pain, more complications. It's hard. Social media and the media. You know, a celebrity is diagnosed with some sort of cancer or some other illness, and they decided to go down some pathway, and a lot of people will follow that. And a lot of conversations that I have with women with breast cancer will tell me, my friend said I should have this, my cousin had this and she's still alive, someone told me not to do that. So we are constantly trying to inform our patients as best as we can. And I appreciate your comments about how we talk to patients and the words we use and how we explain things to patients. And I think, as a physician in this era, I just don't think there's any substitution for time. It's just spending time with the patient, figuring out where misconceptions may be, try to right those misconceptions, and try to provide patients with the most accurate information they can have to make a treatment decision. But you're 100% right. We're often battling with social media and friends and celebrities about how they had their particular cancer treated or how they had a particular diagnosis and treatment for other diseases as well.
Chair, probably if you permit, I could also answer to Brian's question on the NSOPs and the students and how we see our participation. Yeah, as universities and training institutions, one of our roles is to create knowledge, create evidence, and influence policy and practice. And that is through the research arm of our mission. What we need probably to look at is how we position ourselves, and that has usually been the challenge. How do we position ourselves to be seen as credible advisors to the policymakers so that we can attract the funding to conduct this inquiry in terms of research and other elements, and then be able to inform the policy process. We are trying to do that, and what we need to do now as students or as advocacy groups is to team up. We need to team up so that it's not an individual effort, because when you organize, you get the audience of the people that you want to reach. When you go solo, then we do not usually raise the response that we need. So what I would advocate for is that as an association, we do have representation in the different training programs that we know, and form that body that can generate discussion with the ministers and the other leaders in the sector and ask them the questions they want to answer, first of all, so that we can take them on as universities through the association. And that will be able to provide credible continuity and evidence. Because there is a tendency to hire consultants, but that goes at a very high cost, and also normally the consultants have a given tailored language. They can write your report in 3 days, but not that they have actually done the depth, because certain things, just like we do in machine learning, certain things tend to repeat themselves. So you say, the answer to this problem must be ABC, and you will write the report, but not that you've gone to the actual ground. But as training institutions, there are opportunities that we can even assign residents and other researchers to the task, not only to inform the policy, but also for their own academic growth. So there will be a lot of benefit. So if we organize and be intentional about it, I think that can work. And we can see students participating. We can also be the initiators of the research. Because, yes, the ministers and the leadership could have the questions, the challenges they want answers to, but we can also be able to preempt through other research and be able to sell this to the government. Now, what we need to do then is to learn how to engage the policymakers to buy our evidence. Because a lot of research is presented, and we are going to have a lot even today in this scientific conference. But how does this get translated in a half page or a one pager to the person who will drive the policy to impact that evidence or to be impacted by that evidence? Normally, we have ended up not doing that because as soon as you've got your M.Med or your PhD, you are comfortable and you are happier to say, I have got so many publications. But and so what? How many of these publications have translated into policy and practice? How many of these publications have been cited by any other researcher? I think that becomes the metric now that we need to be measuring, instead of how many publications per se you have put out, because you could easily have 10 publications, but only one has been cited and cited only once by your fellow student. So what's the impact then? And so how do you convince the policymaker that you will be able to provide them the evidence and therefore you are a credible partner in this environment? So I think those kind of things have to be considered, but to underline it is to associate. We need to organize ourselves, be intentional. Fortunately, our president is an ardent researcher, so I'm sure we can come up with this kind of research body central to our soul, but having the players in the different training programs in the country and being able to determine the research agenda and also the policy framework. Thank you. And that would then bring in the NSOPs and any other aspects. Yeah. Thank you.
Once again, I would like to thank our very distinguished panelists for that spirited discussion about advocacy. And I think what you can take home from here, I won't give you the opportunity to give your take-home message. I will take that opportunity. And first of all, each one of us here is an advocate. We're an advocate for the surgical fraternity. We're an advocate for the patients and the people in the community that we live in. So from the P's that Professor Chamanya talked about, within this room we have the product, we have those who are in the process, and we know that at the end of it all, we also have the context within here, Uganda, but we've also got a view of where we fit in the whole picture within the region and within the world globally. So don't think that whatever you do here is just within your small microcosm, but whatever you do, think about who you're representing and don't forget that you are an advocate for better surgical services. And at this juncture, please give a big round of applause to our panelists and to my co-chair, Dr. Luwede, and thank you all. And before we leave the podium, we request for a group photo.
Thank you so much. The chairs of the previous session and our panelists. We're going to proceed to the next session. I would like to invite Professor Patrick Chamanywa, who is the Vice Chancellor of Uganda Matters University, to come and take on the next session. Professor Chamanywa, you're welcome.
Thank you very much. Good afternoon again. I hope everyone has had a cup of coffee or tea or something to keep the systems, the physiology running. But we've also been seated for a while. Maybe let us get up and just turn around 360 and sit again. Just turn around, making sure every turn is a step that you take. Yes. 360, 360. Yes, let us improve that Venus return, yeah. Okay, now you have earned yourself a seat. Thank you. You can sit down. Yeah, as we wait for our keynote speaker, I would like to draw back to the program. And I realized that we missed a talk, but now I don't see the lady with the colorful headgear. Okay, she's here. Yes, I would like to invite Dr. Olive Kovsinje to the stage before I start my session, because I know that your talk is quite informative to my session as well, and that is taking stock of surgical practice in Uganda. Are we there yet? So if you're ready, please come to the podium. And while you come, I will go through the rundown of the next speaker. So after Dr. Olive, we'll have a keynote address from Dr. Ahmed Ogwelo-Wuma, who will speak to us about building surgical capacity and resource mobilization for surgical care in Africa. Following that, we shall have 3 short publications, 8 minutes each, because I know I'm standing between you and lunch, and I don't want to see people getting angry faces. So let's invite and welcome, join me to welcome Dr. Olive Kovsinje, who is an author, a philanthropist, a nature lover, when she's not in the surgical mindset of trauma care. So she's welcome to address us. Thank you very much. Yeah, can we please upload the presentation by Dr. Olive Kovsinje?
If they don't have it ready, maybe somebody else should come, and then, I don't want to, because I know we're running out of time.
Are we ready to upload? Dr. Kakungulu, were you able to share the presentation with the audiovisual team? Okay, so for the interest of time, let's allow Dr. Olive to do the sharing while we welcome our keynote speaker, Dr. Ahmed Ogwel. Please come and speak to us, especially on something you do very well as at the UN Foundation, and that is resource mobilization. We are eager to listen to that. Thank you very much. Please welcome Dr. Ahmed. I'm sure he was introduced yesterday, so I will not bother to do that again. Thank you. Welcome, sir.
Thank you very much, Chair, and good. We were not asked to adjust any time today, so I think we stick with it must be good afternoon at the moment. So time is a little bit short, but I must thank ASO through you and your whole team for inviting me to come. And of course, for making all the arrangements for this very lovely event. And I hope that as we get into the third day tomorrow, things will only improve in terms of the deliberations in the corridor and, of course, the presentations here as well. It's not easy organizing a scientific conference. And when one is organized and the weather decides to do what it has been doing and still we are here full room, then really I would ask for a big round of applause to the team and to ourselves for making it here on the second day running. And then the consistency. I'm told this is the third with the exhibition, but the other one is number 20. Yeah, so doing this for the past 20 plus years is not a mean achievement, and we look forward to the next 20 years of success. I must, however, say that global surgery is a growing field, and as it gains momentum, it is really gratifying to see that it is not only gaining momentum where surgical practice is cutting edge, it is also gaining momentum here on the continent of Africa, where although we struggle with facilities, with expertise, with consumables, we struggle with policy, we struggle with patients. Many times we struggle with resources of different types. Global surgery is taking root and is growing and becoming really an essential part of global health. And for those of us who are practitioners of global health, it gives us a lot of pleasure to see the kind of growth that global surgery has been having over the last few years. So I really encourage ASO leadership to continue to grow the interest in global surgery here in Uganda and reach out to your colleagues across the borders on the continent of Africa to ensure that this growth is sustained in an effective way. Africa, unfortunately, has been bearing the greatest burden of disease and illness, yet the continent has the least access to the relevant services, to experts, to tools, to infrastructure, and to training. Our continent is not only underserved, therefore, but it is also in crisis. A crisis that needs to be addressed quickly and with determination so that we can achieve more for our people and also for global health. This crisis can only be addressed if you and me are part of thinking through the innovative solutions that this continent really, really needs. Just before the pandemic overwhelmed the world in 2019 or thereabout, the Africa Union called for a new public health order. Our heads of states, 2 years later, at the UN General Assembly of 2022, they made a formal statement calling upon governments, multilateral organizations, philanthropies, the private sector, and civil society like yourselves to support the full implementation of Africa's new public health order. This new public health order has 5 pillars, and I'll go quickly through them. One is strong African public health institutions, whether they are for training, whether they are for research, whether they are for intervention, whether they are for resource mobilization, doesn't matter. The first pillar is strong African public health institutions. These institutions will then represent the African priorities at the global level and ensure that the continent can be able to achieve its priorities within global health. And we can stage that to say within global surgery. The second pillar is investment, indeed increased investment in health workforce development. This will ensure that Africa has the experts that it needs to address the unique health challenges that the continent actually has. And this second pillar fits in very well with the theme of this session, as well as the theme of the conference this year. The third pillar of the new public health order is expanded manufacturing of all types of health products, whether they are vaccines or diagnostics or therapeutics, or whether they are non-pharmaceutical products. This will ensure that Africa has increased autonomy when it comes to planning and action for healthcare services, indeed for any health emergencies that may reach the shores of the continent. The fourth pillar is increased domestic investment in the health sector. We all are experiencing, one way or the other, the very difficult situation we are in with reduced ODA from many development partners. Indeed, the many executive orders that have made sure that a lot of the work that has been going on the continent of Africa in global health have been stopped. That's why this increase in investment, in domestic investment within the health sector is critical for Africa to be able to continue to maintain the indicators that have been growing very positively over the last decade or so. But domestic investment is not only money. It includes expertise, and we've been talking about that today a lot. It includes technical resources, whether it is machines or whether it is knowledge, or whether it is facilities, institutions. We need those resources to be part of what is invested locally. It includes infrastructure and networks, and of course, financing itself. But Africa, under this fourth pillar, needs to increase domestic investment within the health sector. Finally, the fifth pillar is respectful and action-oriented partnerships. Partnerships that are there to advance Africa's priorities in health delivery. And in our case, partnerships that actually advance global surgery here on the continent of Africa. The recent developments in the global health financing space are a vindication that we need to fully implement Africa's new public health order. Although this was conceptualized and advocated for before the pandemic, now is really when it is being felt for the need for implementation of this new public health order. When fully implemented, the continent will progress faster when it takes full responsibility for the welfare of its people, when it takes full responsibility for the health of her people. Africa will certainly develop better, faster, when the health sector is within the purview and capacities of the African continent, her policymakers, her experts, and the resources that are there within the continent of Africa. Domestic investment in health should therefore be the primary source of resources that goes into the health sector. Any further support that may come thereafter from friends and partners of the continent will be in addition to what has already been locally mobilized and what has already been locally secured. But how do we get to build surgical capacity, and where can we be able to mobilize the required resources as I have been asked to speak about? Let me make a few suggestions. Number one is building confidence. We must have, and this is the way to build the surgical capacity on the continent of Africa. Number one is building confidence. We must have the public appreciate and understand that we have the relevant expertise, the capacity, and indeed, Uganda in this case, but any other African country would fit very well, that there are plans in place to grow that capacity to ensure that we continue to handle most of the surgical cases that are required by our citizens. The best form of building confidence is experience. When that patient or that client walks into a facility and they are well handled, when that patient, that client, lies on the table, wakes up, and some of the problems that were facing them have been surgically addressed, then they can be the best advocates out there to say that yes, that facility, that particular surgeon, that particular team have the capacity to be able to address the challenges that are being faced by the citizens in that location or in that country. With this increase in public confidence, we will therefore have more of our people placing their health, indeed, their surgical needs in the hands of local experts, and with increased visitations and with increased participation of the public, we will have our facilities becoming more and more experienced and adept at addressing the surgical needs of our society. So that confidence building really needs to come first from us, not just communicating it by word of mouth, but also handling the patients and the clients in a certain way that makes them want to go out there and say good, positive things, and we don't end up with so many wanting to go abroad for relatively minor surgical procedures. The second is documentation. The medical field is unfortunately very poor at documenting what we do. We do very good work, but we never go out there to say that we are doing good work. I guess we are so busy doing the work that at the end of the day we are tired, we go to sleep, we wake up, and some of the good work that we have done become public when there is a crisis. We need to stop that and document what we are doing effectively and share all that good news and good information with everyone who needs to know about it, from the public to policymakers to possible partners, to the private sector who need to be making more contribution to the work that we are doing. People need to know what we have done and how it is impacting positively on the lives and the development of our countries and our continent. We also need people to know what we can be able to do and how much of all these different surgical procedures can be done within country without having to go out. And of course, what the cost of that is going to be to them, and they compare that with going abroad, and hopefully many more are going to stay behind. Let's document and share to let people know what we can be able to do. Thirdly is homegrown training, how we are going to be able to build the capacity. Training outside of the country in some circumstances is welcome, but a lot of the training that is required all the way down to the lowest level of facilities can be able to be done within the country. If it cannot be able to be done within one country, then it could be done in a neighboring country where travel and upkeep is much less than going many thousands of miles away, depending on the complexity of the training that needs to be done. So if we diversified the facilities where we can be able to have these trainings being done, if we improved on the work environments so that our regular facilities can be used for training as well, we will be reducing the cost and we will be building the capacities a lot faster, because a certain amount of money invested will train many more of our experts rather than going very far and you find very few people are being trained. So by having homegrown training, where home is within the country and the immediate neighboring countries, we can be able to train more people, more experts to contribute to the global surgery targets that we are setting for ourselves. Fourth is to regionalize certification. I think the East African community has this already in place. If you're trained in one country, then you are eligible to work in another country. That means that the cross-border training that I was speaking about earlier becomes not a barrier, but it is easily facilitated because our countries have already gone into regionalizing certification. When you've been trained in one place, you can be able to work in another, and that increases the chances of improving the numbers of those that we need to be trained in as far as global surgery is concerned. Fifth is benchmarking. We benchmark with both those who are ahead and those who are behind. Don't benchmark only with those who are ahead. When you benchmark with those who are behind, you become the source for them to come for training to your place. When you benchmark with those who are ahead, then you get to know where you can be able to improve yourself. But don't forget that you also need to be making yourself available to improve others who may be doing a little bit worse than you are. And if we benchmark these facilities, if we benchmark our facilities with a much more complex facility elsewhere, then you find the gap is so huge, sometimes you start getting discouraged. But if you benchmark yourself with facilities that are not too far from you, then you get encouraged that I can actually be able to reach that next step. So let's benchmark locally, even as we aim to benchmark with those who are really, really advanced in many steps ahead of us, and we aim for that progressively. Finally is mentorship, the way to increase this capacity relatively faster. We need to mentor the younger generation who are willing to be part of global surgery. We need to encourage those who have not yet made up their mind to come into this field so that we are constantly getting the numbers to be more and more, because the population on the continent, and including here in Uganda, is increasing, and we need more people. By mentoring the younger generation, we ensure that tomorrow we have more global surgery cadres and experts than we found it in our own times. Colleagues, resources are a critical part of what we are talking about. And we cannot be able to increase the numbers, as I've described here, unless we do have the resources and they are accessible to us. I'll suggest 3 ways in which we can be able to secure these resources progressively. Number 1 is through government. And I start with government because the real responsibility of growing service delivery rests with the government. Governments can do this through scholarships, because some of these areas are specialized. The basic training had already been done. Governments can be able to do this through providing facilities that can be used for training. And governments can also be able to do this through mobilizing extra resources themselves from partners that we may not be able to reach on an individual basis. As the PS was saying yesterday, the development banks, for example, could be a source of that. Surgical practice, it's a specialization. And since the government is a big employer in this context, it is crucial that it invests in all the different cadres, not just the one who is holding the knife to cut, but everybody else who is involved in providing the service in as far as global surgery is concerned. And engaging with the governments early so that they understand where you're coming from and where you would like to reach will ensure that in their future budgets, they can be able to accommodate your requests for more and increased resources. So this is one, where we can be able to get the resources to increase global surgery in as far as training is concerned. The private sector, and especially the local private sector, they are many aspects of the private sector that can be able to improve training for us to reach our global surgery targets. For example, private health facilities would like their staff to increase their skills and knowledge. They will pay for those staff, and that resource can be used to improve and deliver on specific training, including for those who may be coming from government facilities and do not have the full access to resources as the private health facilities will have. So private health facilities can be a source by paying for their staff, and those resources can be used to improve on the training that we continue to give. Private practitioners as well not necessarily attached to any health facility. If they want to improve their skills, they too will be able to pay for these trainings. And faith-based organizations will do that as well, especially those that are running health facilities. Any private sector person who needs to improve on their surgical skills and they are willing to make that payment, then they should be encouraged to do that so that we can be able to get this, the initial funding that is required to keep this training running. And in fact, if we broaden the private sector to include donors, those who are not in the health sector at all, telecommunication companies, banks, different types of industrialists and manufacturers, we need to encourage them to support the process of training for global surgery so that services to their market, services to their clients are eventually improved. And in this way, the private sector, especially the local one, can be a very good source of those funds that we need so badly. Finally is the non-local donors. The non-local donors is probably the most straightforward. Many times we look at that particular category as the one that is the most difficult. In my experience, it is not. The most straightforward are the non-local donors, where those who have had a little bit of experience in engaging with the international philanthropies or international organizations that provide resources. If you have a good idea, you write a good grant, that is the beginning, and that usually is about 30% of the effort. In my experience, money is never given to strangers. So you need to stop being a stranger. And you stop being a stranger in two ways. One is you get to know the right people, and I think the networking that you're doing here is already good enough. And when you know the people and your interest in securing funding comes to someone you know, it is looked at completely differently from if it was someone that you don't know. The second way of stopping being a stranger is being involved within that area of expertise and work. Within global surgery, it is a growing field. Let's be part of it. Let us know who are those who are engaged in global surgery, which institutions, which organizations, and they get to know us and our work. And in that way, we reduce the gap of being a stranger. And for me, the non-local donors, so long as we organize ourselves well, and ASOW is here to be able to coordinate some of these grants that need to be written, we would be very willing, some of us, to knock on doors with yourselves so that we get the seed funding that is required. And for me, it is just seed funding because it will facilitate the beginning of a process, and then what we can mobilize locally is going to be the real resources that we need in expanding the global surgery program that is hopefully going to take a very good root here in Uganda. And as I conclude, and in case you did not get all that I have said, I invite you to remember these 5 things. The first is that the practice of global surgery is not only important, it is an essential part of global health. It is an essential part of global health. So let us expand the knowledge in global surgery and include it in our daily work. This is one. Second is that there is urgency. There is urgency in fully implementing Africa's new public health order because within it are very critical areas of improving our health workforce, improving our institutions, and mobilizing local and domestic resources. So implementation of that Africa's new public health order is particularly critical. Third is that building surgical capacity should be a local and a regional effort where communities of experts, where communities of countries can be able to come together, pool their resources, and get global surgery to be better understood. Then when we get support from outside, it will be based on the priorities that we've already discussed and set for ourselves. We need to have regionalization of these communities so that we work together with people who are relatively closer to ensure that our numbers can increase, hopefully exponentially. Fourth is mentorship. It is the core part of developing a sustainable global surgery program within a country and within this continent. Let us mentor those who are from behind, and let us look for mentors who are going to hold our hands for us to be able to go further. And finally, finding resources to build the capacity and sustain a successful surgical training program is both a domestic and a global affair. Let us do both. Let us not do one at the expense of the other. Both can be able to work, and as we continue to expand our networks, let us ensure that not just Uganda, but indeed the whole continent of Africa will build and succeed in increasing the local passion for global surgery, and will increase understanding and therefore resourcing of this very important area. And therefore I urge myself and you, individually and collectively, that we increase this passion amongst ourselves and those who may not be here but need to hear about it. We increase that passion, and collectively we generate the momentum that is required for this effort to succeed, because together we can be able to do more. Thank you very much for the opportunity.
Wow, I think that was a mean applause. Let us do it better. Thank you. Thank you very much, Dr. Ahmed. Indeed, this is coming from a man of great experience in doing what he's talking about. And I think you've just made it sound like you were my mentor when I was reading about decolonization. Decolonization has 4 phases. The first is rediscovery and recovery. So we need to start discovering ourselves again. The second is mourning. I think we've done a bit of mourning about what is not working, what should have been possible. And the third is dreaming. We should be free to dream of the desired future. But what you are urging us to do today are the 4th and the 5th steps. That is commitment and action. You are driving us with the public health order to take action. Stop mourning, stop dreaming, and commit and take action. So I think we are now well advised. And the other thing that I take from your call to us to action is homegrown training. I returned last night from a conference in Rwanda, in Kigali, about medical education, advancing medical education in Africa. And that was one of the things that was still sounded there. And Rwanda gave us a good example. Rwanda has launched what they've called a 4x4 reform. It was launched in 2023. And they are trying to quadruple the human resources for health in Rwanda in the next 4 years. It's an ambitious call, but we know Rwanda to be ambitious also. And they have done that in many ways. But one of the fairly brave acts that I saw was they are stopping missions, foreign missions, to come to Rwanda. They want you to come with the trainers and work with Rwandans so that you can pass on capacity. Not come in, do the cleft slips, you've come with your team, there's no Rwandan around you, and then you leave them to manage the patients with no capacity. They're saying, if you want to do work with us, bring your team, commit to stay, commit to visit regularly, and come and train as many Rwandans as can be accessible. Yesterday we were told Rwanda is now having success with 64 kidney transplants in the last 1 year. And that's because the teams were brought from wherever they were, and they They were in Rwanda to train Rwandans on how to do kidney transplants. Today they are doing that. They are now stopping the cardiac missions. They have come in to do the training locally. And you talked about regional coordination. They have actually brought in specialists from the region, from Ethiopia, from South Africa, from wherever, who are now stationed in Rwanda and doing the local training, in-country training, so that more people can get exposed with that volume. So I think the examples you are giving are really very good. I liked the example of the resources, thinking outside the box. I think, Mr. President, we should talk to Airtel and MTN to see if we can have an MTN surgical access scholarship so that they can sponsor maybe 5 people to go and do a fellowship in hepatobiliary or whatever. Or get one of these wealthy, previously unfortunate people who are unfortunate, meaning they have got a surgical sentiment because they have had to undergo a surgical procedure. And see, can they sponsor someone in the area where they got that surgery so that it can now be in country? They don't have to fly their next relative out. Maybe we can name these scholarships and tell them their names will forever be embedded on the certificate. This is the beneficiary of the X neurosurgical scholarship and that kind of thing. So we thank you very much, and again, we shall try not to be strangers to the funders. So we shall network, and I'm happy we are networking with you. You will hold our hand to the next funders. So that said, I would like now to invite Dr. Olive to tell us where we are. We've been told how to go forward, but where are we now? Please come and tell us the state of surgical care. Thank you very much. Join me to welcome Dr. Olive.
Thank you very much indeed. Actually, I fear that most of what I'm going to say has probably already been said many times, but I was told recently that on average, we need to hear something like 3 times before we can remember it. So hopefully 5 times? Oh my gosh. Okay, so I'm in a good place. I'm going to say a few things that you've heard 4 times already. And I hope my presentation is coming up. So the question was, are we there yet? And how do I advance that? Okay, so we're talking about Uganda, and we've, especially Professor Makasa, yesterday gave us lots of information from SADC, but we'd like to bring it home now and say, so Uganda is predominantly rural, and actually a lot of this urban that we're seeing at nearly 38% has only happened in the last 20 years. So it previously was 12% urban, 15% urban, and then it's very rapidly gone up to 37%. If we look at the population, that 46 million Ugandans, we can see that the majority of them are actually under the age of 18. So we are predominantly rural and young. If we say young as Mr. Sekabira likes them, below the age of 14, we still are, it's still going to be a very young age group, population. So if we think about surgical access, about how we get this predominantly young, rural population to have surgical access, we can think about, so what's the need? What need is there for surgical services? Now, this is, the first one is from a 2014 cross-sectional survey, so we're already 11 years ahead, but it reported that 1 in 10 individuals that you come across has a condition that requires surgical consultation. That's a lot of people that need surgical consultation. If you just think about how many people are here and 1 in 10 needs to get surgical consultation, that's a lot of need. Now, if we think about that age group, 50 and above, and we already said we are predominantly young, so this is not a huge population, but it still is significant, that close to 28% of them have unmet surgical need. They do require surgical services, they don't have them. Now, this is something from Soroti, and I know Soroti has been keeping very good data. And they said the majority of surgical patients were male. We're not surprised about that. The median age being 22 years. And common conditions, maybe not very surprising, fractures, trauma, indeed, and soft tissue infections. So we think about what the need is. Okay, let's look at the pediatric surgical need. As we said, this is a predominantly young population. A cross-sectional survey in eastern Uganda found that 16% of children had a surgical condition, and 6.3 have an unmet need for surgery. If we think about public, yesterday I think it was Dr. Kasaga who presented work, and he was focusing only on public facilities, that a nationwide study reported an average annual rate of 22 major surgical procedures per 100,000 pediatric population. And the bulk of them were congenital, they were those that were infectious, and injuries, again, being the most common conditions. Mulago, which is largest hospital in the country, has been a teaching hospital for the longest time, no longer is, I made to understand. Congenital anomalies accounted for 38%, close to 40% of pediatric surgical admissions, followed by infections and tumors. Professor Makasa referred to this work yesterday by Albert and others. And this just looked at this is from 2016. It looked at operative volume and surgical case distribution in Ugandan public sector. And what they found, so they looked at district hospitals, they looked at regional referral hospitals, and then they looked at Mulago as well. So you can say that they had, other than the Karamoja region, they really had the country well covered. And they discovered that in terms of the operative volume, the bulk of the surgeries that were being done were obstetrics gynecology, maybe not very surprising, followed by general surgery and orthopedics at 4%, neurosurgery at 0.4%, and then all of the other subspecialties were lumped together as 2.9. Now, this is saying what is being done. It's not saying what needs to be done, and there's a big difference there. Is that on the one hand, we have unmet surgical need, but we don't quite know exactly what kind of unmet surgical need is. Those results that I just presented, first of all, are somewhat dated, but they also are not, they throw a huge blanket, so you don't quite know what kind of subspecialties there are, and more to the point, the need that's not being met. So you have on the one hand that we're doing so much of general surgery, obstetrics, gynecology, but you don't know how much should have been done that wasn't done. That's actually indeed unmet. So if we were to go by this, we would then quickly say, oh, so we probably need more people to work in the obs-gyne area, we need more people to work in the general surgical area, and we hardly need anybody to work in ophthalmology, ENT, because this actually doesn't come up here. But again, it's what's being done, not what needs to be done. As always, when we think about access, we think about why people are not able to access the services that they should, and they might not be available, but the big question is, can they pay? Are they able to pay for those services if they were available? Now, this is somewhat more recent. A 2022 review indicated that public and private sectors contribute equally in terms of the facilities that are there. although some other reports suggest that 55% of facilities are privately owned or mission-owned, as opposed to 45% which are government-owned. This distribution is very different when you're in a rural area compared to the city. I found this somewhat shocking, but maybe it shouldn't be, that only 2% of health facilities are government-owned in Kampala, and yet Kampala has a huge population. So where is this huge population going for their care? They're clearly not going to government facilities. This was alluded to yesterday as well, so maybe this is the third time it's being mentioned. From a 2024 National Population and Housing Census, only 1.1% of the population is covered under any health insurance policy. And I don't want to embarrass us here by asking how many are covered by an insurance policy, but if we think Kampala has the highest coverage, it's only 4.1%. While sub-regions like Bukedi, Sebe, Mr. Epodoy, where your patients come from, is only 0.4%. So if financial access is a huge deal, and it indeed is a huge deal, then it means that the majority of Ugandans might not access care if they had to pay for it and they didn't have insurance. So the question is, are we there yet? And we're thinking, where do we want to be? Again, Professor Makasa yesterday talked extensively about healthy lives and well-being. This is SDG 3, Sustainable Development Goal 3, about people living healthy lives and the well-being for all ages, regardless of where you live. So if you live in Karangala or if you live in Kololo in Kampala, you should still be able to live the full extent of your life, healthy, and there would be well-being for all. So if we think about the there, where is the there? Are we there yet? And if we say that there is that we want people to live healthy lives regardless of where they live, if Ugandans should lead healthy lives regardless of where they live, and we've seen that we actually can't quite quantify this unmet need, it means that we should probably work a lot harder to understand that unmet need, so that we can meet it, so that people can get the care they need when they need it, and they can then go ahead and live their healthy lives. Currently, we don't seem to have a good understanding of, we all agree that surgical access is poor, it's inadequate, but we can't quite say, I haven't heard anybody come up here, I've looked in the literature, I don't see it, what exactly is that unmet need? And what kind of personnel, of facilities do we need to create, to put in place in order to meet that need? And how do we know that we are there, that we've now put in place? So it would seem to me, and if anybody knows different, let me know, that currently the way we determine how we train, we say we have all these subspecialties, we have all these specialties, and we have an enthusiastic group of young people that want to become specialist surgeons. And depending on what scholarships are available, that's what they'll take, or if they happen to like this specialty, or if they think it's easy to pass, or if they like the professor in that department. And I think what Professor Galokande and his team are going to be telling the PS, remember yesterday you had this appointment for first week of April, what you're going to be telling her is, this is the unmet need. It is in this and this and this area. We have so much ENT, ophthalmology, GI, surgical need, And this is the capacity that we have currently. We have so many such surgeons, such facilities, with all of what goes with it, anesthesia and all and all. And this is the gap. And I don't think that we have that information yet. So I'm not saying don't go there, I'm saying we need to work hard to get this. I get the sense that, I think it was Dr. Nyonzima this morning said a couple of times, maybe more than a couple of times, that you cannot do research while your patients are dying. And that is so very true. But the reverse is also true, that we cannot remain on the cutting edge of good clinical care unless we have research. So the two have to go together. We cannot say we are going to be brilliant clinicians, but we really don't need research. And I think that's where we're going to need to now double up and do our research and say this is the capacity. And it could be changing, and so research is not static, but this is the surgical need that we have that is unmet, and this is what it's going to take to meet it. And if we are doing the right documentation, again, quoting from the speaker just now, then we are going to know when we are there. We are going to know when our patients are getting seen in time, when they are recovering in time, when they have minimal complications. There was an interesting presentation this morning about the project in Mbale, and they were looking at reducing postoperative death. Death is, I think even in Uganda, it's a relatively rare event. It means that lots of things happen before the patient dies. So maybe we should be tracking those things before we say we have a death. So maybe we'll be looking at need for repeat procedures or for urgent intervention or other complications. So we do need to ramp up, let me say it 3 times so that we remember it. Research. We need to ramp up our capacity for research. It's going to give us the answers to whether we are there, what kind of facilities do we need to get there, and we'll know when we are there. Thank you very much.
Thank you very much, Dr. Olive. I think let's clap for her again. She's taking up the big role of documenting for the surgical fraternity. And that was an assignment by the president. And so we look forward to listening to more next year on where we would be by then. She's talked about access, and she's talked about research and data, and I think we need to think beyond output to outcome so that we can impact on the real outcome, not how many colonoscopies, but how does the patient perform 3 years down the road. And that means the follow-up has to be intentional, and the documentation must be intentional. And unfortunately, when we think about research, we always think about trying to get a Nobel Prize winning research and forget the very things before us, the practice-related research. And if we can only improve our data and documentation, we shall have enough to analyze, to inform practice. And I think that's the core. We want to inform practice, to better outcomes, and be able to say that surgery is doing what it has to do. So we now have 2 speakers coming, each of whom will have 8 minutes to speak. And I'm going to be very strict with time on this, because my people have exercised what we call diplomatic patience and resilience, but it's not that they are necessarily willing to wait any longer. So let us welcome Dr. Francis Basimbe. Dr. Francis Basimbe is a GI surgeon, interventional endoscopist, and is going to speak to us about colonoscopy training in Uganda using a computer-based simulation model, a path to competence-based assessment and certification. Dr. Basimbe, you're welcome. Thank you very much. 8 minutes and I will count.
Thank you, Professor. My Vice Chancellor, I'm called Dr. Basimbe. I'm a surgeon. I work with Nsambia Hospital, and I'm the chair of surgery at Nsambia. I'm going to share this with you, something that we've been working on, and we held a training and we followed it up with a couple of activities that have shown probably where we need to go in training in endoscopy in this country. I'll start with what we already know, is that one, GI malignancies, GI cancers are increasing worldwide. We know that very well, it's out there. In our setting, it is also true that particularly in those that are less than 50 years, and so there is need to have an intervention and attend to these issues. And we know that in managing GI cancers, early detection is extremely important. And a tool that we know that is important in doing that for GI malignancies is gastrointestinal endoscopy, that is both diagnostic, but even in very early stages can offer therapeutic advantages. So what are the gaps? In terms of training in endoscopy, Uganda lacks currently a structured training program for GI endoscopy. And I will confess, and I know many of the people in this room will agree with me, that many of us have trained informally as a result of apprenticeships. I was mentored by the late Professor Kakande mainly. He actually inspired me to get into this particular work. And it's true for many of us here as well who are practicing endoscopy. So this comes with a bit of challenges. One is the standard. So sometimes you're as good as the person who has mentored you and trained you. And when it comes now to certification, that creates challenges. So there's this lack of formal training creates a variability of skills between the different endoscopies. What can someone do? What can someone do? And that creates a bit of challenges when you look beyond Uganda. So we feel that is a problem that definitely needs to be addressed. So across the world, endoscopy training has shifted from the apprenticeship model to now mainly simulation-based training. And this offers a couple of advantages. One of them is it allows practitioners to develop their skills in a stress-free environment, because many times you do not have, especially at the beginning when you're honing your skills, there is no patients at risk. And so it's only when you've developed the competent skills that can come in later. So it is fairly safe, it mitigates risk, and then it is easy to then, at the end of the day, standardize competencies. That if you have 2 or 3 people, if you've assessed them based on a particular standard, then you can easily start now considering certifying them, that now this group are certified people competent in this skill. Now, when we look at simulators, what is on the horizon? What I have in that picture is the mechanical simulator, which I've used, and I know many people here who do endoscopy have used before. And it offers, especially for beginners. However, one of the challenges for many of you that have used this will know that it lacks that realism. When you're doing it, most of them are plastic, so you're pushing a scope, it is rigid, and there are many issues there. So the fact that, yes, it may be able to demonstrate a bit of the anatomy, but the feel is not like that of a patient, has created a bit of problems. The second one, which are now quite prevalent, are the computer-based models. Now these ones, many of them are silicon-based, and this material has been refined to be able to give the trainers a feel of fairly good tissue based on many of the feedbacks. And the advantage with this is that because of the technology, AI, most of the trainings, there are many, these models have many sensors that can mimic many live situations that can also be used to test particular skills. The third one, which we also use, are the animal tissue-based simulators. And I've been privileged to attend trainings where this is acceptable. Now, this is real live animal tissue that can be, if you're doing maybe stomach, if they're teaching you procedures like polypectomy, these are good because you're dealing with real animal tissue. But as you are aware globally, you run into many questions with that tissue, especially when you get confronted by how you're obtaining it. If you're using live animal, then there's also a whole lot of ethical issues there to deal with. So, therefore, why is it important to develop these competencies well? One is, if these skills are acquired well and competently well, then that means that most of our patients will be undergoing a proper procedure, and that procedure is a safe procedure that is not going to miss pathology. Remember, we are going to be dealing with mainly cancers. And so in colonoscopy, there are many techniques that we want to evaluate: loop reduction, advancement, mucosal inspection, to make sure we do not miss lesions. So simulators, especially the computer-based ones, have been shown to actually help us in doing that. So what we did last year is I'm going to push this a little ahead, is we conducted a training where we got access to one of the simulators that is run by this particular, it's a Fujifilm-based simulator that has many sensors in there that mimic a real endoscopy procedure. And so we recruited about 11 trainees, and when they underwent this training, many of them, we conducted a survey after that training, and we're trying to look at what do they think of doing this as a standard in our country. And what we looked at is, at the end of the day, most of the trainees gave very good feedback, especially with the fact that they were learning a skill in a fairly stress-free environment, and also they were able to look at complications and also work around those complications without really endangering patients. And so the way we conducted it is we first had a couple of lectures of essential issues to deal with in colonoscopy, especially the indications, the techniques of sedation, and also how to do the procedures, bowel preparation. And after this, our trainees had practical sessions where they were using this simulator that has highlighted called Mikoto. And at the end of that training, many of these trainees had very important feedbacks, and I'm going to run very back to that. So they found that this was a realistic way of training. They appreciated the practical sessions, and they suggested one of the things that they thought we could improve was to categorize the training, especially for some of those that have a bit of experience but want to improve their skill further, such that they have special sessions. And so overall, they felt that this kind of training is important and offers them the feedback and the skills advancement they need. So the question I put out there then is that I think as a country, should we look at this definitely as a standard for endoscopy training and certification? I'll leave it up to you. Thank you very much.
Thank you very much, Dr. Basimbe. Yeah, we are living in an era where the patient rights have actually become very central, but also we always have to mind what I call the VCS. That's the volume. As a student in surgery or a trainee or a practitioner, are you able to ramp up the volume required? We are also dealing with the C, and that's the competence. As you do the volumes, are you able to demonstrate competence? But at the bottom of that is the S. Can we ensure safety? Are you a safe surgeon? Now, to do that with the patients is no longer acceptable because there used to be a time, actually, in the UK it was researched and in other areas, where the surgical mortality was highest in the months of September to January, because that's when there was a change of cohorts. So they came in raw, they were trying all things, and then by January they had stabilized and the graph would go down, only to come up again in the next September. But we can no longer afford that. We can no longer afford to learn and acquire volume on human beings whose health and outcomes cannot be guaranteed. So thank you very much, Dr. Basimbe, for shedding light on simulation. Our next and last presentation in this session is also on simulation, and it's from Dr. Sajawal Joaya. He's online. He's an orthopedic house officer in Pakistan, and is joining us online. He's at Lahore University or College of Medicine and Health Sciences, and is going to present to us the effectiveness of simulation-based training versus standard lecture for outbreak investigation among medical students at the Lahore Medical College as a randomized controlled trial. Dr. Sajawal, you are very welcome and you can proceed. I will give you 8 minutes, and we thank you for making the time to join us online.
I hope I'm audible. Hey everyone, my name is Sajawal and I am from Pakistan. I am here working as a house physician in orthopedic surgery at CMS Lahore. So today I'll be presenting my research on evaluation of effectiveness of simulation-based training and teaching outbreak investigation skills. So to start, we conducted a randomized controlled trial over a
We seem to have lost the connection. Let's give him a few minutes. Maybe he
Hey everyone, am I audible?
Yes, we had lost you for a moment. You can carry on.
All right. All right, I'll start again. My name is Dr. Sajawal Joya. I am from Pakistan, same as Lahore. I work here as a house physician in orthopedic surgery at the moment. So today I'll be presenting my research on evaluating the effectiveness of simulation-based intervention in teaching outbreak investigation skills to fourth-year MBA students at our mid school, which was CMS Lahore. To start, we conducted a randomized controlled trial over a 6-month period from February till July 2023. Should I share my screen as well? Or you can...
Yeah, please, you can share your screen so you have the control over the slide transition. Share your screen, please. You can disable the video now and share your screen. Maybe the bandwidth will be much less strained. Yeah, these are the real life challenges of technology. Yeah, you can disable the video now. We've seen you, and then share the screen so we can follow the presentation. Thank you. Okay, I think we might have to make an apology here.
I share my screen. Just give me a second.
Share the screen, please. Disable the video. Okay, unfortunately,
Am I audible now?
Okay, there you are. Yes, carry on, please.
Are you able to see my screen?
Yes, we can see your screen. Thank you.
All right. So today I'll be presenting my research on evaluating the effectiveness of simulation-based training versus standard lecturing for outbreak investigation among medical students at CMS Lahore. To start, we conducted a randomized control trial over a 6-month period from February to July 2023. And our study population included all consenting fourth-year students, and we employed a universal sampling technique to ensure all eligible participants were included. Using GPAR software, we calculated a sample size of 82 to achieve a statistical power of 0.8, an effective size of 0.3, and an alpha error 0.05. Our primary goal was to assess the effectiveness in 3 domains: knowledge, skill, and attitude towards outbreak investigation and community medicine. We developed a questionnaire for this purpose, which underwent validation by faculty members and a group of 30 participants, resulting in a reliability score of 0.7. Next, we randomly divided participants into 2 groups. The control group received traditional lecture-based teaching, and the interview exercise at providing a more interactive learning experience. Both groups completed a pre-evaluation questionnaire to assess their baseline levels of knowledge, skills, and attitude. After the scores were gathered to measure changes. So these are some of the pictures which we collected while we're doing the research. And moving to our results, The intervention group, as you can see, demonstrated a significant improvement in both knowledge and skill.
We cannot continue with the presentation due to the connection challenges, but we thank you for having made the effort to be part of this conference. I would like now to welcome to the stage Dr. Kakungulu to guide us on the next part of the agenda. Unfortunately, we are not able to take any questions from the previous presentations because of the pressure of time, but I encourage us to network with the presenters and share the insights that have come through from their presentations. Thank you very much. Doctor, you can come and take over.
Thank you so much, Professor Chamanywa. I'm not Dr. Kakungulu. I'm Dr. Tendo. Can we give a round of applause for the keynote speakers, the guest speakers, the panelists, and to you as well? Another round of applause, please. Thank you for enduring all this time. So we've come to the end of our morning session, and right now we are going to have a group photo. So I'll invite us here to have a group photo, and then thereafter, we have an exhibition tent. And I invite all of us, surgeons, we have radiologists in the house, interventional radiologists, and all of us, let us go down to the booths and at least spend 30 minutes and look at the new innovative surgeries that are going on and different exhibitions that are going on. And we shall be distributing our lunch coupons right there at the exhibition. So lunch will be an hour. Well, then we'll come back. We still have a packed program, but very, very interesting and very informative. I encourage all of us to stay around until the end of the day. So we bless God for this meal that we are going to have. In Jesus' name, amen. And for the Muslims, if we have Muslims who are right here and they are fasting, kindly register your names at the registration table so that we have, I think it's called iftar. Iftar, yeah. You're all well catered for, our Muslim brothers and sisters. Kindly register at the reception desk. So at this moment, let me invite all of us to come forward for a group photo. Thank you. So let's have a quick one, group photo, and then thereafter we shall have the keynote speakers. Please come forward for a group photo. All our delegates. And after the group photo, we shall have one with the keynote speakers. Thank you. Your position.
Good afternoon, everyone. Let's take our seats and continue with our program. The next session is about the role of surgical training, and I would like to welcome Dr. Aikoru Rachel. Dr. Aikoru. Yes, to proceed with the session. Thank you.
Good afternoon. Yes, I think after lunch it's the right timing to have a session on the role of surgical training. So I would like to invite our first presenter. To keep people awake, I would encourage you to keep 8 minutes to the dot. Dr. Emmanuel Bua is a surgeon that is based in Mbale Hospital, and he's going to talk about designing a residence research database, a framework for standardizing data collection and analysis. Let's put our hands together for Dr. Emmanuel. You're welcome.
Thank you so much, Rachel. I'll try to use 7 minutes, so maybe someone can use my 1 minute. My name is Emmanuel Bua, and I am the Library and Information Secretary of ASO, and I'm here to present part of the work that is ongoing from ASO, and that is designing a resident surgical research question database. This followed actually an outcry from the residents who were facing a bit of difficulties with their research, not only completion, but even designing proper research questions. So in response to that, ASO came up with this project that is ongoing, and in formulating a research question, we all know formulating a research question is crucial for any scientific study because it's a step in providing quality, clinically relevant results. So I'm here to talk about a structured approach that we are designing to generating surgical research questions that are considered of good quality and hopefully relevant to all the residents across the country. Specifically, we designed this in the hope that we can develop at least 300 surgical research questions that are relevant to residents across the medical schools and other training hospitals, and in the process, fostering critical thinking in research. So the first step was to do a literature review, gathering as much literature as we can from various sources. And the idea was to identify trending topics, controversies, and knowledge gaps. So because this is something for the residents, they are the beneficiaries, we thought it wise to engage them, and that is the second step that we are going towards, engaging the residents, having group discussions with them, surveys, and identifying any queries and challenges and possibly areas of curiosity. And then when that is done, we'll definitely involve the experts. And by experts, I mean you people in this auditorium this afternoon. I'm hoping that when we reach out to you, you'll be gracious enough to help us put this together. After generating the research questions, the next step would be to categorize them into themes. For example, those that have been listed down, like techniques, patient safety, education, global surgery, and so forth. And this slide is very important because after generating these research questions, they are considered crude and maybe not refined. So the next step would be to create well-structured, specific, answerable questions using some of the frameworks that we know. For example, the PICO, which is patient intervention, comparison, and outcome, or the FINA, which talks about whether a research subject or topic is feasible, interesting, original, and ethically acceptable or relevant, so to speak. There are several other frameworks which we shall use to refine these questions. And then finally, we'll have a peer review by panel of experts that will help us validate the generated questions for relevance, importance, and potential for research. At the end of it all, we expect to have a list of about 300 surgical research questions that are relevant, meaningful, and feasible for residents to investigate. And hopefully in the process, we'll be promoting research skills, critical thinking, identifying priority areas, and contributing something to the knowledge base of surgery. A question came up that how will these people access these research questions or research topics? The idea is we will create a portal that will be accessible to all residents, but there will be some controls just to ensure that someone else does not come and access that information anyhow, so there will be some kind of controls. And the design also will ensure that whoever accesses the portal leaves a footprint just to avoid issues of clashing on different topics. This will be refined as we go on. And that's the timeline. The whole project is expected to take about 18 weeks. And periodically we'll be disseminating the information on how far we have gone. And hopefully by next year's conference, we'll have everything done and we shall have a final dissemination. Like I said, we began already, and these are just preliminary results of the first step. So far we have generated 94 research questions. The aim is to have as many as possible so that we can sit down and refine them and hopefully remain with maybe 300. That would be good enough. So based on what we have seen so far, even in the short time, we can say a well-defined and specific research question is more likely to guide residents in making decisions about study designs and population. And then subsequently, it will be good for standardizing data collection analysis. I want to give credit to Professor Galukande, with whom we have been working on this. Thank you very much. I hope I used 7 minutes.
Thank you. Please have, I came so that you don't go down. Have a seat. Thank you. Sorry for intercepting you, but I had to do that. Our next speaker is called Dr. Eva Navawanuka. She's going to present the implementation of interventional radiology training program in Uganda, an analysis of results at the 1-year mark. I would like to say this lady here prevents us from opening patients just to see. She gives us a reason whether to open or not. And if you're a cake lover, please like her. She attracts cake.
I feel like I've been ably introduced, so I will not say anything else because they've disclosed my love for cake. I am here to talk about this implementation of interventional radiology training in the country. And I will be talking about our results at the end of 1 year. I have nothing to declare. Basically, I'm just going to tell you a story of what we've done, how it started, and how it's going. That's my team in the picture. Dr. Bogeza is right here in the room. I know he's not a stranger to many of you. So how it started. First of all, interventional radiology is really the use of imaging to help us diagnose and treat diseases. I know that the surgeons know this, so I don't have to belabor the point. But until recently, we didn't have any local training opportunities in the country, which leaves all of us, lacking access to these things. And obviously, this is the same, or at least at the time I got, introduced to this thing called interventional radiology. In the entire Africa, there were only 5 countries training. That map shows the countries in yellow. The countries in yellow are the ones that have radiology training. The countries in green at the time were the countries that had interventional radiology training. And so I wondered why, on the east of Africa, all those countries around us had these programs, but we didn't have any. So I looked around, and the one that caught my attention was this particular paper that had been published by the Tanzanian community, and they were talking about their journey of interventional radiology, how they built their program. It got me so excited. I talked to my chair of the department, who was Dr. Bogeza at the moment, but also the only person I knew who was doing anything interventional radiology in the country at the time. And we came up with this plan. That's a timeline showing the things that we wanted to do. And we drew this in 2020, COVID. This was our COVID present. Where the circle is, August 2024, is really the things that I'm going to talk about. After 1 year of being in existence, building a clinical service in Mulago, and what we've done. We came up with a curriculum to train people locally, and these are radiologists who are interested in doing interventional procedures. And we designed the curriculum in such a way that the first phase of training would do non-vascular interventions, and the second phase of training would do vascular interventions. We are in our second phase right now. Dr. Bogeza, myself, and another colleague are the pioneer trainees. And how we do it is we adopted this, we call it the Road to IR training model that was used by the Tanzanians. So what they do is they attract people from all over the world to give of their time, come to the country, do training, teach us how to do procedures. When they leave, they continue to give us the didactic sessions online. And this has been in existence in Tanzania for 5 years. They've trained 19 interventional radiologists in country as I speak. Uganda is on the same journey, and we have 3 trainees. We launched our program in 2023, August, and it was exciting. The media got excited, and they reported it as a new cancer treatment technique. You can always trust the media. They spice things up. So what we've done, how it's going right now, is we've attracted people from all over the world. In the room right now, I have a team from France, and I'll introduce them. Hi, They are intervention radiologists from France. Basically, what I've done is go to meetings like this, talk about what we are doing, ask people who want to help us, and we invite them and they come. We arrange for them to come. Those pictures are pictures of the different groups of people that have come as I speak. We have had 22 teams in the last 20 months. They come from all over the world. And it's exciting to learn from different people. And as you can imagine, it's challenging, right? Because everyone comes with their other things. But we embrace the challenges and we pick all the knowledge. When they come, they engage with the trainees, but they also engage with the radiology department. So not only us who are doing interventional radiology procedures, but all the residents, all the radiologists that are practicing, especially within Mulago Hospital, which is our training facility. So 1 year later, what we've done is establish an interventional radiology clinic in the hospital. And by August, we had 829 interventional radiology consultations, mainly from people from surgery, I'll say, actually. And we had a total of 552 procedures. That's how we conduct our clinic. Usually we'll have the intervention radiologist sit in as the trainees do a consultation. We will look at the imaging and evaluate which one we are going to do and what we are not going to do. That is myself with one of the attendings, watching and supervising as I do a procedure. So it's really hands-on, and we get involved to do the procedures. Most of our procedures so far have been biopsies, mainly ultrasound guided, CT guided, and fluoroscopy guided. The reason for this is because this is what we have, honestly. The range of intervention radiologist procedures is broad, but we are building as we go, and that is why it was important for us to do the training in country, because we train the people, but then we also build the structures so that we are able to do this work. It was interesting for me to look at the social factors. Our patients come from all over the region. We have patients from Congo, Sudan. They speak all languages. They're still traveling up to 24 hours to come and have a tube draining an abscess, which is sad because I'm talking about non-vascular procedures, at least now. You can't do this alone. It takes a village. We have had so many institutions involved, so talk about global health. We are doing it. And when they come, we tour our beautiful country. We come to meetings like this. Thank you so much for your attention.
Thank you so much. I will invite you to take a seat. As they take a seat, please note we are going to have only 2 questions. We are left with only 2 presenters. Now, we have stressed the importance of safety in patient care. Our next speaker is going to talk about the implementation of a cadaver-based operative trauma course for surgical trainees in Uganda. Let's invite Dr. Ibingira Treasure. Thank you.
Good afternoon to you all. My name is Treasure Ibingira. I am a surgeon. It's a pleasure to be here. I'm going to say a few things about trauma care. We have this ongoing project and vision and goal to improve trauma care in Uganda. So I'm going to talk about some of the things that we're doing. I'll start by talking about how this all started. This started about more than 15 years ago. It was actually started by Dr. Mabwijano Jackie. I think she's here. This first picture that you see is pre-hospital care. So Dr. Jackie Mabwijano, together with Professor Doruk, had a goal to improve trauma care, and they started by doing some pre-hospital care. It's a continuum of so many things, but they started with pre-hospital care by training police as first responders. Then this graduated into, sorry, is someone controlling the slides other than me? Oh, okay. Time, okay. So yeah, then they went on to emergency care, doing the Kampala Advanced Trauma course. This is where we train the interns about surgical trauma care, inserting chest tubes, doing bar holes, and then we proceeded to doing more of surgical care. This is where we train surgical residents in surgical maneuvers, especially abdominal, chest, neuro. So my main goal today is talking about the surgery residence program, which is the operative trauma course. So first, this is it's a preliminary study just to see what this is all about and what we do. So the first is the training evaluation. And here, when you look at the Kirkpatrick pyramid, we do pre-surveys and post-course surveys just to assess the reaction to the course and the knowledge of the trainees. So what we found out was that after doing this program, giving it to the residents, we found that 85% of them found the content extremely useful, and there was a knowledge gain, and it was significant. So we found that the trainees reported that they benefited most from the EFAS training, from the surgical airway training, and from the thoracotomy. So this was the trainees in Mulago. And then we looked at the trainees in Bara. We gave them the same program, and we found that 70% of them found it extremely useful. Again, there was a huge knowledge gain. And these are only 10. The ones in Mulago were a lot more. There were similar outcomes in terms of the areas that they felt made the biggest difference. That was neck injury, thoracotomy. And then this raised the question, why do they have similar areas of improvement? So we looked at the case experience. We found that most of the SHOs have some experience doing laparotomies, but no experience doing thoracotomies. As evidenced by these graphs, you can see that the thoracotomy is assisting, doing almost non-existent. So what are the future direction for this? We feel we need to go further up the pyramid for the Kirkpatrick model, and this is now evaluating the changes in the operative management after this training. So that is where behavior comes in. And then we looked at the cost of the course. In the US, you can see that to train every resident, it will require about $1,000 USD. But here in Uganda, to train one resident will require approximately $89 US. So what does this mean? Okay, I'll conclude later. So then we also do case conferences. The main takeaway from okay, I'll conclude. So basically it means that the course is very relevant, and we'll be going ahead to do a lot more. Thank you.
Whoever is controlling, you're really keeping time. Thank you. We may wonder why we see bowel endometriosis, endometriosis, and what this has got to do with the surgeon. The surgeon, 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 the I think we'll invite Dr. Chigundu Spire to take us through this so that we're enlightened.
Thank you very much. I'm glad to be here. I work with the Henry Hospital as an endometriosis surgeon and a fertility specialist. So today, I wanted to interest us with endometriosis. I usually say endometriosis is a disease without a lobby because it affects every other system. So why bowel endometriosis? Because we've seen quite a lot of patients who have involvement of the bowel in different regions that we shall see. I also want to emphasize how we can reduce the delay in the diagnosis of endometriosis and the possible intervention. So we'll literally work together with the surgeons. I want to take the opportunity to thank Dr. Gideon for helping us to improve the safety of bowel surgery. Okay, so just briefly to mention that 45% of women with reproductive age have endometriosis. Yeah, okay, thank you. Have endometriosis, and 90% of these have deep lesions in the posterior compartment. And we've noted that 66% usually have intestinal lesions. And among these, we have the rectal sigmoid as the biggest culprit. We also know that a transvaginal ultrasound is the gold standard in the diagnosis of endometriosis. Common symptoms, as we know, are chronic pelvic pain, dysmenorrhea, dyspareunia. Sometimes bowel symptoms are a bit subtle and easily missed. I also want to put a disclaimer that 50% of these patients usually do not present with any symptoms. So that means you need a high index of suspicion to be able to diagnose bowel endometriosis. The definition of bowel endometriosis is basically the presence of endometrial glands and stroma in the bowel wall. I want to take particular note that endometriosis goes for the anterior bowel wall, especially the muscularis propria, where it causes smooth muscle hyperplasia and fibrosis. Unlike malignancies, the disease does not go for the mucosa. It never invades the mucosa and won't cross to the posterior bowel wall. It is a disease limited to the anterior bowel wall. So what we call a bowel nodules are basically hyperplasia or fibrosis of these layer of the bowel, and this is responsible for the chronic pain these women go through. With particular interest, as I mentioned earlier, 65% of these lesions are in the rectal sigmoid. However, we find that 4% of the patients will have endometriosis-related appendicitis. It is true that most of the patients you're going to come across as surgeons with appendicitis as females have endometriosis. So it is not enough to pick out the appendix and leave the disease in the pelvis. You should take keen note of that. Unfortunately, most of these women have moved around for 8 years without a diagnosis, and during this time, they've had several interventions. On average, they have seen like 8 general practitioners and have had incomplete surgeries. A picture like that is not uncommon in your practice, where you find a woman who has had several surgeries, several complications, just because people have gone into a frozen pelvis and couldn't do much. So we want to avoid this kind of picture by having the right and timely diagnosis. Pelvic exam is very important, especially a digital rectal exam. And I want to particularly mention, and I'm glad that we have the radiology team in the house. I really want to challenge them to put particular emphasis on the diagnosis of endometriosis, because we get a lot of scans coming even from the senior people, and they have missed endometriosis. So the gold standard to the diagnosis of endometriosis is a simple TVS, okay? And if a woman is a virgin, you can do a rectal ultrasound. You can be able to pick out these lesions in the bowel quite easily. Laparoscopy is not the gold standard in the diagnosis of endometriosis. It should be reserved for treatment. The first surgery should be the last surgery and should be the best surgery. So we should emphasize the role of doing a very good endometriosis ultrasound. Sometimes you will find a picture like that of a frozen pelvis and you do not know how to proceed. But if you did a proper ultrasound, you can see that you should be able to pick out the lesion circled there as a bowel nodule, and you can plan adequately. This is what we call a tip of an iceberg. We call it a diabolo-like noten. The kind of nodule you see on ultrasound on the image on the left. And if you do surgery, the specimen will look like that. That is what you call a bowel nodule. It is hyperplasia of the muscularis mucosae. And these are usually missed. You cannot see them with a naked eye unless you did a proper ultrasound. What should the surgeon know? Ultrasound is the gold standard. We need to look at the size, the distance from the anal vag, rule out stenosis of the bowel and multifocal lesions to plan our surgery better. This is the picture of the bowel on ultrasound. And I just want you to focus on the anterior bowel wall. The muscularis mucosae is the area where the nodules go. This image basically shows you a real life ultrasound, and what you see is a bowel nodule. It is just dilatation or hyperplasia of that layer of the bowel. You notice that the posterior bowel wall is spared, and we measure the distance from the anal vag. We take the length and the depth of the lesion, and that helps us to plan our surgery. We have what we call the Enzian classification. When we scan, we do the Enzian because this helps us to stage the patients and helps us to plan surgery. With particular interest is the rectum, and that is what we do. A C represents the rectum, and any lesion less than 1 centimeter is superficial. Lesions more than 3 centimeters are deep, and they might require rectal resection. There are different techniques we shall see. You can decide to become conservative depending on the staging. If someone has superficial lesions, you go for what you call shaving or a discoid resection of the bowel. That is just taking a small segment of the bowel where the nodule is, sparing the posterior wall. Or you can decide to get radical if someone has a deep lesion or multiple lesions. That is a diagrammatic representation of what I've said. This is how we do the discoid resection. You get the stapler through the rectum and just take the section of the anterior wall of the bowel, you staple that off, and that will help to improve the reservoir. The outcomes are much better with a discoid than a segmental. But if you have a whole length of bowel more than 6 centimeters, rather 3 centimeters, or multiple lesions, you'll have to do a segmental bowel resection. And these are the specimens showing you the involvement of the bowel. I'm about to finish. Here we have multiple lesions of the bowel, and if you have a patient like this, the lesions will not fit into the discoid, so we do a segmental resection. These are the statistics at our facility. We worked on a total of about 26 patients between 25 and 25. Among those, 59% had superficial bowel nodules and required shaving. 7% we did discoid resection, and 33%, which is a large figure, required segmental bowel resection. Post-op outcomes were good. Hospital stay between 3 and 5 days. Complication rates were low, less than 1%. We had one patient who had bowel stenosis and required dilatation. The rest were okay. We didn't register cases of sepsis, leakage of bowel atony, and this goes down to the technique. We use a technique called the nerve sparing technique of preparing the bowel, and we try to make sure that we preserve enough of the mesorectum. With that, you get better function. Remember, endometriosis is a benign disease. It's not a malignancy, and the women are usually relatively younger, and they do well post-operatively. I also want to put a disclaimer that the treatment of endometriosis is complete excision. It's not ablation, so if you decide to go for surgery, you have to be sure to complete the surgery. Lastly, in conclusion, I still want to give you this paper for your reading. It has a comprehensive picture of how we diagnose endometriosis using a TVS. And for me, I think this is where, this is the game changer. If all of us would really get information about the prevalence of the disease, the burden is real, and then make sure that we reduce the waiting time to diagnosis and get timely diagnosis, get these patients scored well and sent to the right centers for treatment, then would avoid the multiple interventions that we see. I want to thank you very much for listening.
Thank you. Thank you, Dr. Spire. The notice said the first surgery should be the best surgery and the best treatment. The last surgery. Just a question, what should we expect on digital rectal exam as microphones move around for the two questions?
Thank you for that question. So usually the examination of a patient with endometriosis should be comprehensive, and you should examine the patient as if you're examining the patient for malignancy, because endometriosis behaves like a malignancy to me. I don't want to call it a benign malignancy. That doesn't apply, but the way it behaves is quite similar. So you do a bimanual vaginal examination, trying to look out for the involvement of the ligaments, especially, I mentioned that endometriosis is essentially a posterior compartment disease. And that means it goes for the uterosacral ligaments, the parametrium, the nerves, and the bowel. So if you put your finger in the rectum, you will actually feel, you would feel that there is no sliding sign. There is the feel of the bowel moving across with the uterus. And if the patient doesn't have a sliding sign, then it is a sign that they have a frozen pelvis. But secondly, you would be able to palpate those nodules. They're quite obvious when you put your finger in the rectum. You'd feel them. Yeah.
Thank you so much. Any questions? We are taking two. Yes, we have one there. Okay. We'll take all the two questions and then answer them. And
Thank you, Madam Chair, for giving me the opportunity to ask all the two questions on behalf of the rest. Question number one is to Dr. Nabawanuka of Interventional Radiology. We want to appreciate your zeal in pushing for interventional radiology. We are seeing a threatening trend of rising incidences of cancer, which are reporting late. And we think interventional radiology should be one of the undertakings to deal with this threat to lessen the burden on the economy of this country. My question, though, is given the central role of this intervention, how come Uganda's training has only 3 people undertaking the training? And yet, it is being done in country. The cost implications are relatively low. The trainers are coming and finding you here. What if we had a bigger number of radiologists on the training program? Then the next question is also on training. Dr. Emmanuel Boa, thank you so much for helping to facilitate research in the country. But I have a concern. You know, the purpose of postgraduate training, one of the purposes is to put the trainees in a situation where they will practice situation analysis, stretching their imagination, and finding innovation to solutions to problems. And that's part of the reason why they are required to develop a research proposal and go ahead and conduct research. Now, when you give them a pool of already done work, and you removing the chance for them to stretch their imaginations, to look around and identify problems and imagine solutions, aren't we going to promote laziness? Because people will stop thinking and they will just go to your portal and find ready-made topics, and they just go to do the research. Isn't that moving backwards when it comes to training? We are spoon-feeding learners. It will be a risky thing. Because tomorrow, the thinkers will not be there. What happens to this pool who have been used to finding ready-made things when you who are thinking for them are out of the way? Thank you.
Dr. Riaka, you had a question, and then they will answer.
Thank you so much. I'd like to ask Dr. Eva, I like interventional radiology, and I think we the surgeons are your best friends concerning this. So I've tried to teach myself how to do point-of-care ultrasound scan, and it has helped me a lot in diagnosis and managing conditions. I don't know if your department would like to have some teaching for us, the surgeons, on that point, so that we are more competent, can be able to better manage our patients, especially concerning point-of-care ultrasound scan. Then Dr. Bingira, cadaver for teaching, I think, is very excellent, not only for undergraduates, but even for postgraduate training and fellowship. Mine is the ethics. These bodies you're using, where are you getting them from? Then number two, I think in the future you should scale it up to even involve postgraduate training and fellowship training as well, because I think it would allow people to be more competent. Thank you.
We'll answer that as brief as possible and to the point.
Thank you. Thank you very much for the questions. Why 3 radiologists? We have planned to take 3 trainees every year for the first 5 years at least. The reason is because interventional radiology training is actually very expensive. One of the things we found out as we benchmarked the other African countries why they didn't have training programs is because it's very, very expensive to train. As I speak in Molago, we are struggling with equipment. We don't have an angio suite. It's expensive to build one. It's not only the equipment that you need, there are so many consumables that go into every case, and they are used once. You use it and throw it away. So it's an expense, really. Most of our training, even as I'm saying it's local because people come and train, many times we have to fly out of here and go to Tanzania because they have the only angio suite in the region. So it's challenges with money. That's why we are training 3. Point of care ultrasound, yes, we have done this not as interventional radiologists, but as the Association of Radiologists of Uganda. We have different people that we are partnering with to offer point of care ultrasound. The quickest on the hill is IDI. They have a program that's running, and we are participating in that as radiologists. So this is something that we are doing. There are opportunities, and if the surgeons want to be part, you're very welcome to be part.
Thank you. Dr. Boa?
Yeah, thank you very much, Dr. Bisso. I hope I made a clear communication, but maybe for clarity, I want to say 3 things.
The first is that in our methods, we are going to engage the residents. In fact, that's the second step, meaning most of these questions will actually be generated by the residents themselves. The whole idea is to refine them and make them, and checking if they are really relevant as worth researching on. So the first thing is that part of the questions will actually be generated by the residents. And the other reason is part of this project is to ensure that we don't repeat things that have been done before. I mentioned this, that it will be identifying knowledge gaps and areas of interest and curiosity. So part of the process will be encouraging them not to go into things that have been done before, unless there is really something interesting about it. But of course, like we said, this is the beginning of everything. There could be a lot of lessons for us to learn also along the way. But at the end of it all, these projects ideally should not be run by individual residents. I believe that their supervisors should also be part of the project. So I expect a lot of input from the experts during that process. Thank you very much, but thanks for the concern, actually.
Thank you, Dr. Treasure.
Thank you, Dr. Erica, thank you for your question. I think cadaver-based training raises a very big question in terms of ethics. It's a dilemma. But for now, we shall still ask IRB to approve. We shall be asking for consent from the relatives to allow us to use bodies. But then there's also unclaimed bodies. There's a huge number of unclaimed bodies in the morgue, and that's how we plan to go about it. It offers excellent exposure, even for trained surgeons, and I think it's a game changer for not just trauma care, but for training as well.
Thank you so much for your attention. And since we have our sole president here, he will push for maybe healthcare financing to make this surgical training more better. Like we're seeing what is going on with the interventional radiology and many others. Thank you so much. We can take our seats.
Thank you so much. Let's give a round of applause for the previous panelists. And in our midst, we have the guest of honor with us. At this juncture, I would like to invite the president, Professor Galkande, to invite the guest of honor. Thank you.
Good afternoon, ladies and gentlemen, once again. We are privileged to have in our midst Honorable Charles Ayume, the MP for Koboko Municipality, and is also the former chair of the Parliamentary Committee for the Health Committee. And I think now he's chairing a different committee on antimicrobials. But he's here to represent the Speaker of Parliament. In Luganda, they say mwesuneko. If there's anyone who can translate to a neighbor who doesn't know mwesuneko, what it means? Just to say that you are lucky to have the Speaker of Parliament represented here. Honorable Ayume, the deliberations we've had earlier, yesterday and earlier today, echoed by the Permanent Secretary and the Minister of Health, they have convinced us, which fact we knew, but they have reaffirmed that the work of the association is not just for the sake of the association, but it's done on behalf of the Minister of Health, and it's done for the good of the people of Uganda. But we've also articulated the point that whereas the association is strong, it can be stronger. Our potential is not yet realized. Not because we don't want, but there are some bottlenecks there. And some of the bottlenecks are to be able to facilitate our activities to be more efficient. And we also know very well that you've made some pledges to us to be an advocate, especially for resources, for the association, to move forward. I mean, one of the reason we exist is to improve access to surgical care to the people of this country. We know very well it's limited, and we have evidence from the data that's been collected before that, and I guess it's still true, that 10% of the population of Uganda will need a surgical consult, and they may not be able to access someone to deliver this consult. And we also know for a fact that many people and potential donors have confessed that it's difficult to support surgery because maybe it's not well understood. It is thought to be complex, it's thought to be expensive, but we want to change that narrative. And this association is a platform to do that. And we are convinced that people like you and the office you represent will be our partner in this journey. Thank you for making the time. I'll welcome you to address the members of the association and the guests that we have that have come from a couple of countries. I don't know whether Professor Mukasa, is Professor Mukasa there? He's coming from Zambia. It's Professor Makasa, but Makasa is difficult to pronounce, so we'll call him Mukasa. Mukasa is easier. We also have some people from France. It's France, radiologists from France. Please give me a wave or stand for recognition. And we also have our friends from Minnesota, Professor Todd and Jennifer and I think a few others. You may wave for recognition. So you're welcome to address the members of the association. And thank you very much again.
This is the speaker's speech, so it is not adulterated. So you have witnessed me open it. The Honorable Minister of Health, the Permanent Secretary, Ministry of Health, the Director General Health Services, the President Associations of Surgeons of Uganda, ladies and gentlemen, I would like to observe the protocol. As Parliament of Uganda, we recognize the role played by the health workforce in Uganda, and in particular the surgeons and auxiliary professions. Despite the continued challenges, the situation is better than before. From 1 medical training school to 11 medical training schools, more resources allocated to secondary and tertiary care, more hospitals built, and strengthening regional referral capacity by building surgical and maternal child health complexes, more theaters, and ICU stroke HDU capacity at regional referral hospitals. As Parliament, we have established the Uganda Heart Institute and Uganda Cancer Institute under Acts of Parliament to give them the advantages that come with full autonomy. Other acts of Parliament that make surgical services better, like the Uganda Human Organ Donation and Transplant Act of 2023, are now in our statute books. We hope to also pass the Assisted Reproductive Technologies Bill to help improve the lives of women, but also their families. I am aware of the challenges to do with funding, with ICUs across the country, and Mulago Hospital, which I visited in 2024, as well as the lack of consumables for neurosurgery and also non-functionality of the Organ Transplant Council, which operationalizes the Uganda Human Organ Donation and Transplant Act 2023. Therefore, this coming financial year, 2025-2026, Parliament will give priority to funding these areas, including the money needed for the Organ Transplant Council in order to save lives and prevent referrals abroad. We also need to prioritize operationalization of ICU beds at Mulago by allocating extra resources for ICU staff and ICU consumables. Finally, I appreciate you for inviting me to this important occasion, and I look forward to receiving the resolutions reached at during this event to establish how the legislature can be of help. I thank you. Signed by Anita Annette Among, Member of Parliament, and the Speaker of Parliament. I was given 4 copies, which I will hand over to the President. Myself, in my other hat, I am Dr. Charles Ayume when I do not represent the Speaker of Parliament. I am a Member of Parliament for Koboko Municipality. I am the Chair Emeritus of the Parliamentary Committee of Health, and now I am a founding chairperson of the Forum on Antimicrobial Resistance. Fora are advocacy groups in Parliament that try and champion a cause. You assemble some like-minded people and champion a cause. Like this particular forum has members of Parliament from the Agriculture Committee, Education, and so forth. I must say I've worked closely with the Uganda Medical Association, including the Association of Surgeons in Uganda. And when I was at the helm of the Parliamentary Committee of Health, I had an open door policy. And sometimes I'm on WhatsApp with a number of you into the night and so forth, because most people think Parliament is a very sacred place, and whenever you're invited, you've been invited for having committed a crime. But I made it very approachable, and a number of you had come to vent your anger, especially our good intern doctors, and we gave them platform to come and also be on TV and be recognized in their various capacities. But it's really a struggle in there amidst a very resource-constrained envelope. I do not have to explain that. We all know what's going on at the global level. Priority shifts. And I was once on that side, but I think I also got frustrated as a doctor, no supplies and all that. So I said, no, instead of complaining there's no salt in food, let me go to where it matters most. I do not read the book of Lamentations in the Bible because I don't like to lament, okay? So I would want to encourage you people, I can see Titus here. Please, when you've had it with the medical profession, come to Parliament and we give hope to the next generation of Ugandans, doctors, and surgeons. Of course, Parliament, our cardinal roles are very simple. There are 4. To make laws, and I think in the Speaker's speech we cited some laws that needed to be in place for you to be able to carry out your job as surgeons. Secondly is to appropriate the national budget. Thirdly is to carry out oversight and then to represent our people. Now, some of those landmark laws, the Public Health Act, which we had to amend, hadn't been touched in 87 years. But then the newest, which had never been on our statute books, was the Uganda Human Organ Donation and Transplant Bill, which is an act of Parliament. And I would like to thank the association. In one of your colleagues, Dr. Frank Asimwe, we burnt the midnight oil to ensure that we had a very good law. And it is very common for the president, after Parliament has passed a law, he will send it back not once, not twice, and sometimes he can reject it. But I'm happy to say that this law went to him. It spent maybe about 60 days, but he returned it signed into an act of Parliament, into law, meaning that we did a very good job as Parliament, but also as all those people who came and had their input from the medical fraternity. And this law for us is a game changer. We have never done kidney transplants, liver transplants, and so forth, but it has given us an enabling framework. I just lost somebody, a son of somebody who ideally should have been saved, because I'm reliably informed that Rubaga Hospital is ready to do liver transplant. At Mulago, we had our first prototypes, I think last year, and we are ready. Now what we need is about 5 billion shillings to operationalize the Organ Transplant Council. And we were very intentional when we put the Organ Transplant Council in the law. My colleagues from the United States, we anticipated organ trafficking. You know the location of Uganda. So we anticipated organ trafficking, a child being ambushed and taken behind, and So we had to put very tough conditions in the law. Some we did not give options for financial punishments. We put life sentences in there, like if you're caught with organs or kidneys of a child, we did not give the provision or the magistrate to give a discretion that you can be fined. We say that will be a life imprisonment. And then, of course, we also took part of the responsibility to the healthcare providers. Sometimes we took an oath to do good, but you'll find surgeons with vested interests. So we also put punitive measures in there, and also for the healthcare facilities. For example, if it is a private hospital and you're doing malpractice in there, I think some of the fines were as high as $1.5 million. That should be able to close your hospital and so forth. So I think some of these laws are made for us to function better, but also to protect the image of the profession. I'm one person who doesn't believe in the bad publicity portrayed on some of the Ugandan doctors. There are just a few bad people out there, but also it's very easy for a non-medical person to access a stethoscope and a white coat and masquerade as a doctor. As I conclude, antimicrobial resistance, which I now head, and I'm a champion at national level, continental level, and global level. Mr. President, I think it is an area that you need to cascade down to the surgeons because it's a global threat, and we probably think it might be the next pandemic because we have not advanced in pharmaceutical development of a number of the antibiotics, whether it's the penicillins, and if you look in the last 50 years, they are more or less the same. But it's very common now to walk on the street and you find everybody with a cannula of ceftriaxone. So we are not regulating. And part of the problem, honorable colleagues, is that medical workers, whoever mentors, the health profession is about mentorship. Whoever mentors you, most likely you'll be skewed to their treatment regimens, even if we have our national treatment guidelines or formulary. So if it is Professor so-and-so and he likes beta-lactams, cephalosporins, you'll grow up as a doctor skewed to that side. Like I'm a fan of penicillins, even when it is not necessary. So 2 weeks ago, the forum was touring regional referral hospitals, and we were happy what we saw there. There are antimicrobial stewardship committees, medicines and therapeutic management committees, infection prevention control committees. And to the surgeons, I was also impressed that a number of the regional hospitals are developing antibiograms. Antibiograms, it is not enough for national medical stores or Ministry of Health to say that ceftriaxone is now resistant. No, it may be resistant in Barra, but it's working in Lira, in Arua. So we are encouraging regional referral hospitals, their labs together with the clinicians to develop what they call antibiograms, because erythromycin may be resistant in Mbale, but it's not resistant in Barara. So those antibiograms guide the clinicians to know what to prescribe, but later on also guide the procurement teams to know what to procure. So that NMS doesn't just deliver cephalosporins across the board, but hospitals should be given the opportunity to procure what is best for them. And sometimes you can rest an antibiotic, and after 6 years, its efficacy has improved. So we might actually go back to chloroquine. Maybe the Plasmodium is now sensitive to chloroquine. But we also had the opportunity to look at who are the highest consumers of antibiotics, and I'm happy to say that the surgical department, for some strange reason, eluded the top list. Most of the hospitals went for was OBS-GYN, and then 2 days ago, we were in Entebbe, they told us it was the medical and internal medicine and pediatrics department. But surgeons, please go back, take a reflection that you would guide us. The argument is, after surgery, do you have to give people antibiotics? Or do you give prophylactic antibiotics, for how long, and all that kind of stuff? I think during circumcision, people were only living with paracetamol. They were not being given what? Antibiotics. When we were doing this, the mass circumcision for people, I think they were only being given antibiotics. Finally, the issue of medical tourism. I am a proponent of medical tourism, and I think Uganda can be a very favorable destination of medical tourism in the Great Lakes region. We just have to tie up the loose ends. I think we have all what it takes. A number of you who are not content with the private sector, I think the government or public sector, I think the discussion should be, how do we help you people with low-cost financing to go and set up private hospitals, to go and set up private practices, so that we become a favorite destination for medical tourism. We lost a colleague early this year, and I hope this doesn't run on media, but I think we could have spent anywhere between 1 to 2 billion shillings on this colleague when he was in Nairobi, and that's money we have given to our next door neighbors. You understand? PET scans, I think, and all that. So when I handed over, one of my priority areas is medical tourism, to ensure that we have PET scanners and so forth. We are on the right trajectory. Colleagues, let's not lose hope. You have sober-minded people in Parliament. Oncology, we're regionalizing now to unpack the center. Oncology speaks to surgery because we have surgical oncology as well. We're done with the one in Gulu, the regional center. Next is the one in Arua. Islamic Development Bank has been on ground to do the designs. And then the next would be Mbale and finally Mbarara. Last month we did the milestone groundbreaking in Naguru for our new heart center, $73 million. And I think once that is complete, I trust the good people at Uganda Heart Institute. They have the capacity and they're quite passionate. Ours is to put the infrastructure and theirs is to do the job. So, Mr. President, we have listened in, and even when we do not interact, we keep track of a number of your needs. Last year, I made a promise. Unfortunately, it was not fulfilled. Among your recommendations to the Right Honorable Speaker of Parliament is, can we have that subvention through Ministry of Health of about 300 million shillings, which could be slightly below $100,000, so that whenever you're doing your surgical camps as an association, you don't go for fundraising, you don't go to City Oil, we need fuel and all that. It should just be seamless. We should put it in our recurrent cost, give it to Ministry of Health. Unfortunately or fortunately, I smuggled it into the budget last year, and there are things we do for the good of running of the country, but and you're ready to defend when you're going to Luzira prison. I hope you people can come and visit me there and say, yes, he went to Luzira, but he gave us the 300 million shillings for our medical camps. So I hope it is one of your prayers that you'll put in. And Mr. President, I would also encourage that the association looks into auxiliary services that fit into the outcome of surgical care. Physiotherapy, the people of the, once the ENTs have done their surgeons, they also have their people, the ophthalmologists. There are services that we neglect. And even when we are funding them as government, we don't prioritize them. But the outcome, 100% outcome of surgery is physiotherapy. You will do your very good implants and all that, but you need those professions. And it's high time you took stock of them and how many of them are deployed across the country. The need and ours would be to provide the necessary funding. Financing of healthcare, like I said, the outlook is a bit dim. We all know what is happening in Washington. I was in the UK last week meeting their Secretary of Health, and he kept on writing. He did not nod in affirmative or in the negative. So I cannot pop the champagne that we are going to get the necessary monies for HIV and all that, but ours is to have hope, but also as a country, we need to plug our excesses, plug in the issues to do with corruption, you understand? And there's a lot of wastages, and plan better, but also look at prevention where we can. We immunize. You're talking about cancer of the cervix. Can we scale up human papillomavirus vaccine, and so many other things. So, ladies and gentlemen, I beg to end here. We shall continue to support the sector. Please feel free. The person who succeeded me is also very approachable. And come and state your case. We're in the budgeting cycle, and that's why I came late. In the budgeting cycle, you have to be there to defend a number of things that you think should appear in the budget. If the neurosurgeons are here, I would like to take full responsibility, but also it's a bit painful to know that we do not give them consumables from our national medical stores. And I think last year I tried to prioritize 600 million shillings so that they can buy their mesh implants and so forth. I've raised that on the floor of Parliament, that we are not, it's an area that we have actually ignored, and most of their consumables are through well-wishers. And when there are no consumables, most likely you will die. So I think this financial year we shall also try and see if we can put some money for the neurosurgical consumables. I thank you very much, colleagues. And I will hand over 4 copies of the speech from the Speaker to the President. And you will make reference to her speech. And we shall also expect some of the recommendations, personal ones. One that you should not leave behind is the issue of operationalizing the 14 ICU beds in Mulago National Referral Hospital. Thank you.
Thank you so much. Thank you so much, Honorable Ayume, for representing the Honorable, and this. We've taken notes, and we appreciate making the time and your presence. Once again, let's give another round of applause for the Honorable. So we're going to continue with our program, and I would like to invite the next session chair, and that is Dr. Boa with Dr. Patrick Onyai. Please come forward, and this session is about surgical trauma. So let's invite the next, let's welcome the next panel. These are really gentlemen. I think you can see the way they are walking in, like, yeah. So Dr. Boa and Dr. Patrick.
All right, thank you very much, Dr. Tendo. I think we'll try to, in the interest of time, maintain the 8 minutes that we talked about. The first presenter is not around physically, but he had promised to have an online presentation. I wonder if he's on. We had a few issues this morning with our technology. I hope it was fixed. Or maybe as they fix it, we could go to the second presenter, and then we'll move back to the first presenter when we're ready. So it's my honor to invite Dr. Alphonse Digozon Omona, who will be speaking to us about a locally developed trauma assessment, treatment, and training with local resources to reduce preventive trauma mortality. The case of the Uganda Trauma Assessment and Treatment Algorithm to TATA. Welcome, Digozon.
Good evening, ladies and gentlemen. I'm Dr. Mona Alphonse. I'm a general surgeon, and I work at Masaka Regional Referral Hospital. I'm the head of the emergency department. If I could have the presentation come up. As we wait for the PowerPoint to come up, this is a locally developed trauma assessment and treatment, which we designed at Masaka Regional Referral Hospital, and we trained our staff on how to assess and treat these patients. As you are all aware, trauma, just like surgery, is a neglected part of healthcare. And if we don't come up and take the lead role in advocacy, the burden of surgery and trauma care will be much, much bigger than what we are seeing right now. Okay. Can we start from the beginning? Okay, yes, there are lots of studies that has already been done to show the burden of trauma, and a lot of this has been done by Dr. Olive. They are published, and you can always look at it. But key is that the mortality due to trauma is way more than malaria, TB, and HIV combined. And yet, we don't see any significant investment in trauma care, especially here in Uganda. The response to injuries has been very, very abysmal, and especially on scene care. Many of you have been working in the emergency department. You have always seen patients being brought by the police under the pickup truck. And this should tell you that whatever has happened on the scene, this patient has been lucky to have managed to reach the emergency department. And when you reach the emergency department, especially where I work, I have very few staff, and mostly they are nurses. And they don't have any formal training in how to attend to patient care, especially the structured ABCDE approach in trauma care. And there are big gaps, and these gaps are many, especially in manpower, in training, in communication, transportation, emergency department, name it, across the board. The gaps are so big. However, what we looked at is the training gap, and that's what we did. Now, when we look at this study, this was done in 1998, the outcome of major trauma at Mulago Hospital, assessment using the TRIS methodology. Importantly, you'll see that almost 60% of the deaths which occur are either due to airway obstruction, C-spine fracture, tension pneumothorax, massive pneumothorax, open pneumothorax, flail chest, cardiac tamponade, or hemorrhage. And yet, these are conditions that are easy to identify and they are easy to treat. And in this study, you will see that the main problem which they identified was that the clinicians do not adequately assess the patients, and they do not adequately resuscitate. Technical team, can you help me move the... Like in this, on day one, you see that 13 patients died of hemorrhagic shock, and yet adequate IV fluid and blood transfusion are enough to treat these patients. Of course, there are challenges to do with the logistics of administering this treatment, but however, misdiagnosis, as you can see, there are significant errors of misdiagnosis, accounting for over 52%, inadequate resuscitation, accounting for over 20%. Delayed surgery, inadequate surgery, these are interventions that come much, much later, and they only come when the patient has been fully resuscitated, all life-threatening conditions identified and treated. So the key issue is inadequate clinical evaluation. In the emergency room, we should not worry so much about investigations, especially when it comes to trauma. So clinical evaluation and interventions are very important. So that's why, together with the Ministry of Health, we came up to think about the Uganda trauma assessment and treatment. And we are looking at low cadre staff in our emergency departments, who are the nurses. In many cases, they are certificate holders or diploma holders. In very rare cases, would you find clinical officers? And especially in my department, I have only 4 medical officers that I work with. And our main goal is to reduce and maintain preventable trauma mortality below 10% by 2040. And the mission is 60-6-60. 60-6-60 is derived from the golden hour. The first 60 is 60 seconds of triage. You should be able to know that this trauma patient is category red and it needs immediate intervention, category yellow or category green. And by the end of 6 minutes, all life-threatening conditions have been identified and treatment initiated. And by the end of 60 minutes, that is 1 hour, the patient is ready for definite care. The definite care in this case can be maybe trauma laparotomy or other surgical intervention. So we wanted to train all pre-hospital and emergency department staff across the country on how to identify and treat these life-threatening conditions. And specifically, a rapid and accurate assessment of trauma victims, rapid and effective treatment of all life-threatening conditions by prioritizing the injuries and stabilization and rapid transfer. So the purpose is to empower health workers with knowledge and skills in trauma care, especially in our resource-limited settings, by prioritizing injuries, making most available materials, and implementing effective techniques. So we had this in 3 phases. The development has, first was the development of the algorithm, and this has been on the background of the EMS pilot project that was happening in Masaka region, and it was supported by the Korean Foundation of International Healthcare. And within that project, there was a capacity development aspect where health workers were taken for EMS fellowship in South Korea. So these are the team that we worked with to develop this. And also we procured an ultrasound scan machine for the training, and then later it was being used up to now in the emergency department. And then the second phase was in the training of the health workers at Masaka Regional Referral Hospital, all the staff of the emergency department, and a select staff from other departments who help us, especially in cases of mass casualties. And then the phase 3, it was for evaluation. We wanted to use serum-based deficit and LDH as a marker of adequate resuscitation, but as we are going to see, it was not feasible. And then we looked at also mortality at 2 weeks, and this data was collected and we used in a registry. And then later on, the findings would be used and see if the ministry can adapt across the country. So like I said, this was an initiative from the EMS department of the Ministry of Health with support from the Korean Foundation for International Healthcare and some experts from Yonsei University in South Korea. So there was training, PowerPoint presentation, simulation in the skills laboratory. At Masaka, we have the skills lab, which was also constructed under the bigger EMS project of the Ministry of Health. And then assessment included a pre-test and a post-test, plus also individual and group skills assessment. So this is a very big, much condensed version of the training. We looked at, because in our emergency department, at any one time, we have only 3 staff, 1 medical officer and 2 nurses. And basing on this human resource is what we designed this. We have the airway manager who handles the airway, but also takes charge of disability. And we have the sonar, is the person who is in charge of EFAST, and he does breathing and circulation. And then the third person is the circulator who handles the C in this. And then the E aspect is done by the group together after A, B, C, and D has been sorted. So that was the training. Point of care, EFAST ultrasound scan, airway. On your left is the classroom presentation and skill session on the right. So during the evaluation phase, we looked at trauma trend in our hospital for a period of 6 months, which started in July 2023 to March 2024. As you can see, there's a rise in the recognition and treatment of life-threatening injuries, as shown by the orange line. As you can see, the trauma mortality reduced from around 32% to 6% by the end of March. And this was a very good trend, and we shared these findings with the Ministry of Health, 2 committees that we shared with them, and at the senior management level, they were impressed, and they are considering taking it up as a training for the entire country. So the challenges we faced included limited resources, especially at the emergency department. However, because of the bigger EMS project that was ongoing, there was a lot of support in supplies and other equipment for the emergency department. So in our emergency department, we also have a portable X-ray, we have a point of care ultrasound scan, and others. Now, I spoke about the LDH and base deficit. This was not possible because the machine broke down and it was very expensive to buy the reagents, so we gave up on it. Training requirements, skills and simulation laboratories, which are mainly lacking across all the regional referral hospitals. And these are very important aspects that are needed so that such kind of trainings can be scaled down. Monitoring and evaluation. There's a lot of data that are generated in the emergency department, and without a structured monitoring and evaluations tool like a trauma registry or an emergency care registry, it would be difficult to monitor the effectiveness and also in modification and improvement of this kind of training. And sustainability is a key aspect, which needs advocacy, ongoing support, especially from government. So it is generally possible to have these courses designed locally, and especially the training done in the very setting where our workforce are. They are cheap. Initially, it was expensive, up to $30,000 US, but most of the money went into procurement. But subsequent trainings, which we have done, it cost way less than $100 per person. So the future, we have trained 80 intern doctors so far, and these are the people who are the first line in the emergency department. But also we look forward to having trauma surgeons to supervise these people, both in the pre-hospital and in the emergency department. Thank you.
So our next presenter is Dr. Eric Senunu. His topic is improving on-site, on-scene trauma care in Uganda, the role of nationwide lay first responder training program. So we are asking the IT team to play the presentation because he's not there physically with us. Thank you.
Yes. Hello, everyone. Am I audible? Hello.
Hello. You are audible. Go ahead.
Okay. Thank you. Thank you so much. Sorry. I was struggling with the network. I actually thought my presentation will be played and then be seen from that side. However, I can do that. I think I need just a second to put up my slide and then I can share with us all. Okay, are my slide visible now?
Not yet. Yeah, we have it.
Yes.
Okay. Thank you so much, everyone. I'm very delighted to be with you, though virtually. My name is Eric Senoni. I'm a Ugandan twin doctor as well as a master's student in global surgery at University of Global Health Equity. I'm basically presenting about improving on scene trauma care, an understanding of the role of a nationwide lay first responder training program.
Dr.
I
Senuni,
think earlier,
you have 5 minutes to present.
Previous speaker made the case of the trauma burden. However, I must mention that the 5 Thank you so much. Thank you so much. I'll try to keep it there. So I think it's more than 5 million because the number of deaths that occur outside the hospital and really go uncaptured. You've perhaps seen this newspaper in Uganda talking about borders becoming wheels of death, and still the burden of road traffic accident is among the leading causes of mortality and morbidity in Uganda. And if you're keen enough, you've seen this tweet from Dr. Kabanda mentioning how trauma is becoming actually an epidemic in the country and that it needs urgent intervention to be addressed. My question would be how many of us took this serious and how many really thought it's something that we can work on. We've seen work done by the ministry in terms of establishing a fully-fledged emergency care system with the objective of improving emergency on-scene care by 2025, which is this very year, by up to 50%, meaning every 1 in 2 individuals should be able to receive on-scene care as needed. However, when you look at the training across the country, you see that there is a huge area that is actually not covered by the lay first responder programs. And even in areas like Kampala, where these programs have been, they've been inconsistent. There has not been a well-structured, interval at which these programs were conducted, and therefore that has also inhibited the scale-up of the training to cover the entire country. We think it's not just about the burden of trauma and the unmet need for unseen care, but also being the fact that we are part of the agenda of having the Sustainable Development Goals achieved in the next 5 years, but as well as the vision for Uganda to become an upper middle income country by 2040. We can only achieve this if we invest in the lives of our people. We invest in the lives of the young people who actually die of trauma-related deaths. And we therefore need to act urgently and promote on-scene trauma care. Well, you again understand that these programs are actually feasible. They are cost-effective, sustainable, and they save life because they offer the most urgently needed, emergency care service on scene. And our opinion is we need not to work in silos. Let's collaborate. Let's create public awareness. Where need be, we might need to give incentives to people who actually have invested in this work. And looking at the long run, we must look into incorporating these programs, say, in the licensing processes for border taxi drivers, but also incorporate it.
Eric, are you still online? You have 1 minute.
Yes, I'm still online.
All right. Let's try to summarize. You have 1 minute
Thank you.
left.
I'm closing. I'm closing, and I'll close by again echoing what Dr. Kabanda said, that we need urgent remedy to address this burden. And the only remedy that is at hand for now is actually empowering lay first responders. Thank you.
So our next presenter is Dr. Alan Tumusime. His topic is open non-cardiac thoracostomy among adults in Mulago National Referral Hospital, a 5-year assessment of, so you are welcome.
Thank you so much. Good afternoon, everyone. So this is my postgraduate thesis. It's my very first paper to write. I hope it will be the first domino in a long chain of dominoes. I'm very proud of this baby, and I hope it will inspire me to do more research. My name is Alan Tumosime. I am a postgraduate student at Makerere, but I'm also currently at St. Mary's Hospital, Acho, in Gulu. That's where I earn my keep. So, well, the paper is not being presented, shown on the PowerPoint slide, but I can actually speak about it. It's a paper that studies open thoracotomy in Mulago. And in our problem statement, we realized that, okay, a lot of postgraduate papers talk about paucity of data. But when it comes to open thoracotomies, there is actually no paper in Uganda and in East Africa. In sub-Saharan Africa, you'll be hard-stretched to find more than 3 papers on open thoracotomy. So this paper is very useful. And also, prior to 2018, Mulago did not have regular open thoracotomies. Thoracotomies happened every once in a while. They were sporadic. But right now, as we speak, Mulago carries out thoracotomies probably bi-weekly, twice a week, minimum once a week. So since 2018 up to now, it has become a common procedure, but we do not have enough information about it. So we purposed to study it. It was a retrospective study, and we looked through the charts, and we got 149 patients. But of these 149, about 30 of them were less than 18, and about 40 something had very incomplete notes. And this is on us, the doctors. We are not writing enough, we are not capturing enough data, so those files could not be used. The other challenge we had while collecting this data is COVID-19. COVID-19 was a problem in 2020 and 2021. It disrupted surgical care in Mulago quite significantly. So we didn't have a lot of patients in that time. But nonetheless, we obtained a number of patients and we went ahead to study them. So our objectives were essentially to evaluate the indications for open thoracotomy at Mulago over a 5-year period. This was from 2019 to 2023. And in this evaluation, we hoped we could also come up with factors that also said with poor outcomes. So it was a retrospective review of patient records, and as I said, in hindsight, the records in Mulago are quite wanting. We studied data from 1st January 2019 to 31st December 2023. And as you can see, all our patients were adults. Most of the thoracotomies prior to 2018 were in children. So adult thoracotomies are relatively new on a routine basis. So if you look at
2 minutes to go.
2 minutes.
Yes.
All right, I will move on. But what I want to emphasize on this is the common indications. Empyema thoracis accounts for about 10% of all the patients we studied. And this goes to the trainers. A lot of times we leave surgical training without enough information on decortication and surgical management of empyema thoracis. Yes, it's very important. And most of these patients are unable to travel to Kampala for some of these surgeries. So I'll move very quickly to my discussion. So of course, as you can see, those are the leading causes: empyema, bullous lung disease, and esophageal cancer. But what we found in our multivariate analysis was we have a very long ICU stay of about 13.5 days. The longest and the median is 3 days. This is a lot longer than in the developed world where they have an ICU stay of 1 day. And we think this is because of open thoracotomy. Now, if you compare laparoscopy and laparotomy, the difference laparoscopy makes is huge. But when it comes to the chest, the difference between VATS and open surgery is a lot bigger. Because in open surgery, you're spreading ribs, you're cutting through muscles. So VATS would significantly improve the situation. But I would like to disagree. I don't think I have 8 minutes. I've been timing.
No, it's 5 actually. It's not 8. We reduced it to 5.
5, eh?
And
Oh,
you're
okay.
left with 1.
All right. So, thank you so much. I understand we are behind schedule. But I want to emphasize HIV and tuberculosis. These are diseases that have been looked at extensively in abdominal and colorectal surgery, but not in the chest. And they have very significant impact on outcomes. And we found that HIV and TB were the main predictors of a very long ICU stay, as well as mortality. Hypertension was associated with ARDS, associated with reintervention. And of course, COVID showed us that hypertension and ARDS are closely linked. And this paper continues to emphasize this. So I think as we go forward, let's keep in mind that HIV and TB are very significant players when it comes to outcomes in chest disease. Thank you so much.
You're welcome. Thank you so much, Doctor. Sorry about the rush, but we are trying to catch up with time. Maybe you can make up for that by answering the first question. I'll invite 2 questions, and preferably one for him to make up for the time he has lost. Do we have any questions? Yeah, we have a hand.
Thank you so much, Alan, for the presentation. I just want to find out, in your cases of thoracotomy, did you find any cases where the thoracotomy cases was as a result of trauma, like maybe an open thoracotomy at casualty? Thank you so much.
Yes, there were only 5 cases of trauma in the adults. That is if I'm discussing my paper. But in the entire data set, there are also 3 children with trauma. So 5 is quite a small number for a country where we have 37 trauma deaths per 100,000. But that's what we found. I think the chest tubes are doing enough.
I have a question here. Thank you so much. Dr. Mona, isn't the tutata more cumbersome than the traditional ATLS assessment in the ER nowadays? How do you convince us that the tutata is not more cumbersome than the traditional ATLS assessment for trauma patients in the ER nowadays? And then for Dr. Tumwine, we have done 2 cases of VATS in Zambia Hospital, but it's been more or less diagnostic, and people were enthusiastic to get to the chest, and patients were helped. So I don't know if in your looking up, you try to be ambitious and ask around why VATS is not being done. Thank you.
Yeah, thank you so much. Is tutata more cumbersome than ATLS? First of all, the ATLS must be available. And as we know it, I don't know how many in this room have been trained in ATLS. And if so, I myself was trained, but it was very expensive. I had to travel to Nairobi for training in ATLS and PHTLS. And these are very expensive, and I don't think the majority of the health workers, especially those who work at regional referral hospitals and district hospitals, if they can afford to be trained in ATLS or pre-hospital trauma life support. Truth is, it just doesn't exist. It's not there. So at least we have tutata, and we designed it for training, especially lower cadre health workforce, who are the majority of the people at district hospitals and health center force. Even during the training, we had to tone down our languages. We had to tone down what they can do. But then we actually realized that these are very, very simple interventions, simple assessment, look, listen, and feel. The nurses actually did way better than the medical officers because it was more or less of following a structured process. So once they are able to identify airway obstruction, a simple chin lift, jaw thrust is enough. Placement of a C-collar. And then the E-FAST, initially we thought it was difficult, but it was not actually difficult. And anybody of those health workforce are able to do it, and they're able to determine presence of, for example, tension pneumothorax or a massive pneumothorax, and intervention is rapidly done. And then because our workforce is really small, we had to design it and use the limited workforce that we have. Thank you. So I think it is not more cumbersome than ATLS. Thank you.
Simi?
Thank you. Someone asked about utility of VATS. I didn't see your face, but someone was standing in front of you. But I think we are lucky, very, very lucky. We are among the first postgraduate students to be trained in laparoscopic surgery, minimally invasive surgery. The surgeons above us had to put in a lot of personal effort and resources to obtain the same skill. So I think as time goes on, these things will slowly be incorporated into surgical practice in Uganda and become mainstream. But right now, the surgeons who are very comfortable with minimal access are quite few, and it's because they put in a lot of effort. So I think that's why we don't see VATS. But I'm very sure we are going to be seeing it in a few years. Yeah.
Thank you so much. Our presenters. Okay, we'll take the last one.
Thank you for sneaking me in, Dr. Podo Isoroti. I'm looking at the practicality of scaling up the thoracotomy procedures, especially at the regional referral hospitals. We all know that it's quite a challenge, especially skills, instruments, postoperative care and anesthesia to do those procedures. I'm seeing it as a very big tall order to achieve it in the near future. Thank you.
I think since Dr. Ayume is here, it's not just, okay, neurosurgery, much as we appreciate the addition of consumables, each of these super specialized fields of surgery have very, very high consumable demand. To make a list for the requirements of a patient that will need a WIPO, a pancreatic duodenectomy, I need to look for big paper. I can't write on the small hospital form 5. So they need those really large consumable lists. And this also goes to the thoracotomies. So I think as we plan to help neurosurgery, we can also think about the other subspecialized units. It is going to be very hard to do thoracotomies up country. I've tried to do one, but I struggled to get lung isolation, all these things. But I think with time, as we get more comfortable with it and as becomes a routine in our training, we shall also be able to do it up country. Thank you.
Yeah, thank you. Can I suggest that if we have any questions, we get in touch with the presenters after here, just in the interest of time. So I think now is a good time to stand up and take a picture. Thank you so much for the presentation.
Thank you so much. This was a session on surgical trauma, and we appreciate there's more trauma than malaria, I think, because as we sit right now, someone is dying or someone is having an accident. You know, physicians they are saying, let's end malaria by 2040, we end HIV. Can we end trauma as surgeons? That is something to think about. Trauma is really preventable, and I don't think patients should really get this complication. So right now I'm going to invite a representative from Ruby. I'm going to give you 5 minutes, and as he comes, someone asked me why don't they invite anesthesiologists to parties? And then someone said that they usually put people to sleep. So as you're seated right there, there's a bottle of water, and if you feel sleepy and you don't have water, kindly let us know. We'll get you some water, because the next panel is also very interesting. Keep tuned. 5 minutes, sir.
Good evening, ladies and gentlemen, my esteemed doctors and distinguished surgeons. I'm Vinod. I am the head of operations, and I'm representing Ruby Hospital. I would like to take you through a couple of slides. Before that, I would, I witnessed a couple of speakers in the last day and a half, and there were talks about Uganda doesn't have enough infrastructure, enough equipments to support surgeries, and that's the reason many, medical tourism and patients are not getting treated appropriately. To address some of the concerns, Ruby as a team, we work together with our chairman's dream to envision that we equip ourselves, both equipment-wise as well as infrastructure-wise, to ensure that we provide quality healthcare services. So I'll just take you through the slides. I hope this is not counted in the 5 minutes. Okay, till the time he puts on the slides, I will just talk about, so this is, so as far as the precision in surgery is concerned, we have we have got a commitment to surgical excellence. We are committed to provide world-class surgical care, and in that direction, we are trying to cover technology, equipment, infrastructure. So we have built in our surgical, we have got in our surgical microscope, and we are also got the Karl Stoll's endoscope, which is going to support the neuro, spine, and different specialties of surgeries. As I told you, this is the microscope that we have procured. It is a $1 million microscope, which is from Leica. It is a M530 OHX model, and it is mainly designed to enhance the precision in surgeries. Some of the key features of the microscope, it has got the fusion optics technology, the 400-watt xenon light. It's got a small angle illumination, and it can be worked at a 600 mm distance. Other features include it has got a magnification of around 40% higher magnification, so you can see it magnified, which is more important for cranial and spine surgeries. Other than that, it's got the speed spot laser focus. It's got the surgeon information panel and the electromagnetic brakes, where we can maneuver the microscope from one theater to another or within the theater. The visualization, effortless positioning, workflow efficiency, and the patient safety are some of the key features that the microscope provides. This is what I've already spoke about. Other than that, we have added on the 4K imaging Karl Stoll's endoscopy. It's again ultra clear 4K resolution for laparoscopic procedures. It helps in excellent tissue differentiation and color accuracy. It supports diagnosis and treatment in real time, and it's very lightweight, ergonomic, and image capture, and it has also got the recording system. These are the different for different specialties. As you guys know, that certain specialties require different types of endoscope along with it, like the angled endoscope, the neuroendoscope for the neurosurgeries, the flexible endoscope. We have already procured all of this, and this is also a part of the microscope and its endoscopes needed. For it can also be applied for ENT surgeries, like the rigid nasal endoscopes for sinus surgeries, the laryngoscopes for voice box and vocal cord procedures, and otoscope endoscope hybrid for middle and inner ear surgeries. This is also used for spinal surgeries. The spinal endoscope and the flexible endoscopes are also a part of the microscope accessories. For plastic and reconstructive surgery as well, we can use this mainly for minimally invasive facial rejuvenation procedures and for flap procedures like the deep inferior epigastric perforator. Now moving on to the other area where we have been a pioneer. I mean, as I told you, the microscope, we are one of the pioneers in getting the microscope in Uganda. We were also a pioneer for getting the 3 Tesla MRI in Uganda, which was 4 years back, was the only 3 Tesla machine in Uganda. Now, as far as neurophysiology is concerned, we have also come up with EEG, that is the EEG and the EMG facilities. We also have the intraoperative neuromonitoring system, which is specifically used for neurosurgical procedures during the surgeries. We have the EEG, as I told you, the electroencephalogram, which understands and measures the brain's electrical activity, non-invasive. It's very non-invasive, fast, and revealing. It's mainly used for diagnosing the epilepsy, seizures, sleep disorders, coma and brain death assessments, etc. The EMG, we are again pioneers here in getting the EMG. I think, as far as I am aware, there is no hospital in Uganda which has the EMG facility, which helps in muscle and nerve testing, which detects the nerve damage and muscle health. The main conditions that are identified using the EMG are the myasthenia gravis, spinal cord injuries, the ALS, and peripheral nerve damages. We are also capable of doing evoked potentials using the EEG. It's mainly used in neurology, ophthalmology, ENT, and psychiatry. Polysomnography, PSG, which is called as, it's mainly used for diagnosing sleep apnea, insomnia, restless leg syndrome, etc. We also conduct the nerve conduction studies, which are mainly used for peripheral neuropathies, carpal tunnel syndrome, and the nerve compression injuries. We also conduct the sympathetic skin response treatments, which are mainly used for diseases like diabetic neuropathy, Horner syndrome, anxiety disorders, and neurodegenerative diseases. This is, as far as the equipment is concerned, since I have very limited time, I ran through the slides, just taking you through the brief points. Other than the equipment, we have also coming up with an infrastructure development. We are coming up with a new OT, which is already in the process, in the verge of completion. We have built up a state-of-art operating room, which is mainly specialized for neuro and spinal surgeries. It's basically, it has the AHUs, the air handling units, and also the table, the operating table is going to be is of the latest technology, and also we are going to incorporate various other machines like the anesthesia machine, which is going to be the state of the art. So this is already on the verge of completion, and I am sure with these kind of support and this kind of equipment and infrastructure in our hospital, we will be able to serve more and more population of Uganda and ensure that the people of Uganda don't have to go outside the country to avail such treatment. Thank you so much for your time and your patience. Thanks.
Thank you, Ruby Hospital, and this comes in handy with the next session. There's a lot of advances and new technology in surgery. So, our next session is about advances in surgery, and I would like to welcome the chair, Dr. Gabriel Okumu. Please make your way. He's one of my lecturers, and so I'm so humbled to be inviting him. And he's a general surgeon as well as a laparoscopic surgeon at Nakasero Hospital. Let's give a hand of applause as we welcome Dr. Okumu Gabriel. Please make use of that bottle of water. It's very important.
Good evening, everyone. I think one of the hardest things is to present in 5 minutes, because as you know, the microphone gets sweet when you start talking. But I'd encourage everybody coming to try to keep time. But also one thing is that in Kampala it is said that if you don't leave before 5, leave after 8. So if you leave us here talking and then you go, we shall find you navigating jam somewhere in Kabaragara. So please don't leave us. We shall find you in jam, because the traffic is high now. It will get down later. We shall have our next session, advances in surgery. I don't know what an advance in surgery is and where the epitome is, but I've just read something on the net. Someone is saying that Bill Gates says that, you know what? Someone posted something that by 2030, AI will have taken over, and most of us doctors will have lost our jobs. So maybe the advance in surgery a time will come whereby AI diagnoses a patient, AI removes the appendix, AI closes the wounds. I don't know what we shall be doing. I don't know who will pay us. I don't know how we shall survive, but AI is good anyway. If it's going to do that and also give us some money and we survive, that's fine. I'll welcome the members. We're going to do our next session. We shall try to keep time. I know the microphone is sweet, but try to keep to 5 minutes. I'll welcome Dr. Brian Kasaga. He's an SHO. He's already presented before. He's going to tell us something about twists and turns, ileal knot in pregnancy, resulting in small bowel obstruction plus abortion. It's a case study. Welcome, Dr. Kasaga. Try to stick to 5 minutes. Or less.
Thank you. Yeah, so a good evening, everyone. I'm going to talk about an interesting case that we worked on as residents in general surgery. So we have a 30-year-old mother who presented. Unfortunately, she was a prime gravida, and she had an abortion due to unfortunate circumstances that I'm going to talk about. So this patient provided consent to sharing some of this information I'm going to give you. And so this was a case of small bowel obstruction in pregnancy, which is kind of rare, in the range of between 1 to 1,500 and 1 in 16,000 pregnancies, according to some literature review by Ukara et al. And ileal knotting is an exceptionally rare cause of small bowel obstruction with an extremely high mortality. Timely intervention is very important to prevent bad outcomes. So we have a mother who presented with abdominal pain for 6 days, abdominal distension, and inability to pass flatters. So when she got these symptoms, she went to a lower health facility, from there she was conservatively managed for intestinal obstruction. They did an abdominal ultrasound scan, which was largely normal. So they just prescribed some fluids, put an NG tube, and then according to them, the patient improved and actually passed stool. So the patient was discharged after 3 days and went back home. And in that same night, the patient had an abortion at 25 weeks. So this prompted them to seek care at Kawempe Regional Referral Hospital. Then from Kawempe, the patient was referred to Mulago. So when we saw the patient was the vitals, mainly the patient had a tachycardia, was a bit dehydrated, and an abdominal exam had hyperactive bowel sounds, about 8 per 30 seconds. The rectal exam, there was no stool in the rectum. And then what we did immediately, we resuscitated her with fluids, and then we did NG tube decompression, we gave her an analgesia, started antibiotics, because we preempted this is a case of IO. So we also monitored her vitals, and as we were waiting to get theater space, we did a quick erect abdominal x-ray that shows air fluid levels, as you can see. The labs are there, we are largely normal, and Yeah, so we contacted the consultant on ward, informed them about the case, and then also obtained informed consent, and then went in. What did we find? 1 liter of very foul ascites and a necrotic ileum, and a knot that was around 200 centimeters from the ileocecal valve. The proximal valve was dilated, and we had 2 adhesive bands and another outpouching from the bowel. As you can see in the image, the second image is what we found, the necrotic bowel, and the other, on the extreme left, you see an adhesive band and a loop of bowel extending towards the abdominal wall, and then you can see the knot in the third image. So what we did end block resection of the knot, and then we resected about 80 centimeters, then did a jejunal ilioanastomosis using Vicryl 2O in 2 layers, then left a lavage after draining. Sorry, we lavage and then put a drain. Patient had a stable postoperative course, only that she got a surgical site infection that we managed in the second week, and we had to switch antibiotics to piperacin and tazobactam. We did secondary closure on the second week. We discharged the patient, and she was generally okay when we saw her a week after discharge. So in our case, this was an interesting case because most of the times the symptoms of intestinal obstruction are not clear-cut in pregnancy. And of course, most of the times in pregnancy, rarely do you suspect intestinal obstruction, or when it's present, you may be hesitant to go in and do a laparotomy. Also, sometimes imaging limitations, there's some literature that there is no safe limit for exposure, especially for ionizing radiation. So it's even irrespective on the trimester. Some papers say that third trimester may be safe, but it is not entirely, there is no safe limit for exposure to ionizing radiation. So in our case, this case is rare because, of course, it was the second reported case of an ilionot in pregnancy. And of course, because pregnancy masks most of the symptoms of IO, and the successive outcome depends on timely recognition. And then what we did a pathology, and there were 2 adhesive bands, as you saw in the previous image. And when we did the pathology, they found it was normal bowel in the left image. So we came to the conclusion that there was a Meckel's diverticulum, 200 centimeters from the ileocecal junction, and then probably it could have been the axis of rotation. So the other causes of ilionot could be a capacious bowel, abdomen, or maybe patients who take a high fiber diet. And so the key takeaways is that to consider probably ilionot or any other causes of small bowel obstruction in pregnancy, or you have to think about these ones, and because early intervention is very crucial to prevent maternal fetal bad outcomes, as we saw in this mother who unfortunately lost the child, and she was a primigravida. So a call to action is to the surgeons and obstetricians to think about IO, especially when mothers present with some symptoms that are vague. Yeah, thank you so much. Those are my references, and thank you for listening to me.
Thank you, Dr. Kasaga. He has really set the record well. He's taken his 5 minutes. I don't know if the next presenter, Mr. Hafiz, is here? Is Dr. Kakuba Frank around? I've not seen him yet. Oh, okay. Get ready also. Dr. Michael Kalongo, ready? Let's see Dr. Kakuba first, then we shall proceed. I think one thing I learned from this case, it's always good for us to document cases. These rare cases happen, and sometimes you can find someone has seen it here before but never documented. So let's try to document these cases and maybe present them when the chance comes. Welcome, Dr. Frank.
Good evening. At time. My names are those, Frank Kakuba. I'm a pathologist at Mulago Hospital and Mengo. So I'm going to talk about common causes of dissatisfaction to surgeons here in Uganda. The reason I do this is to try and some sort of build a good relationship between you surgeons and us pathologists, because quite often we are blamed for doing bad work. Today I want to spoil your day. We share the blame somehow. Okay, well, not much How much I want to give some disclaimers. I'm not here to demote or to promote anyone. This is totally for goodness, and I've taken money from no one. So one of the reasons you get agitated is delayed results, histopathological results. I'm talking as an anatomical pathologist and clinical pathologist. The ideal turnaround time should be 3 days for H&E results. You should not accept 2 weeks results from today onwards. But there are some reasons that make them delay, and you are part of them. We share the reasons. Number one, size of the specimen. Some are so big to fix quickly. If you remove a whole organ, then you fix it in a small bottle, you just pour a few mils of formalin, don't expect results in 3 days. They will delay. So if you want to improve the time, use your surgical knife and cut through the tumor or the organ, just to do a close section. If there is no fluid to power. If there is fluid to power, be careful, because we need to describe it as pathologist. Otherwise, if you section it, it fixes very quickly. Number two, time of submission. Some of you take out tumors from theater, send them to the ward, patients go with them back home. Then when they come for review, you ask for results, they never submitted the tumor to the lab actually. They took it home. Then of course, others are slow processes in the lab. That is for us to blame. Then poor sampling, sometimes you give us, that tumor was submitted from a regional referral hospital, so many kilometers to Kampala. The doctor expected results. It is decayed because he sent it in very little formalin. Number two reason you give that agitates you, results are not matching your clinical suspicions. You are suspecting this, the pathologist gives you another thing, and the causes, we share them. Number one is the sampling technique. You sample from an area which does not have what you suspect. So it is unfortunate that the radiologists here have gone, but we feel so bad when we receive a tissue from those complicated procedures and we cannot see a diagnosis. So please, when you have the chance and you have entered that abdomen and you are seeing the tumor, pick from as many areas of the tumor as possible so that we don't tell you you sampled insufficiently. Then for lymph nodes, pick out the whole lymph node and give it to us. You save the day. Then the worst is the insufficient clinical information. When you give suspicious clinical information, it makes me concentrate, re-examine myself. If you describe a cancer patient in your notes, and my first microscope, I'm not seeing cancer, I'm going to check myself. So you must give as detailed as possible. Now here, I just want to give you an example. This one, 16-year-old male with periumbilical discharging tumor. That is the only notes I received. Now, under the microscope, I am seeing the skin with very good colorectal glands under the skin. Now, you know that for cancer, once you see ectopic tissue which is not supposed to be there, and you see it, you are suspecting cancer. But it's a 16-year-old, and these are glands in the skin. Is it a metastatic cancer in a 16-year-old? There was missing information. I wish the doctor described positive and negative findings, because by the time you have metastatic cancer to the skin, what they call the Sister Mary Joseph's nodule, there should be ascites. Tell me there is ascites, there is primary GI symptoms. There was nothing. So when I saw the glands, they look benign. Then I lacked information, and I was wondering how can normal glands of the colorectum go to the umbilicus. I had never seen it. But later on, I called the parent. The mother tells me that the father had the same problem. I wish the surgeon had taken that information and also told me that this condition, the father of this child had it. Later on, I concluded that it was a benign congenital ectopic colorectal mucosa to the umbilicus. I know you know, it was my first time to see. But your notes would have helped me a big deal. See this, the only information I get, adult female with lymphadenopathy, and the surgeon only gave me a lymph node. Only. Now when you see that is a lymph node, that is a tumor in the middle. Now this tumor looks like a glandular tumor, it is adenocarcinoma. But from what? From where? So how do you expect the pathologist to report this? So if you see lymphadenopathy, you try to also examine the other systems and say there was GI symptoms, there is a breast mass, there was nothing talked about. He only gave me a lymph node and I see adenocarcinoma. So here the diagnosis becomes very hard. And what I say here as a pathologist, I say metastatic adenocarcinoma from nowhere because you didn't tell me. Look at this, another problem, poor tissue processing in the laboratory. Even as the pathologist, once we are grossing, we make mistakes. But what helps us correct our mistakes is the suspicion you put in my head. One of you good surgeons here in this house gave me the mass, and he described it, 56-year-old man with anorectal mass, parectal bleeding for 2 years, pain and weight loss. That is a description of cancer. And he gives me a rectal mass. By examination, even you can see that that is a normal tissue. Then I'm asking myself, the clinical description does not match the first histology. I checked myself, and I recut. When I recut, image 1, still normal. I gave him the results. He is here. When I gave him the results, when I gave him the results, he said, please check again. And that is the essence of my talk today. Please, you talk to your pathologist. Ask him to check again before you get agitated and withdraw the block. When he told me to check again, I checked again and I got image B. Image B is an adenocarcinoma. If this surgeon had gotten agitated at that point and withdrew the block and took to lab B was going to start with that section and find cancer, and he would never come back to me. So the reason for all this, please have a call to your pathologist to review before you get agitated. Then sometimes we also don't know some things, and you must forgive us. There are some things we don't see regularly, and we miss them. Image A, an adult man, nearly 50 years, came with a diagnosis of hepatocellular carcinoma. That is liver tissue. You can forgive the pathologist who gave hepatocellular carcinoma because that tissue is largely necrotic from liver tissue. So now the pathologist will think, what else is causing all this? But when you check well, I don't know how to mark this, the round thing you are seeing is a parasite, and it is schistosomiasis. Now, some of those things, unless you have practiced tropical pathology, you may never know. So that is another reason why you can have differing results. Image B, an appendix removed, thinking it is a common appendectomy, and that round thing you will see is enterobius vermicularis. Pathologists may not many may have seen that. So that is another cause of differing results. Now you complain that we give you non-detailed, less informative report. That is a complaint I get every day. We share the blame. Number one, once you are sampling, you don't give us lymph nodes. And sometimes when you give them, you don't label them. From which level have you got them? 2 minutes, I will be done. Then you also don't orient your tumors. You should orient them and say it has a relationship up, down. Tell us the relationship. If you don't orient it, how do you want me to tell you how far the cancer has gone? Then ask also the pathologist. Once we are sampling, we sample poorly. We don't sample from the margins. We don't pick lymph nodes. We don't take the organs like semivesicles. That is our mistake. Then, of course, some of us lack the adequate technical knowledge in oncopathology reporting. Thankfully, the trend is going to change. Makerere University has improved the curriculum greatly. Another complaint, you tell us, I have got results from lab A, they don't look like results from lab B. And it is the same patient. The reason is one, once you remove the tumor and send it to me, I give you a diagnosis, you don't agree with it, you take back the patient to theater, resample. When you resample, you have gotten actually different tissue and send to lab B. Lab B may give you a diagnosis different from mine because we examine the different tissues. Some of you get the tumor, divide it, give a part to Kakuba, give another part to another one. How sure are you? How sure are you we have examined the similar tissue? We may have examined different tissue. So what you can do is use your eye macroscopically, see where the tumor could have spread, and you make sure you have divided the real tumor if you want to test pathologists. The best way to test pathologists, for your reason, the best way to test pathologists is to use the made slides. You say, give me back my slides. Then you give your pathologist similar slides to examine, and you'll be sure they are looking at the same things. Okay. Look at this, the very last slide. This one was a referral from a colleague, a surgeon, who was not happy with the diagnosis. He didn't give age of the patient, and the patient had an ovarian tumor. If you look at this, even you surgeons, that is a papillary tumor. Don't you see it is forming papilla? The pathologist innocently got it as a papillary adenocarcinoma of the ovary, because which other tumor comes from the ovary and forms the papillary adenocarcinoma? Now, when the surgeon received the result, he did not agree. He's like, a papillary adenocarcinoma in a 9-year-old? For him, he knew the age. He had forgotten to give the age to the pathologist. Then he referred the block to me for review. When I looked at it, I called him and said, wait a minute. How old is this patient? He's like, the patient is a 9-year-old. The only game changer that day was the age of the patient, because I was wondering how a 9-year-old can have a papillary adenocarcinoma of the ovary. The age of the patient made me rethink of which other tumor that can form papilla, and that tumor was a yolk sac tumor. How I wish the gyne surgeon thought about it earlier, because he had the differentials, and even gave me the tumor markers. Say there is an ovarian tumor in a 9-year-old, alpha fetoprotein is this far, whatever. Just describe all you can so that the diagnosis becomes quick and short. I thank you very much. There is a lot to say, friends. We can only say it if we develop a very strong and lengthy relationship between surgeon and pathologist. Thank you very much.
Thank you, Dr. Frank. And thank you for having the boldness to come and also meet all these surgeons too, because I think you have like 1,000 questions. Do you think so? You know, for us, we think that you people are bright. We think when you see something, you know, this is right breast, this is left breast. This is right thumb, this is left thumb. That's what for us we think. That's why you don't give a history. You think that you can say this is a right thumbnail. That's what you always assume. Anyway, Dr. Kalongo, are you ready? Please come in. Hope your slides are already there so you can save time. We shall have the questions at the end. They prepare your questions. Shall try to have at least brief questions.
Respected Professor, respected Surgeon, dear colleague, good evening. I have a pleasure today to share with you the initial experience in the Bogota, in the use of Bogota in peritonitis. So I'm Dr. Michel Kalongo. I'm a resident in general surgery at Makerere University. And this work is still ongoing, and there will be a supervisor with Professor Ngalukande and Dr. Reginald Morel. So the acute peritonitis is one of complex pathologies incorporated by surgeon in his practice, because he has a high morbidity and mortality. The survival of patients with secondary acute peritonitis mainly depends on the control of the SARS contamination of the peritonite cavity. So, in temporary closure of peritoneal cavity, in case of secondary peritonitis, is considered in case of we have impossibility of obtaining a complete cleaning of a peritoneal cavity, or if the patient is unstable or is in shock. So there are many studies who done about temporary closure, but at initial, they use the Bogota laparostomy. Why we use the Bogota laparostomy because it's cheaper, is easy to perform it, and is accessible. So, what is the Bogota technique? Normally, this technique was used for first time by Oslad Borges, is a surgeon in Bogota, in Colombia, and it was in 1984. But it was introduced in our region by Dr. Reginald Morel. So this technique, it consists to use the sterile plastic bag. So normally, that we have in our region we use the urina bag, and you cut surround the bag, and you add the small hole to promote the elimination of the secretion, and then you slide the plastic bag under the abdominal wall. So normally, the plastic bag is placed after a good control of the source of contamination and the systematic cleaning of the peritoneal cavity. You use more water, like 4 to 5 liters of warm normal saline. And you do a good cleaner for subphrenic lodge, Douglas, and between the intestinal lobe. So that is the sample for one patient who referred for our hospital. He undergone 4 laparostomy, and the first one was due to appendicitis. And the second image is after doing Bogota technique. So the objective of this study is to determine the Bogota laparotomy in the management of aquatic peritonitis, and there is a pilot study of INISHI, but it may be extended on another facility subsequently. So the INISHI is local, in French is the unité chirurgicale, means surgical unity, and it is located in eastern of DRC, just in 70 kilometers western of Pondwe in Kasese. It's functional since August 2023, and we have a capacity of 100 beds, and we use 42 beds for surgery. We have a free operating room with a 4 operating table. Oh. So that is our initiative, Dr. Morel. So I have 1 minute. So about the results, we present here as a draft because the study is still ongoing, and the eligibility for Bogota laparostomy patients of any age, and the one who they have generalized peritonitis up to 24 hours, and they are stable patients with key SOFA superiorly to 2 or equal to 2. So 20% was treated with Bogota laparostomy technique. The sex errors was female, 1.5. The mean age was 25.8 years, and 65% were from Rio region, 90% were reference cases. The complaint admission was the digestive content exit through the surgical wound. 90% of the cases were received after having benefit from 1 or more laparostomy in another city. Most of cases were received between 24 and 72 hours. The mean key SOFA score on admission was a 2.2, and most of this patient was unstable. The intestinal perforation and exploratory laparostomy were the most frequent indication for this operation. And the preparative resuscitation, we use the crystalloid mean of 2.1 liters. 80% cases were transferred. So in Perup, we find the past was the most following with intestinal perforation and anastomosis leak. So the plan we use in open after surgery in surgery was intestinal resection, stoma, and put Bogota. So the outcome, 6 of our patients died, and the surgical site infection was 55 cases. So in contemporary surgery, the use of delay closure of the peritoneal cavity is okay. In conclusion, we have presented this draft result of the initial experience in the use of Bogota in peritonitis, and the study is ongoing, and we intend to extend it to other health facilities. We believe that the Bogota technique would be the better suited to the management of peritonitis. So the goal also with this presentation is to see we have many about inequality of the care, because we have many surgeons who is still only in the capital in a big big town, and in upper country they need also the surgeon. So we request it is possible also for the surgery to go in the upper country like Kansas and other region to see. I know it's possible because we have the errors who try to go far in the upper country to help the people. So the main question is to know, will also think about organizing a CAP in the eastern of Democratic of Congo, because it's also something to promote the Eastern African and the African Union. So that is our reference, and thank you.
Thank you very much, Dr. Kalongo. Next, we'll have Dr. Olivia Chitoka presenting something on consent decision, informed consent. Welcome, Dr. Chitoka.
You're probably wondering what I'm doing with consent, and yet we're here talking surgery. But a lot of us here have challenges actually communicating with our patients. And many of the problems we're having nowadays with litigation are coming up as a result of this gap that we sometimes tend to leave to other people, and yet it's really us. So this is not my presentation, but I know we are both Olivia. As we wait for it to be loaded, I looked at the quality of consent and looked at it from the experiences of patients and next of kin, patients who had undergone emergency surgery and how they went through the consent process in 2 hospitals. This was Mulago and Zambia Hospital. And at the time, this was part of my PhD work, and we were looking at how we go about doing consent in such a scenario. And it was interesting that for this work, I found myself becoming an advocate for the patients and the next of kin. Advocacy is what we're talking about today, but I found that as we described the experiences of the patients and their next of kin, we got to know an insight of the other side, what happens when you tell a patient that you need surgery, and yet this patient at that time is in a very dire condition. Imagine a lot of things that are going on at that time. The patient is afraid of dying. The next of kin are also anxious. And here you are telling them that they're going to have surgery, and you know all the connotations of surgery. For the average person, the moment you talk about surgery, you think that is just death. So it was interesting to note what we found when we looked at the experiences of the patients and the next of kin. So to start with, we mainly looked at, we conducted a qualitative study, and we conducted interviews. We interviewed 22 patients and 17 next of kin of those patients in both Zambia and Mulago hospitals. We used these institutions because we thought that this was probably going to be, these are places where you have training being done, and we knew that a lot of what is practiced in these two institutions, both one being private and one public, would probably give us a better idea of what happens within our urban setting in an emergency situation. So when we interviewed these patients, most of them were male, as expected, and the next of kin who were involved in the decision making at the time of informed consent, we looked, there were mostly spouses, the parents of the patients, even those who are older. We also looked at those who are, some were brothers or siblings, and then a few, in one or two cases, actually the so-called next of kin was actually a workmate or a colleague. And when we interviewed them, there were several things that came up. And some of the things were, we looked at different themes that came up from what information we got from them. I'm sorry, what is being projected isn't the presentation that I sent. But, and we found that most of these patients found that there were challenges in how the consent was being documented, how it was, in some cases whereby it wasn't even documented at all. Strangely, you have patients whom you take to theater without their consent. Secondly, the patients preferred that the doctors are the ones who actually provide the consent. And this was interesting to note because in most places, actually the nurses are the ones who are seeking consent. And yet, when you talk about informed consent, we're not talking about just signing here and signing there. We're talking about giving information about the procedure that's going to be done, the risks of that procedure, and the benefits. And imagine your nurse who is expected to explain the complications and the risks and benefits of you doing a bar hole in a patient who has hematoma. So these are some of the things that were coming out. As far as the next of kin were concerned, most of them really had challenges. They had a lot of anxiety in trying to make the decisions for the patients, mainly because they had that, the responsibility of taking on that difficult decision to make. And a lot of times it turned out that much as there was a next of kin who was there, whom we expected to have the capacity to consent for patients who are unable to consent for themselves because of the condition they were in, you found that the next of kin, in most cases, tried to look for somebody else to also give some guidance on how to make the decision. So you'd find that a patient is unconscious, and the next of kin who is present is the mother of the patient. And the mother says, no, let me first call my husband, the father of the child, because he's the one who knows what should happen. A few cases, there were even people consulting the employers because they were thinking that if you're going to have surgery, who's going to pay for it? Those are some of the things that were coming out. So at the end of it all, from the experiences that we got from the patients and next of kin, one of the things that we came up with, or we found was that we need to appreciate that during that consent process, especially in an emergency setting, we have to think about the use of shared decision-making. Just appreciate that when the decision is being made for the patient, it is not, don't expect it in the Western world, in other countries. Most times there's a lot of power between the next of kin. Even the patients themselves are very enlightened and have a lot of autonomy and tend to be able to make decisions for themselves without any issues. But in our setting, we find that in those kinds of in an emergency situation, you find so many other people are brought into the picture. And the point is that we need to be patient and allow for that discussion. And when we talk about that discussion with other people, then we also talk about discussing what we're going to do with the patients. Many of the patients, unfortunately, didn't even know what was done for their the surgeries. They were just told that you're going to have a surgery and this is it. And yet, they were not given an opportunity to discuss and have an iterative process between the patient and the doctor about what was going to be done and how it was going to be done and what were the outcomes. And this is one of the things that we felt that came out from this study. The other thing that we found was that, as I earlier intimated, the patients and the next of kin want to hear from us. We should stop hiding behind the nurses. The truth is, in an emergency setting especially, the moment the surgeon sees that the patient needs surgery, they'll just go and quickly start preparing for theater and just tell the patient, you need an operation, and then walk away. And then the nurse comes with the informed consent, and what happens? Sign here, sign there, sign here, and that's it. So at the end of the day, for us to be able to give quality care and be able to communicate well with our patients and be able to get better outcomes and prevent issues of litigation and dissatisfaction, we need to be present. We need to be the ones to give the consent. And for that matter, it came out when you look at the consent forms of many of the two institutions that I looked at, you find that there's so much lacking. You find that the consent form for the patients sign a kind of blanket consent for whatever is going to be done. I've consented to everything. And yet there's so much more that needs to be discussed and captured in the consent forms to show that the patient actually has been informed and is decided and made an informed decision. I'm sorry I've not been able to have my presentation put up, but I will stop here. I think probably taken my 5 minutes. Thank you.
Thank you very much, Dr. Olivia. Last, shall have Dr. Alice. Recently, we were going to do a case and asked an old man that, please sign here. The man said, you mean someone of my age can move from all the way in Namugongo and come to hospital without knowing what to do? That I've already consented by coming here. But anyway, you have to make sure they sign. Otherwise, when things go south, they come for you. 5 minutes, huh?
Thank you. All right. Good evening. Thank you so much for giving us this platform to present. Thank you to ASAO and all the stakeholders. I want to give a special thanks to Dr. Ayume for advocating for neurosurgery. The reason why is because I'm a neurosurgery resident in my final year. My name is Alice Katerega, and I'll be presenting about surgical errors and residents' experiences with surgical errors. I'd say thank you to my co-authors, Professor Galukande and Professor Sam Novoga. So, surgical errors, they are deemed or thought to be inevitable. If you're a surgeon, at one point in time, you're going to experience a surgical error. And if you know what Murphy's Law is, it states that anything that can go wrong will go wrong. So would you want to think of Murphy's Law as a friend or a foe? It can be a friend in that it helps you to prepare for potential surgical errors. And just as I talk about the statistics and the global context, I'd like us to compare different aspects. So surgery can learn a lot from the aviation safety industry. In aviation, their fatality rate is about 1 death per 14 million boardings. So 14 million people who board flights annually, only about 1 will pass on. When you compare that to road traffic accidents, we lose about 1 million people globally every year to road traffic accidents. So when we look to surgical errors, we know these are unintentional preventable injuries that occur in the perioperative period that can be prevented by adequate safety protocols and procedures. About 300 million surgeries are performed globally, of which 15 million are within lower and middle income countries. In Uganda, that number is about 35,000. So it's a significant to us. So our methodology, we did a cross-sectional descriptive study amongst the newest cohort of surgical residents at Makerere University College of Health Sciences, and that was the intake for last year, 2024. And we generated the list from the department, and then we sent out hard copy and soft copy questionnaires for the residents to fill out. These were anonymously filled. They gave their consent, and the study variables that we looked up included the types of surgical areas that they had experienced, disclosure status, and barriers to disclosure. So we had 30 residents responded to our questionnaire, to our study. The ratio of male to female residents remains 5:1. That was the same as last year's cohort. I'm hoping that that will improve over time and we drop that ratio to something more amenable. The age range was the mid-30s or early 30s, and that's reflected with what's found across the globe. And the disciplines that participated, surgery had the greatest percentage at 43%, but there were other disciplines like neurosurgery, orthopedic surgery, eye involved, ophthalmology as well, and ENT. And so that was useful for us. Specialty status, only 2 out of the 30 had done a previous surgical degree. And what were the responses? We found that the mean time that they had before coming back to school dropped from 5.6 years to 4 years, so we're coming back to school earlier and earlier. And we found that 70% of the residents had ever committed or experienced a surgical error. And out of those, at least a third had experienced a surgical error within the past 1 year. A smaller percentage, so just over a quarter, had disclosed that surgical error to their peers, while less than 20% had disclosed that error to the patient involved. Examples of the errors cited, so wrong site surgery came up most with about 60%. Then we had wrong incisions for the surgery, and then retained objects. And then we looked at what the residents experienced after the error and found that about a third took responsibility for the error, and when they disclosed to the patient, they validated what the patient felt. So the patients may feel angry, shocked, sad about this happening to them, and it's important for us to empathize with them. Only 6.6% led to deaths. We hope to drop that number. However, the residents who are hesitant to disclose future prevention measures. So although about 80% knew that there are procedures in place to prevent errors in the future, less than half of those residents took the initiative with those systems to discuss prevention in the future. The reasons for non-disclosure, this was the prior cohort, so 2024, it was mostly fear and litigation. So just know about a third were worried about litigation, and understandably, and then the other third were worried about fear, and then there were other smaller percentages. And then 2025's cohort were more concerned about fear of retribution, fear of being attacked or assaulted by the patient's family or the patient, And I know, given in the context of last year's happenings, we can understand what they were worried about. And then following that, there was also the fear of litigation. And then what were the cohort's experiences with disclosure? Many of them had already faced litigation. Some of them had faced loss of trust from their peers or from the patient. Some had been expelled from their jobs. Some had experienced blackmail or aggressive behavior from the patient and their next of kin. When you compare that to non-disclosure, a few had mentioned guilt, and this is in contrast to the 2024 cohort, where many of that cohort experienced PTSD, lack of sleep, and other effects, psychological aspects of failure to disclose. So to facilitate disclosure, they encouraged us to have systems in place to protect them, safety for the healthcare worker against aggression and attacks, indemnity cover, and education on the impact of errors. And this is my conclusion. This is a cathedral in Southern America, in Colombia. It's very beautiful, but it's also functional and efficient. How do we put in place things that are structurally appropriate, functional, and yet elegant? Ensure that we push for prevention by educating the residents and healthcare workers, communicate with the patients and with healthcare workers, and put systems in place and checkpoints to reduce errors. But also, like Dr. Olivia said, advocate for the patient and for the surgeon. Thank you very much.
Thank you very much, Dr. Alice. So shall welcome, I think, 2 or 3 questions only to the panel. I don't know, somebody at the microphone, just to make it brief so we get brief answers. That's a tough research, issues of the heart. It's like passing a paper around and saying how many have ever cheated, isn't it? It's not easy. But anyway, thank you for that. The microphone. Yes, Dr. Mona? There's one coming from this side. Yes, Honorable. Let's listen from Honorable. Microphone.
Yeah, thank you so much, the presenters, for the presentations. I have a question for the pathologist. One issue I wanted to ask about is the lack of standardized reporting, whereby we have several reporting systems from all the labs across the country. How can you try to harmonize that? A case in hand is especially with Hirschsprung's disease, one of the diseases that's non-oncologic, but we usually rely so much on the pathologist's eye. And I don't know if it's because most of the pathologists are used to reviewing oncologic specimen, but when it comes to non-oncologic specimen analysis, the reports are always they're not standard, and they're usually vague reporting. So someone will tell you maybe hypoganglionic tissue, and you can't really make sense of that. So is there a way you can try to standardize the reporting as a measure, or as a grievance we have towards you guys? Thank you.
Shall I take all the questions and answer at once? Yes? Honorable.
Yeah, thank you very much. I'll draw my attention to Dr. Alice and Dr. Olivia. I think very good reports and submissions, and these are really areas that we seem to ignore, and we are quick to go in for the clinical output. My humble request is that as we train and mentor the next generation of health workers, we need to focus on these areas. I foresee a scenario where lawyers will start doing ward rounds behind you guys, and because they have run out of options. Thank you.
Thank you, Honorable, for the comment. Dr. Mona had a hand. What are you going to do? I wanted to limit. Okay,
thank you very much. Surgical errors.
Yes.
I was wondering if the people interviewed were using surgical safety checklist? Yeah. And then what was the role of the team around them?
Maybe we take one, then one.
Thank you so much to Dr. Frank. Mine is intercommunication between, this time around is not between the surgeons and then the pathologists, but between the pathologists and then the treatment centers. Case in point, you find a patient, biopsy taken, histology results out, refer the patient to the treatment center, but after 2-3 days, the patient is calling you that they are looking for, they want their meat or their block. And you keep on having a discussion with the doctor where you took the samples for analysis, but still it takes long time, even to the extent that the patient travels from Kampala to Mbale to pick their tissue, which was sent to Kampala. Because actually somebody talked about standardization. Then to Dr. Chituka, still we have traditional beliefs. I don't know how you are navigating around that. Case in point, we had the worst scenario where we had to wait for the clan leader to come and sign consent for the patient. And these were people who were all able, but they were waiting for the clan leader. This is a gentleman, a 60-year-old, who had sigmoid volvulus, spent 4 days in their clinics, wherever they were, came to us, but when we diagnosed it, we summoned the operation, but still they said we had to wait for the clan leader. We took about 3 days again waiting for the clan leader to come. On Monday, when the clan leader came, of course, we were too late. Actually, we lost that gentleman in the process of resuscitating him up to theater that very Monday. Thank you so much.
Okay, let's take one question from here, and then we shall answer.
Hi, good evening. This is with regards to the surgical errors. I was going to ask you the same question. How effectively is the surgical safety checklist practiced? Because I think that's one of the major concerns in majority of the operating rooms, because I think it's just, even if it is filled, I think it's just for the sake of filling it, whether it is actually practiced the way it has to be practiced, like reading out the patient's name, the anesthesia name, the site of surgery, and there are various parameters to ensure that we operate the right patient and the right site. Secondly, I think I was surprised to see the numbers. 60% were errors, and many of them were even feared. They were very scared to disclose it. So, do you think giving a punishment for disclosure of doing a wrong thing, is it right, or do you think we should consider it as a part of training and then eventually evaluate as to how the progress is?
I think we shall stop there and take answers, brief answers. Dr. Kakuba, 2 questions for you.
Thank you very much. To start with the doctor outside, you talked about standardization of reports. There are 2 issues here. There is format, reporting format, then there is diagnosis. So I thought you were referring to a reporting format. But I know I later understood when you talked about Hatch-Splang. A reporting format in Uganda, we don't have a standardized reporting format. You as a clinician, as a surgeon, all you need is a surgeon, is a diagnosis and the well-described findings. Some people put the diagnosis first, like I do, then describe. Others describe and put the diagnosis. It means the same thing. But your fear about Hatch-Splang, you don't see the real diagnosis. Now, it comes to you, the surgeon. That is poor diagnosis. It means less technical knowledge of a pathologist. Like I said, a pathologist may not know everything. It is upon you at that time, if you receive a report which is insufficient, which is not communicating, call the pathologist and even advise what you want. You say, please report on the proximal, report on the how deep it goes. That way you are teaching the pathologist. He may not know actually that he's supposed to report that, but don't get angry to withdraw the block or the tissue, but communicate back and tell him or her what you want exactly. Now about the doctor here who talked about lost tissue because of communication, I would blame you. If I was a patient, doctor from Mbale, listen to me. If I was a patient and you are the primary surgeon, I come to look for my tissue, I don't see it, you are to blame. Why would you send a tissue to the lab whose contact you don't have? So now, as a matter of competition, you must only refer your tissues to labs where you have communication line. Thank you.
Thank you, Dr. Kakuba.
Yes, thank you for that question about cultural aspects. One of the things that the study brought out was some of the challenges that we were facing. And that was one of them, that some, even just beliefs of the patients. The truth is some patients actually, many of them will tell, the cultural leader is called because they think it's a witchcraft thing. And they think that that person should come and sort out the problem culturally and may not actually even need surgery. So they'll keep waiting for that kind of thing. And we had those patients. We also had those patients who had religious beliefs. Because in the process of getting informed consent, you're talking about surgery, and you're saying that there's a possibility that we have to give you blood, and they say, but I don't want any blood whatsoever. And in fact, there's a couple of cases which were not necessarily from this study, but we'd had from other places where patients declined because they felt that they could not stand the idea of having surgery, being transfused, and some unfortunately succumbed. But these are some of the issues that were coming up. And in the context of the next of kin, one of the things that this study brought out is that our next of kin, the person who is defined as the next of kin, is very loose. The next of kin might not necessarily be even related to the person. You're finding that the person, next of kin, is almost more or less the person who makes the decisions. And depending on the community, some communities it's a cultural leader. Sometimes it is the person who is paying the bills. So that is how the decisions in finally getting consent were. Those are some of the nuances that we appreciate when we interviewed the patients and the next of kin. Thank you.
Lastly, Dr. Alice, surgical checklist question.
Thank you so much for the questions. First off, I'll start with the disclaimer that these results were from first-year cohorts, so we're taking their experience before they enroll or just after they've enrolled in their residency program at Makerere. So usually that's experience from where they've worked previously, a wide range of hospitals, private, not-for-profit, etc. But I think that the questions raised are extremely pertinent, especially the use of the surgical safety checklists. I do not have the answer now, but we have actually started a study on utilization of surgical safety checklists within Mulago National Referral Theaters. And what I can say anecdotally is that it may vary from unit to unit, but some units do stand out as being exceptional. I'll mention orthopedic spine theater, and they do always utilize WHO surgery safety checklists. Now, when we look at the context, the surgeon is not operating alone, they're in a team. So they have a team of the surgical tech, they have the operating room nurse, they have the charge nurse, they have their assistants. So I think it's really important to look at the role of those auxiliary teams, and it's an area of research we can look into. Then addressing the question about punitive measures or punishments, I would be hesitant to speak on that matter. I'm not a content expert, but I believe that we should foster a culture of being open and auditing these processes or these happenings and move away from finger pointing. So it should be more of an audit and where we can improve the individual performance, improve the systems in place to reduce the occurrence of surgical errors. Thank you very much.
Thank you, everyone. Maybe let's ask one last brief question for Dr. Frank as we stand up to take our picture. Is there any point in taking 6 samples of biopsy? Because some days tell us that when you're doing prostate, you take 6 from here, 6 from here. But I have a feeling people report on only 1 sample, so the other 8, I don't know what happens to them. So should we bother with the 6, so we take 1 and just send to you?
Thank you, doctor. The choice depends on you, the surgeon. How do you see your tumor? Do you think what you have picked is satisfactory, or you also doubt? If you doubt your sample yourself, pick many so that it is upon me, the pathologist, to see them all. But if you really think you have picked from a viable tissue, maybe 1 is enough. So there's no standard of how many you pick. The decision depends on you
the surgeon.
Thank you. We'll stand for a picture. Thank you very much for listening to us. Thank you, panelists.
Let's give them another round of applause. It has been a very interactive and informative session. Thank you so much. We are coming to the end of the session, of the day actually. I don't even want to look at that time, but according to our program, it's 16:20 hours. And we are having a working tea right now. Kindly move slowly to the serving points, and our ushers are moving around to guide you. So as you have a cup of coffee, let's just welcome our final session, and that is chaired by Dr. Chiwewa and co-chaired with Sister Dr. Margaret Ajiko. And this session is about harmonizing multidisciplinary teamwork in surgical care. Let's welcome them. Thank you.
Good evening. We shall have what we describe as a working tea. So as we have our tea, we shall pay attention to the presentations. And without wasting any time, because we are looking at harnessing, harmonizing multidisciplinary teamwork in surgical practice, the pathologist has just been here, is our first presenter, Ms. Shona Arrow here. Kindly come forward and present your paper on the scope of pediatric surgical services at UCI. You're most welcome. You have 5 minutes.
Hello, good evening to you all. All protocol observed. My talk is about the scope of pediatric surgical services at the Uganda Cancer Institute. I just had a survey with Dr. Benjamin and pediatric oncologist Fadil at the Institute, and we came up with some very interesting findings. My name has been said. I'm a pharmacist, pediatric oncopharmacist at the Uganda Cancer Institute with expertise in cancer and nanomedicine. So a bit of background, I'm going to be a little fast because of the 5 minutes. We do provide specialized services at the Institute, and some of the services have been listed there, especially for children that require operative interventions. We do diagnosis, surgical management, follow-ups. So common malignancies are kidney tumors, neuroblastoma, soft tissue sarcomas, retinoblastomas, leukemias, germ cell tumors. And obviously management is holistic and involves a multidisciplinary team. We also have individualized treatment plans for the children. So the aim was to just find out what a month follow-up looks like for a child who has undergone cervical intervention at the Institute. So it was for pediatric patients following a histologically confirmed malignancy. So the methods used were just a retrospective review of surgical records between July and December. Data was collected based on those parameters as it has been listed, and it was compiled, and Microsoft Excel was used for analysis. So interesting findings were found. 88 patients were scheduled. Majority were done on Wilms tumor and retinoblastomas. Ages were ranging from 3 to 12. And 16 underwent definitive curative surgical procedures. And with those 16, 13 were successful with very good follow-ups and clinical outcomes. However, we lost 3 due to sepsis. And then we can see that 6 were lost to follow-up, and 72 cases that involved diagnosis only involved biopsies with no subsequent surgical interventions required. So a conclusion from there was that surgical interventions generally result in positive outcome. When they come early, we do have very good surgeons, and patients experience very good outcomes. However, we have problems with follow-ups in the system. We don't have very good follow-up at the moment, maybe because the team is small for pediatrics, or if they're adequate, maybe it's something that is work in progress. And then for the 72 cases, a few hiccups were there. We were looking at late presentation, and surgical intervention was unfavorable. So obviously they would get maybe palliative chemotherapy. And also with the children coming to the institute, sometimes we do get referral cases that come in late, they're referred late. So I'm not sure if in the community we do have surgeons that are taking part in these referrals. Maybe before a child is sent to the institute, a surgeon, a senior pediatric surgeon has actually been contacted. And also we have certain issues that have been rising about children coming in and they've had something excised. And once it comes, it turns malignant. Excision, unwarranted excisions are still taking place, which would also affect referral process and time, because someone may do an excision and think, okay, this is it, and the child later succumbs to a malignancy. So of course we know that surgery is first-line care for cancer, and we would really encourage that there's timely referral and there's timely and better management out there before they come to the institute. So the recommendations came up with was enhanced referral pathways. I think a whole team in the secondary care should also involve other doctors, have them also mentored or have them also involved in these kind of practices so they know when to excise, when not to excise, what to look out for, what does something that needs to be sent to institute look like. So that we get children timely, have them have their tumors or whatever solid excised in time for them to have better clinical outcomes and survivals. So that has the second point highlighted, that there's improved guidance and a multidisciplinary team expansion. Now on this team, I would like to agree with the pathologist. There are some dissatisfactory things coming in from surgeons. We have, I'm not sure how it is in the surgical world, but I think orthopedics, is it very far from you, or I don't know how it's connected, but we've had a challenge with that department where most of the bone tumors are benefiting from palliative surgeries. And getting hold of these surgeons is not very easy. And that gives the pharmacist a lot of work because I'm having to deal with a lot of sepsis. I'm having to think, I'm having to kill myself just to make sure the child survives. And then a surgeon will tell you, oh, they need the blood levels to this point. Then you bring the blood level to that point. Then the next thing, they'll be like, oh, I'm busy here. Then they say, oh, did you give albumin? Did you do this? Did you do this? And we're doing that and having to wait for you for 1-2 months. So it's something that we think that should be enhanced. And then also in intervention of surgical pharmacists. It's a nice profession, and I would urge that surgeons would be open to having specialty pharmacists as part of multidisciplinary teams. Thank you very much.
Good afternoon. Ladies and gentlemen, protocol observed. First, I begin by bringing you greetings from the city of Soroti. And this topic is very important for all of us if we want good outcomes and happiness to our patients. So you remember that alone you can go fast, but together we shall go far. So our next presenter is Dr. Arthur Nick, and he's going to take us through retrograde intussusception as a rare complication of giant Michel's diverticulum in a 6-year-old male. This is a case report. You're welcome, doctor.
Thank you. Good evening. I've already been introduced, and I and two other people form the pioneer residents at Cavalry University, the program of M.Med General Surgery. So I'm sure a number of us here are very familiar with intussusception. However, this is a unique case in that we had a 6-year-old child who presented to our emergency department. Atypically, he did not have the typical presentation of red currant jelly stools. He just had abdominal pain and distension with failure to pass stool. So when we performed an ultrasound scan, we saw the target sign as indicated by that arrow. And we made the decision to take him for emergency exploratory laparotomy. And intraoperatively, this is what we got. It was a giant Merkel's diverticulum. It was more than 5 centimeters. And also, the intussusception was retrograde in nature. That is, the distal portion was telescoping into the proximal portion. And it was ilio-ilio. Ilio-ilio makes up about 15% of the intussusception cases. Commonly, it is iliocecal. So we performed a resection. Because of the significant edema, we couldn't manually reduce it. And then afterwards, we performed end-to-end ilio-ilio anastomosis. So this is the picture after resection. We resected about 40 centimeters of the terminal ileum. So the portion on the left is the retrograde intussusception. And then the portion with the dilated vessels is the giant Merkel's diverticulum. This is the first reported case in East Africa and Africa. The only other case that we came across was from Colombia. And for it involved also a retrograde into a giant diverticulum. Then the only other case we came across was just involving a giant Merkel's diverticulum, which was complicated with a volvulus. So we discharged our patient 3 days post-op, and 1 month following the surgery, he didn't have any postoperative complications. Histopathology confirmed our diagnosis of a diverticulum. So this case goes to show you the variability in presentation of what could be a common entity, but having an uncommon presentation. So clinically, you need to have a heightened sense of suspicion, and early recognition can prevent misdiagnosis or poor outcome. And these are the key takeaways. These are the authors that were involved in this case report. And I'm happy to announce that it was published last week in the International Journal of Surgery Case Reports. Thank you very much.
Thank you so much, Dr. Nick, for keeping time. We have a huge contingent of pediatric surgeons here. I'm sure they'll have some very wonderful questions for you. Now, before we go back to Dr. Kasaga and Dr. Ali, I would like to welcome presentations from Team Plastics. They've been led by country rep, COSEXA country rep, the wonderful Dr. Rose Aleño. So I'll invite Dr. Ezati and Dr. Rose Aleño to give their presentation on their use and experience in biodegradable temporizing matrix in a low-resource band settings, bands unit in Uganda. It's a case report. Dr. Ezati, you're most welcome.
Good evening, everyone. First slide. No, it doesn't. Thank you. I'll be presenting a case report about our experience as Chirudu National Referral Hospital, the BANS unit, as we used a skin substitute, biodegradable temporizing matrix. I'd like to acknowledge the team that worked on this paper, that is the Burns and Plastics unit, Dr. Natalie and Dr. Rose. So oftentimes we are faced with patients who have extensive burn wounds with limited donor sites, and these patients are physiologically unstable. These patients, in order to manage them and prevent them from going through the systemic response associated with burn injuries, the best treatment is to cover the lost skin with autograft. So temporary skin substitutes are usually used to cover these wounds when they are too large. And one of these skin substitutes that we use is known as biodegradable temporizing matrix. That was a kind donation from Research International. So this case report will discuss the two patients that we operated on and placed BTM on. And we had two patients. We had a 30-year-old female and a 9-year-old female. This skin substitute is made up of a biodegradable polyurethane cell foam that acts as a scaffold for infiltration of cellular material and then therefore forming a neodermis. It also has a non-biodegradable top layer. This non-biodegradable top layer is a silicone layer that acts as a cover of the wound and hence prevents loss of fluids. And it also has fenestrations that prevent accumulation of fluids within the wound. So we had two patients. We had a 30-year-old female that presented with 40% full thickness burns, and also a 9-year-old female that presented with 50% full thickness burns. That for the 30-year-old female, consent was got to put these pictures up. She sustained burns to her lower back, her buttocks, her lower limbs, and her forearm. The image that you see on the left, we did tangential excision, and after tangential excision, we placed the BTM. Seen on the left, it looks like a foam. This BTM was placed after 2 series of excision and later stapled. Following the placement of the BTM, 3 weeks later, there was granulation tissue, as you can see. The picture on the left-hand side shows the child who sustained 40% burns to her trunk, her back, and her upper limbs. So she had granulation tissue formed. That's the yellow appearing substance, that's the non-biodegradable silicone layer. So after 3 weeks, you delaminate, you remove that silicone layer, and then later place a skin graft. So this was after removing the silicone layer, we placed the skin graft, and we had good take. So this, in conclusion, the patients did well, formed good granulation tissue, and serografting was done. And this is the first documented case report of using BTM in our low resource setting, demonstrating a very positive outcome despite placement that was delayed. Thank you.
Thank you so much, Dr. Esati and your team. As you can all know that a team to everyone, you achieve more. See the wonders the plastics are doing. Our next presenter is Dr. Peter Majeme, also in that line of plastic. He's going to present to us case series analysis of oncoplastic surgery in the management of advanced breast cancer in a plastic surgery unit in Uganda. So pay attention. Thank you. Welcome.
Ladies and gentlemen, all protocol observed, good evening. Peter Majeme, I'm a plastic surgeon representing the team at Chirudu National Referral Hospital, Burns and Plastic Unit. Today I'm going to interest you in a case series of advanced breast cancer patients that we are managing in collaboration with Uganda Cancer Institute. And these are our members that we're working with. So breast cancer remains the most frequent malignancy in women worldwide. And in Uganda, it stands as the second common tumor. Most of the patients present in advanced stage, that is stage 3, stage 4. And this accounts for 77% according to Gawaya et al. And most of these patients in advanced stage normally are referred to Uganda Cancer Institute, where they normally receive neoadjuvant chemotherapy, and then some go for surgeries, some don't. Oncoplastic breast surgery integrates the principles of oncologic surgery with the plastic surgery techniques. So the aim is to achieve oncologic control, achieve a good aesthetic outcome, prioritize breast conservation, and also improve the quality of life, especially of these advanced disease breast patients. So the objective of the case series was to assess the feasibility of this study, assess the feasibility of the collaboration between the Cancer Institute and plastic surgery. That was the first main objective. And then the second objective is to look at the clinical characteristics of patients with advanced breast cancer who underwent oncoplastic surgery. And then also we looked at the outcome of oncoplastic surgery in the management of advanced breast cancer. So we enrolled, recruited 27 patients over 2 years following tumor board discussions. 9 were in stage 3 and 18 were in stage 4. 25 of these were female, and only 2 or 7.4% were male. The mean age was 43.6. The most presenting complaint was a unilateral breast lump or mass. And the histologic findings, the most common was invasive ductal carcinoma, 70%. 15% were phylloids, 10% were mucinous adenocarcinoma, and 5% were lobular adenocarcinoma. Majority of these were triple negative, and these underwent oncoplastic surgery. Now, oncoplastic surgery, we are looking at oncologic surgeons, we are looking at the plastic surgeons intervening, achieving oncology control like we had mentioned. So we did 48% that underwent radical mastectomy with a latissimus dorsi flap, and 4 of these had chest wall reconstructions. The rest, 40%, had modified radical mastectomy and latissimus dorsi flap, and 3 patients had modified radical mastectomy and rectus abdominis massoflap. The complications were mainly we had wound dehiscency, 14.8%, partial flap necrosis, and recurrency in 7.4%. This is an example of one of the patients that we had. This was a 32-year-old female who had had neoadjuvant chemotherapy, had invasive ductal carcinoma. We did nipple-sparing mastectomy and a latissimus dorsi on the left breast. The second is a patient who had a phylloid tumor. We did a radical mastectomy with chest wall reconstruction. Latissimus dorsi flap was done, and that was the after result. So in conclusion, a collaboration is important between the oncologists and the plastic surgeons, especially in patients with advanced breast cancer. And once there is this collaboration, we saw a reduction in morbidity and mortality in these patients. And more studies are to be done to improve, to check the quality of life of these patients. Special thanks goes to Dr. Rose, who is been continuously advocating for breast cancer and breast surgery, and also for her mentorship. Thank you very much.
Thank you, Dr. Peter, for that presentation. And thank you, Team Plastics, for this wonderful work. Now we invite Dr. Kasaga Brian to come over again and present on the role of multidisciplinary team discussions management of thoracomphalangus, the conjoined twins. This was a case report again. You're welcome again, Dr. Kasaga.
Yeah. Thank you very much. I'll be very brief. Good evening again. Allow me to share a case that we worked on with the PED surgical team and other residents. Grateful to the team that worked on these twins that we had. We received consent from the family before sharing this information. So maybe just a brief background in history that we've all have heard of a term called congenital Siamese twins. It came from some famous conjoined twins that were born in Siam, the current day Thailand, that were quite common in most of the circus shows. So they used to go around different continents and perform on the circus. So that's where the term Siamese twins came from. But of course, as you can see, they were joined from the abdomen and specifically on autopsy. So they fathered around 21 children, but after death, they were joined at the liver. So in our case, these conjoined twins are quite rare. And in the Ugandan context, there is very scarce literature, but there is some work that was done in the 70s. They found someone was looking at, in a hospital in eastern Uganda, they found that there were around 16 sets that were reported. And recently, we had good news that we had successful separation of conjoined twins at Mulago, and then also in eastern Uganda by Dr. Equitable team. So, and of course, the key issue is that usually the separation carries a high risk of mortality. So we have a refugee mother of 27-year-old who was referred to Mulago. This mother had attended antenatal, but of course she had not done ultrasounds, and citing the lack of electricity at the health facility. So she hadn't done any ultrasound scan. So the team was surprised at birth.
So the baby was during labor, so there was a footling presentation, and of course the doctor had to do an emergency C-section. So to his surprise, he found these babies were joined together and they're conjoined twin, and he had to secure an ambulance and transport these babies. From Chirandongo, there is a camp called Bweali, to Mulago. So they came over a journey of over 4 hours on oxygen, transported with a nurse. So when they arrived at Mulago, so on examination, as you can see, they were joined from the thorax and abdomen. They were clinically stable, but on oxygen. And on the gene examination, what was remarkable from head to toe exam was that they had a single umbilical cord, but the other aspects were normal. And for the respiratory system, they had some bit of distress, and of course, as I say, they were on oxygen. And the admission vitals were as shown there. They had a tachycardia, and of course, they had also tachypnea. So in the early period, in the early postnatal period, and so we had to admit these babies and stabilize them by the ped surgical team. And of course, including daily assessments, taking their weights. We had to keep them on IV fluids, nutrition. We had to start them on EBM slowly and increasing by 2 meals every day, starting on antibiotics and monitoring them. So, and with the history that we had separated some conjoined twins, we are very hopeful on how we are going to work on these ones. So over the next few days, we did a couple of investigations, and one of them was a babygram. As you can see, we wanted to see, are there any maybe fusion in the sternum or maybe some ribs? As you can see there, it wasn't clear, so which prompted us to do other investigations, including a CT angio and echo. So the CT angio that we did, the echo that we did showed that for twin A, had a patent foramen ovale and a PDA plus a VSD, but had no more the forward chambers. But for twin B, had a single atrioventricular valve with hypoplastic AV valve annulus. So the heart chamber of twin B was just a single atrium and single ventricle. So it was a bit generally malformed. But for twin A, they had all the 4 chambers. So, and there was a connection. So when we did a CT to kind of analyze this better, we found that there was a communication. First of all, the twin A, the right side of the heart was located on the left. And the aorta usually is on the left, but the aorta in this case was on the right. So, and most of the liver was actually on the left. So we confirmed that twin A had dextrocardia because most of the organs had been flipped to the other side. So, and they had a connection between the right ventricle of twin A and twin B. So after going, these are some of the images. I won't go through much, but where the arrow is the communication between the 2 ventricles. Other important finding was that the biliary systems were connected, so the 2 livers were connected. And as we went again on the ward caring for these babies, the only marked thing they got was a fever, where we also did CBCs and blood cultures when we had to change antibiotics. And then also they lost some weight, but later in the course of the next week, we had to set up a team of different individuals to try and discuss of how we are going to manage these babies. So, and of course, the pediatric surgical team was big. It has us, the residents, the nurses, the surgeons, the interns. And of course, for us, we are interested in anatomical separation of these twins. How are we going to do this one? So, but of course, we had to do that with other teams. We consulted the cardiologists because, as I showed you, the heart chambers were connected. So what was the ejection fraction of both the kids? How were we going to, if we separate them, what would be the ejection fraction, especially of twin A? The radiologists were very crucial in interpretation and giving us advice on these images. And of course, for surgical planning, we consulted for the anesthesiologists to tell us about the perioperative risk and tell us what will happen after surgery. Will these children actually make it? What will be required? The nutritionists advised us on, especially because the babies were losing weight, so they were responsible for advising us on optimizing the caloric intake. This was a refugee from Bweali camp, so, and some items at the hospital, especially some drugs, they had to buy them, and we had to contact some social workers in the hospital and to contact the office of the Prime Minister, probably to start on helping on sundries and other things. And of course, most importantly, we had to involve the family. So that was the entire team, and of course, what we are all interested in is trying to separate these twins and make sure that our babies are survive. And in our discussion, the main questions that I forgot one key player, I think it was the pharmacist, who someone talked about the surgical pharmacist. And of course, because these twins had a shared circulation, one of the things we are worried about is how, if the dosing of, for example, cefotaxime is 50 milligrams per kg, and these babies have a shared circulation. So we had to consult the pharmacist and advise us, do you give a double dose, or do you somehow divide this dose into two, or do you give these babies separately via the two cannulas? So the pharmacist advised us on that, and what we did is we calculated the total weight and gave them via twin A, and because they had a shared circulation, we assumed that the drug was circulating between the two twins. We are very interested in separation of these twins, so of course, but of course, as we've seen, twin A had a dextrocardia, but of course, twin B had a very hypoplastic heart. So was survival possible in our setting? And what team? We had also a team from Uganda Heart Institute that came in to tell us about the specifics of separation, especially of the heart. And unfortunately, during the just a few days after the multidisciplinary team discussion, the babies didn't make it, and we suspect the cause of the death was because of heart failure, because at some point, twin A was doing most of the work of both babies, because the heart of twin B was severely malformed. Maybe one thing that came out that I forgot to say is that in the discussion was, if we are to operate these, how do you go about the ethical scenario of telling a parent that, are you going to spare, for example, twin A for twin B? So how are you going to explain that to the parent clearly, that you're going to sacrifice one and save the other child and so on? So that was kind of an ethical dilemma that we faced. But of course, we had to communicate the findings of the team, but unfortunately, we couldn't reach to the point of separation of these twins. Yeah, so in conclusion, so these cases are common, but of course, it's a good news that in Mulago, we separated a few cases. But of course, imaging saves. Probably if we detected these babies with an ultrasound scan where they are doing antenatal, probably the team would have prepared well. And of course, multidisciplinary teams are very important in such complex cases. And of course, being a refugee, it gave us a few hoops to jump, and such that we can provide some of the items to this family. So I'd love to acknowledge the team, especially Dr. Sekabira, who employed us to work on this case report, and the fellows, especially Dr. Yasin, and the other PED surgical team, a team at UHI, the anesthesiologists, and the nursing team who took care of this baby. Thank you for listening to me.
Probably we are tired, but let's give him another round of clap. That was a very complicated case. Thank you so much, Dr. Brian and team. Again, you can see the importance of multidisciplinary teamwork in planning. Imagine it was only one doctor planning. You would be so stressed that even you'll forget the route to your home. But when you work as a team, this stress is reduced. So our final, but most important presentation is going to be given by Mr. Hafiz Said. That is comparison of outcomes and of compressed dressing for 2 days versus 7 days after varicose surgery. Doctor, welcome. Is he around? Is he around? Is Mr. Said around? Hafiz? It's not available. He's out of circulation. So let's give a big clap to our presenters of this evening. You can add in.
Yeah, now we shall quickly invite questions. Dr. Saga, come and take a seat up here so that people can ask you. We have some twin separators in the room from before. They may want to know why you did not separate those twins after 30 days. The Honorable Speaker is also here. We had challenges of electricity in Bweyale that sent the doctors to do a Caesar without an ultrasound scan. Maybe we could want to re-invite him back here, but no. Anyway, let's invite questions from the House. Any questions by show of hands? And the microphone will move around. Everybody seems tired. Okay, seeming like there are no questions right now, let's give another round. There's a question in the House. Okay.
My question goes to Dr. Zati's presentation. Thank you so much with the work of research in providing some of these materials to help us in the wound closures. My question is about that BTM. What does it do exactly? Does it reduce the size of the wound, or it will improve in the how the wound will heal and maybe becomes clean, and then later you do the skin grafting? So it didn't come out well. Maybe I don't know whether other research have been done somewhere to tell us about how it works very well, because I saw it really, it's very interesting, especially to use it in the low income or low resource settings. I think it is a very good thing. And then the other thing was what would be the cost implications of this BTM in case I am to consider using it in Moroto or whatever. Thank you so much.
I want to know the cost implication of that donation, she said. Yeah. Any other question? We take all of them at a go and answer. I think that is the only question. Dr. Zati, please.
So BTM, the biodegradable temporizing matrix, it acts as a scaffold. So it actively encourages the wound, if I would say, to granulate, to temporize. It encourages infiltration of the cellular tissue, the myofibroblasts. It doesn't cause wound contraction. It just encourages, should I say, formation of granulation tissue. The cost implication, it was a donation from research. Price differs, but 10 by 10 is about $50 US. I don't know if Dr. Rose can supplement.
Yes, Dr. Rose can get the mic.
When a patient that is burnt that extensive is losing a lot of water, there's high risk of infection, so survival is maybe like 30%. So for the condition to improve, you have to remove all the dead skin. And if you removed them or call it debridement, then the patient gets worse. So what BTM does is that it protects, so the patient is like skin is there, is well protected from infection, from loss of fluids, from pain, can actually eat and survive eventually. So that's one of its major functions, to add on what she said. Thank you.
Thank you very much. Any other question? Maybe for Dr. Peter Majeme. For the patient with the latissimus dorsi, the flap, better to staple the edges or to suture? What would you choose? You chose the suture. Why not the staple? And when do you choose the suture versus the staples?
Thank you for that question. We are plastic surgeons. I think it's an aesthetic issue. So mainly we are looking at aesthetics. If you use staples, they normally tend to leave poor scars compared to the sutures. Yes.
Thank you. Any other burning additions from the House? Final round of applause for our presenters. And time for us to embrace a photo moment. Maybe Dr. Rose will join them. She seems to have been a part of this for Team Plastics. We take a photo moment and we invite the Mistress of Ceremonies to take over. Thank you. Photo session right now.
Thank you, Dr. Chiwewa, Sister Dr. Ajikor, and all the panelists. And I would like to thank all of you in the room for your patience and staying up to this time. I think according to the program, it's 18 hours according to our program. So we would like to say thank you for staying up to this time and listening in. And thank you to all the panelists, the guest speakers. Another round of applause. Yeah, so we've come to the end of this day, and tomorrow is our last day for the scientific conference. We shall also have the memorial lecture, the Chalwazi memorial lecture in the morning, as well as the AGM and the gala. So our program will still start at 8 a.m. Kindly let us keep time, because if we come late, then the program is pushed to this time, which is 18 hours at 19 hours. So I encourage us to come early so that we can be able to start early. And as you go back, may God protect you, and we see you once again tomorrow. If you've not registered, kindly register. And then tomorrow there will also be a session of giving awards. So you're all encouraged to please show up. Thank you so much. Have a safe journey.